ALS, ACLS, and all those stuff, but actually a course which is a policy-based course, which is a system-based course, and which you need to pass the MBBS exam. That has been incorporated in this current NMC bill, and all have been instructed to start the course as soon as possible, whether it is on the ground or with mannequins, it has to be started. So that's the good news. Government also thinking about it. Central government is thinking about it. So hopefully, we'll get the junior medical staff in near future that will be trained in critical care respiratory illness in future. So that's a very positive point. And with this positive note, I want to congratulate all of you to do a extremely good work during the COVID era. And hopefully we have come out of it. And the second, third wave is not coming to India. That's the news, but we all keep our finger crossed. Let's see how things turns out. Thank you.
Nursing Director Loki Sister and Senior Sister Paulami. Please, Loki.
Namaste and good afternoon to all of you. I think there is no ending of learning. This type of platforms who are hosting that respiratory and critical care medicine is mostly important things. And in our hospital, whatever we have seen during COVID situation, till now also our critical care doctors and respiratory medicine doctors, they are awesome because personally I have suffered with COVID. I know how I have survived. What a tremendous effort they put that we cannot say like this, but still it is a learning platform, not only for the doctors, because any clinical outcomes, it depends on the doctors and services. So nursing care as well as doctors, both of us collaboratively, if we are putting our effort, I think we may successful. Dr. Asif and other teams are all senior, Dr. Ashok Senguta, Dr. Mukherjee, Dr. Devraj, Joy, Rana sir, everybody is there. We know the hospital. We understand that COVID has given a lot of bad things, a lot of disaster happened. But other we can say there is a lot of opportunity of learning. Junior doctors, nurses who are not aware how to take care of the critical care or respiratory medicine, they have learned a lot and they saved a lot of patients' life. I must welcome and congratulate the team who are hosting this type of seminars. Apollo always the brand and Apollo Clinics Hospital always known for different types of the seminar. Still, we did not stop the virtually also we are doing. I must thank our senior management, all the respiratory doctors, critical care medicine doctors who are putting continuously effort to build the competency of the doctors and nurses and everybody. Thanks to everybody.
Yeah, namaste and very good evening to all dignitaries present over here. So what every senior dignitaries mentioned, because in this hospital we always believe in knowledge and skill development through different types of platforms. So thank you so much for organizing these activities. And what Madam said, I also suffered from a bad COVID, and all the doctors and along with the sisters, so they have helped me out from there. And now I'm just standing in front of all of you because of our that all the efficient doctors and their good management. I think we should give a round of applause to all our critical care doctors and along with the nursing staff. So thank you so much. Definitely means I think from the nursing side also, as Madam told, and all the nursing side, definitely we will be registering because this is a free registration. So definitely we will pass these things, and that always the knowledge and skill. I think till the last date we should enrich our knowledge and skills. Thank you so much.
We are almost nearing the end of this session. I will ask Dr. Asif Iqbal to come here and give the vote of thanks.
Good afternoon. Thank you to CEO sir and the Joy sir and DMS sir just left because he's a very busy person. and the nursing director ma'am, and my senior colleagues and the junior colleagues. We are very happy that we have overcome the challenges of COVID, and now we are back in track, because Apollo Clinical Hospital is very renowned for the research and culture and the knowledge spreading to the among the community, among the nation. And we are very happy that we are organizing updates in respiratory and critical care medicine. We will have around 60 to 65 faculties, and there is a 55 session, and all over the across the globe we are getting the response is very good. Our faculties from UK, our faculties from California, UAE, Dhaka, they also participate, and there is all national very dignitaries faculties, they also participate this event. And everybody is happy that we are organizing such a session, because in all over the world, we have seen that there is only one faculty. The critical care is conference means the only critical care faculty. But first time we are doing the respiratory pulmonology and the critical care both together, and there is a very interesting topic in this. I hope everybody will be enjoy, and they will learn. And I will specially thank the Cipla Critical Care team. They are doing the live streaming, and the Perch Auxiliary Academy. This is a medical event company. They organize the seminar and all. They are doing the faculty management and the technical support. So, and I thank my department and my hospital, and close this session. Thank you.
Good evening, ladies and gentlemen. Uh, After quite some time, beating all the blues of the pandemic, we are here for the quest of learning and updating ourselves in the realm of medical science. We all know that pandemic has tried everything on us globally, nationally, but still it cannot dominate. It cannot dominate our spirit. So we are here for the session, which will be tomorrow and the day after. It's a combination of pulmonary medicine and critical care medicine, which are like twins. And there will be 55 sessions altogether in these 2 days. And so far, we are overwhelmed with a registration number of more than 600 now, and it is still coming. I would request everybody in this room, please spread the news as much as you can. It's a free registration, nothing needs to pay, and it will provide us with enlightenment of our spirits and updating ourselves. It's meant for postgraduate trainees and all categories of doctors who have an appetite for learning and upgradation. I will now invite our dignitaries, CEO of this hospital, Mr. Rana Das Gupta, DMS, Dr. Shamashik Bandyopadhyay, and Dr. Joy Basu, our General Manager, Administration, for the inauguration, and Nursing Director is also here, Dr. Sister, to inaugurate the session. And all the other consultants, my colleagues and friends, please join us in this auspicious moment. Thank you.
all the other doctors, luckily. It's a real pleasure to have this session, updates on respiratory and critical care. I think learning is always a continuous process, and there's never an end to learning. And I would say that respiratory and critical care, as Sarah said, it goes together hand in hand, and I think it's one of the most important centers of excellence that we have now in the hospital, especially with the onset of COVID and even before that. And now, though, it is even more important. There's so many patients coming in with respiratory disease, and I think we talk about cancer, we talk about cardiac disease, but respiratory disease is no less. And I think it's a form of a chronic disease. If I can say that people who are suffering from, especially elderly people, during winter or change of season, it is every time there's there's a change of season or during winter, you have the elderly coming in with different types of chronic respiratory disease, and I think it's a very, very important department that we have in our hospital, and I think across the globe, if you look at respiratory care and critical care, very, very important. And science is continuously changing, so it is very important that we update ourselves, and such sessions are going to help and take us a long way. And along with the doctors, it's so heartening to see that we have our group of nurses and brothers, sisters and brothers here. So I think together we will make a very strong team. We actually have a very strong team in Apollo, a mixture of a blend of senior and middle level and junior people, and I think we have one of the best teams that in Eastern region, and such updates and continuous process of learning is just going to make it even stronger. Thank you very much.
Thank you.
Dear Mr. Dr. Shyama, you want to answer, please.
Thank you, Ashanta. Thank you all. Just one or two words in this context. Respiratory failure is so important because out of all the organs, if you look at that single organ failure for lung, that's the most difficult one to treat. So in this COVID time and post-COVID time, we have seen excellence from our intensive care and respiratory care physicians, and also the growth and development of our second line doctors, whom we used to call when we were there as junior doctor, but they have superseded in every aspect in last 3, 4, 6 months. They have done individual ward rounds, looked after patients, and I think the benefit of COVID, whatever we had, is this growth and tremendous, contribution of our registrars, associate consultants, junior consultants. They have been truly motivated by their seniors, and that's the reflection of how they have worked in COVID time. The same principle for the nursing also. The junior nurses who have actually excelled this COVID time. So that has been what we have got in this very difficult pandemic time. So all the best to you guys for a fantastic learning session, and I look forward for my enrollment in this. Thank you.
Our GM administration, Dr. Joy Basu, please. Joy.
This COVID time. So that has been what we have got in this very difficult pandemic time. So all the best to you guys for a fantastic learning session, and I look forward for my enrollment in this. Thank you.
our GM administration, Dr. Joy Basu, please. Joy.
Yes, good afternoon. It's an exciting program related to critical care and respiratory medicine. Uh, Apollo is hosting it, and with the international, national, international faculty and the entire critical care team, which is a very sound and solid team what we have in our hospital, uh, along with the nursing team, paramedics team, everyone is involved in that. So it would be an excellent journey in coming 2 days, an excellent learning experience for all of us. Uh, I'll tell you one or two small facts that recently NMC, National Medical Commission, which has replaced MCI, Medical Council of India, they have incorporated critical care into a specific subject in MBBS curriculum. And along with that, they have incorporated emergency medicine as a separate subject in MBBS curriculum. So these two were missing, and fresh MBBS doctor was not exposed to very critical patients, and sometimes they take a small bit of courses of BLS, ACLS, and all those stuff, but actually a course which is a policy based course, which is a system based course, and which you need to pass the MBBS exam, that is being incorporated in this current NMC bill, and all the medical colleges being empowered. The second, third wave is not coming to India. That's the news, but I will all keep offering across. Let's see how things turns out. Thank you.
Nursing Director Loki Sister and Senior Sister Paulami, please. Loki.
Namaste and good afternoon to all of you. I think there is no ending of learning. This type of platforms, the who are hosting that respiratory and critical care medicine is mostly important things. And in our hospital, whatever we have seen during COVID situation, till now also our critical care doctors and respiratory medicine doctors, they are awesome. Because personally, I have suffered with COVID. I know how I have survived. What a tremendous effort they put, that we cannot say like this, but still it is a learning platform, not only for the doctors, because any clinical out on the, so nursing care as well as doctors, both of us collaboratively, if we are putting our effort, I think we made successful. Dr. Asif and other teams are all senior, Dr. Ashok Shendu, Dr. Mukherjee, Dr. Devraj, Joy, Rana sir, everybody is there. We know the hospital. We understand that COVID has given a lot of bad things, a lot of disaster happened. But other we can say there is a lot of opportunity of learning. Junior doctors, nurses who are not aware how to take care of the critical care or respiratory medicine, they have learned a lot and they saved a lot of patients' life. I must welcome and congratulate the team who are hosting this type of seminars. Apollo always the brand, and Apollo Clinics Hospital always known for different types of the seminar. Still, we did not stop the virtually also we are doing. I must thank our senior management, all the respiratory doctors, critical care medicine doctors who are putting continuously effort to build the competency of the doctors and nurses and everybody. Thanks to everybody.
Yeah, namaste and very good evening to all dignitaries present over here. So what every seniors dignitaries mentioned, because in this hospital we always believe in knowledge and skill development through different types of platforms. So thank you so much for organizing these activities. And what Madam said, I also suffered from a bad COVID, and all the doctors and along with the sisters, so they have helped me out from there. And now I'm just standing in front of all of you because of our that all the efficient doctors and their good management. I think we should give a round of applause to all our critical care doctors and along with the nursing staff. So thank you so much. Definitely, means I think from the nursing side also, as Madam told, and all the nursing side, definitely we will be registering because this is a free registration. So definitely we will pass these things, and that always the knowledge and skill. I think till the last date we should enrich our knowledge and skills. Thank you so much.
We are almost nearing the end of this session. I will ask Dr. Asif Iqbal to come here and give the vote of thanks.
Good afternoon. Uh, Thank you to CEO sir and the Joy sir and DMS sir just left because he's a very busy person, and the nursing director ma'am and my senior colleagues and the junior colleagues. We are very happy that we have overcome the challenges of COVID, and now we are back in track because Apollo Clinicals Hospital is very renowned for the research and culture and the knowledge spreading to the among the community, among the nation. And we are very happy that we are organizing updates in respiratory and critical care medicine. We will have
So we are live. Dr. Neeraj, we are live. Dr. Neeraj?
I think Dr. Neeraj had some problem in the connection. Yeah.
Yeah, now I think.
Yeah.
Good afternoon, everyone. So I welcome all the faculties in this update of respiratory care and critical care. We are on the first day of the session. So I think we are waiting for Dr. Neeraj. Till then, we all, like all the faculties can just introduce and have a small brief about yourselves. And then we can start off the session.
Yeah. Tapas, we can start with you.
Hello, everybody. Thank you, Dr. Asif and all the organizing team members for inviting me to this panel discussion. I am Dr. Tapas Kumar Sahu from Medanta Hospital, Ranchi.
Hello, everyone. I am Dr. Yash Javeri. I am the head of critical care and emergency at Regency Super Specialty Hospital, Lucknow. I am the convener for Indian Sepsis Forum as well. Thank you for the kind invitation, Dr. Asif.
We will always have it online meeting.
Hello.
Raju Sida, please introduce yourself.
You are mute, Dr. Roy. Dr. Rajeshri, you are mute. Please unmute yourself.
Is it audible?
Yes.
Yes, I'm Dr. Roy from AMRI Hospital, Kolkata. Thank you. Asif and the organizing committee being in the part of this forum. Okay, next to Dr. Bhaskar Chaudhary.
Hello, good afternoon. Am I audible?
Yes,
Yes,
sir.
yes, yes.
So this is Dr. Bhaskar Chaudhary. I am the consultant microbiologist at PLS Hospital, Kolkata, and advisor microbiology and infection control in Fortis Hospital, Anandapur, Kolkata.
Thank you, sir.
Thank you.
Dr. Neeraj. Yes, Dr. Neeraj.
Can you hear me?
Yes.
Yeah.
So let's restart again, I think. So shall we restart?
Yes, yes.
Okay. So my first question is to Dr. Yash. And Dr. Yash, what are the additional challenges that you see in comparison to Western world that in India we need to somehow partake?
Thank you, Dr. Neeraj. The first and foremost challenge we see in India for sepsis is heterogeneity of care. The care in general, and more so for sepsis, critical care is very, very heterogeneous. There is huge variation from urban areas to semi-urban areas to smaller towns. Tier 1 to Tier 2 cities, there is huge variation. And there is a variation in care in the same hospital according to the crop also. Night time, the care dips significantly in the early. So one is heterogeneity of care. Second is availability of advanced care for sepsis. In many smaller towns and smaller cities, advanced care for sepsis is not available. We have improved quite a bit thanks to COVID pandemic, but still a long way to go. Third major issue is we are still lacking teamwork. There is lesser degree of coordination between various stakeholders for sepsis. Still, there is no ownership for sepsis. Ideally, the critical care colleagues should take over the sepsis patient and others should pitch in best of their capacities. But generally, there is still no ownership of sepsis patient. Many centers have considerably improved the diagnostics, especially the microbiological diagnosis, but most of the centers are still lagging behind. So they have to come up with clinical improvements, and there should be a good crosstalk and input from our clinical microbiological colleagues. It has improved considerably in last few years, but still smaller centers we have a long way. Another problem is overdiagnosis and at times underdiagnosis. Once the patient is in frank sepsis, septic shock, any Tom, Dick, and Harry will be able to diagnose sepsis. That is no big science. But we need to catch them early when the organ dysfunction has not set in. And often, unless the patient comes with a clear cut diagnosis of sepsis, they are missed. They are not only missed in the community, they are also missed in the wards, in the post operative areas. So we miss a lot of sepsis patients and we catch them late even in tertiary healthcare centers. So multidisciplinary care is must. We should have sepsis outreach teams or sepsis teams where everyone partners. One problem, another big problem or challenge I should say is over reliance on sepsis biomarkers. Many primary care physicians, especially medicine colleagues and others also at times critical care physicians also, they give over reliance on procalcitonin. They will not see it in completion. Procalcitonin is high, it is sepsis. Procalcitonin low, it is not sepsis. It is not so simple. We all know this. So these are the major concerns which I see: overdiagnosis versus underdiagnosis, and at times delay in the tertiary healthcare centers. Also, lack of teamwork, integration of clinical microbiological services. One major setback which also we see is a democratic decision making in the sepsis care also. We should abide by the science, respect the science, and not go for democratic decision making, especially for antibiotics. So these are the major flaws I see in sepsis care in India. Thank you, Dr. Neeraj.
Thank you, Dr. Yash. So, as you rightly said, uh, and as a convener of Indian Sepsis Forum, you have worked a lot. So, this paper, which came uh, in 2017, it shows how much awareness at the level of communities is required in order to get some therapy or intervention being acceptable. We have seen in this times of COVID that people are so aware about ECMO that when their patient does not improve by 3/4 a day and be on a mechanical ventilator, they themselves come to us. And if you look at what is the level of surge or level of intuitiveness when it comes to patient's family in comparison of ECMO with sepsis, it is way low. And when they try to find why India is ignorant to sepsis, because if we talk to commoner, sepsis is a term which has been loosely used since decades. And as Dr. Yash has rightly pointed out, the moment there is a delay in sepsis, the chances of survival are as less as 1 out of 4 patients. So I will take the discussion forward. And Dr. Bhaskar Chaudhary, as I said, he's an intense
I'm a
infectious disease
microbiologist.
specialist and microbiologist, and he's the specialty. All intensivists we try to look upon when it comes to saving life and giving us diagnosis early. So my question's got 2 parts. First part is how different is the epidemiology in India, and how much this delay is likely to contribute to this additional challenge when we talk about specific to India. Dr. Bhaskar.
Okay. Thank you. Thank you very much, Dr. Neeraj. So actually, the challenges that was being discussed just now, that we are being discussed. So we are facing these challenges in India. So the epidemiology of the Indian scenario, it's different from the Western statistics. So in the West, we see more of gram-positive infections, less of the tropical diseases and those things. And here we are burdened with the tropical diseases like malaria. Malaria now it is less in prevalence, but we are facing this scrub typhus. It's a very prevalent here. Particularly in our part of the country, we have lots of scrub typhus cases. We are detecting lots by the IgM ELISA, and we also have these viral diseases like dengue. Many of them turn to be hemorrhagic fever. Thanks to COVID, we had less incidence of dengue last year, but we have this dengue and the chikungunya and those things here. But amongst the bacterial infections which cause the major part of sepsis, so we have more of gram negatives here. Our most common bug that we get here is Klebsiella. Many of them are multi-drug resistant, including polymyxin resistant Klebsiella. We are getting next is E. coli. We are getting Next, gram positives are rather less in our country, and amongst the gram positives, we have more of enterococcus rather than staphylococcus. And staphylococcus, around 25% are MRSA we are having here. Unlike in the Western, they have a high burden of MRSA. So coagulase negative staphylococcus, the methicillin resistance are a bit higher. So these are the bugs we are facing, and amongst the enterococcus, we are getting a lots of VREs nowadays, vancomycin resistant enterococcus. But our problem bugs are always the gram-negative bugs, particularly Klebsiella, which is the most notorious, followed by E. coli, which is not that resistant. But we are also having the non-fermenters like Pseudomonas. Acinetobacter is more common than Pseudomonas. And we are also getting the non-fermenters which are intrinsically resistant to polymyxins. Like we are getting infections, we have breakthrough infections by the polystyrene resistant bugs like Proteus group of organisms. Then we have Elizabeth Kingia, then Trichiobacterium. All those things are now coming in. Stenotropomonas, which is not intrinsically resistant to polymyxins, but we are getting these infections. Burkholderia is another infection. We have more incidence of Burkholderia pseudomyelin infection, which causes melioidosis. We have come across such cases, although rarer than the other bugs. So viral, other than COVID, we have already discussed about dengue and other things. And another thing we have interesting thing we have noted last year, due to the COVID scenario, we had more of bloodstream infections. And many of these bloodstream infections, the commonest bug was of course Klebsiella, but second or third, we have seen many lots of Candida, and many of them were fluconazole resistant Candida, like Candida auris, Candida hemuloni. We have got those things, and many of the bugs, we have seen some incidents of Candida guilliarmondi, which were resistant to echinocandids. So these have, with changing scenario, we are getting changing scenario of the bugs as well. And another thing you were asking regarding the delay. So our gold standard is of course culture and sensitivity, but in our most of the labs here now in India, most of the labs are having the rapid diagnostic facilities. So in microbiology also, we are equipped with the automated analyzers which are detecting the ID and the sensitivity of the bugs within 12 hours or so. We are having Vitek and Backtech, Bactalert and those things here. And also we are having now the MALDI-TOF is also there, which can identify the organisms with in a record time as early as within 2 hours. So MALDI-TOF is difficult to be installed in facilities which are having less number of isolates. It's for larger facilities, but we are having those these multiplex PCR systems like the BioFire system and the alike. So this multiplex PCR system has revolutionized the scenario. So we are detecting the organisms, viral, bacterial, protozoal, and as well as viral organisms from the samples like upper respiratory samples, lower respiratory samples, then blood isolates. Blood isolate is not yet detected from directly from the blood cultures, but from the blood, but from the culture when it comes positive. From there, we can do the BCID, blood culture identification panel, to detect the bugs. And even the resistance pattern is detected by these systems, the multiplex PCR systems. Even Gene Expert has a carbapenem resistance detection system. So, and also the gastrointestinal. So these panels have helped us a lot. Now we are being able to give the diagnosis very early. And in case of the conventional blood cultures also, we are doing by rapid culture system, but whenever there is a blood culture positive, so we isolate it. Before isolating, we do a gram stain and immediately report the clinician. And we also put up a primary sensitivity from that broth, so that we can give an idea of the sensitivity by this diffusion within 24 hours. So we are trying our best to help the clinicians for an early diagnosis. Besides the already you have discussed about the markers. I think the markers are overused to some extent, but and they are costly also. Procalcitonin, serial procalcitonin is very difficult to conduct. Another less expensive is the CRP, serial CRP. Okay, so I think these are all from me now. If, thank you. Thank you. Hello. Hello.
Hello?
Hello. Is Dr. Neeraj there?
He's there in the, we can see him in the participants.
But we
But
can't hear anybody.
He's mute. Neeraj, you are mute. Dr. Neeraj, you are mute.
Can you hear me now?
Yes, yes.
Hello?
Yes, yes, you are audible now.
Okay. So what Dr. Yash and Dr. Bhaskar has made us realize that the dysregulated response of host immune system is primarily about gram-negative bacteria and things that comes from that. When we are trying to deal with viral pathogens like dengue, you have direct injury to the endothelium, and when you talk about malaria, there is sequestration of infected red blood cells, which cause direct vital organ dysfunction. Other aspect is tropical diseases. They do have huge proportion of strep typhus like and leishmania like diseases as well. Leptospira is something which we are seeing more frequently. Maybe we are able to diagnose it more. So if you have a great microbiology center and microbiologists combined, then you can rely on those investigations when you are trying to give your initial antibiotics. But in absence of those, please remember the seasonality. Please remember the non-bacterial causes. Please remember something as
Hello, Dr. Neeraj. We are not being able to hear you.
you're still not able to hear me.
Yes, yes. Now it's
Can you hear me now?
Yes.
Okay, so these are certain things that if we do not have exhaustive resources in terms of microbiology, one has to be really careful what kind of antibiotics one have for initial choices. So this brings me to the second part: how we can plan resuscitation, and we can have an indigenized approach of resuscitation, because I do not know whether my sepsis patient who may land into septic shock is a pure gram negative sepsis, or is having a component of dengue, or is having a mixed infection, or is having a malaria alone. So to Dr. Reshu, who is placed in a geographical area where all the three, as Dr. Bhaskar said, are really probable.
Yeah, thank you so much, Dr. Neeraj.
এটা তো 2:30 শেষ হওয়ার কথা আর 2-3 মিনিট আছে তারপরেই আপনারটা
Hello, can I proceed? Yeah, Dr. Asif? Okay, so the resuscitation, as we all know, it's always, we do it through the Surviving Sepsis Campaign bundle. It has been since 2001 when the early goal directed therapy was uh, introduced to us for the sepsis resuscitation thing. Then gradually there have been changes and there is an update every year, almost every year, and we are just updating ourselves. So be it Indianized, the bundle have certain points. Like earlier we had the 3R and 6R bundle, but now by the 2018 update, we have come to 1R bundle, which is very precise, and which if followed, it hardly matters whether you are in a resource limiting situation or in a well advanced center, the basics has to be right. So what we know is that 1R bundle, we have to check the lactates. If lactates are not possible, I'll be telling you about the clinical endpoints later on, where maybe in a resource limiting setting where we do not have those advanced ABG machines, or we cannot measure the lactates, what we can do, we send the cultures, we administer broad spectrum antibiotics, we resuscitate the patient with fluid that is crystalloids at 30 ml per kg body weight crystalloids over a period of time, and use of vasopressors if the patient is still hypotensive after the fluid resuscitation. The target, what we have to achieve, they say, is to maintain a MAP of more than 65 millimeter mercury. So all this have very strong recommendation, and they have been said these are the best practice elements, like obtaining the cultures, getting the cultures done, and targeting on some clinical endpoints. So now on the base of this, the clinical endpoints, basically simplest is what we usually do is we measure the lactates. We measure lactates, and again, we remeasure it after fluid resuscitation. Second, we also can see simple by, if you go back from our MBBS internship days, simply by just checking on the capillary refill time. So even if you are there at the bedside, if you just see the capillary refill time, whether it has improved or not, that is also a clinical endpoint, whether your resuscitation is successful or not. Simple as that, we can just see the urine output as well. That is also, we say, is a poor person's um, marker for resuscitation. So if patient starts pouring good urine output, that is also a good marker. Secondly, if the patient is there in the ICU and patient have a central venous access, then we have those central venous oxygen saturation, what we can see, and we have to maintain it above 70 to 75%. Hello, am I audible?
Audible, you are audible.
Yes.
Okay. So this is the way we practice, and we know that it has to be done within 1 hour. So we need to do it in a very protocolized manner. There have been certain trials, there have been certain studies based on standard therapy versus protocolized early goal directed therapy. So we have seen that the overall in-hospital mortality was found to be at least 16% less than when it is with EGDT, that early goal-directed therapy, as compared to the standard therapy. Hello, Dr. Neeraj? Dr. Neeraj?
Hello,
Yeah, Dr. Neeraj?
you can hear me?
Yeah, in between, your voice is breaking
Hello,
in between.
am I audible?
Yeah, yeah, now you are.
So, as highlighted by this paper, only half of the patients they receive antibiotics in initial 1 hour. To me, that is as important as giving fluid resuscitation. And if I can be a real provocative about it, the new sepsis paradigm is about giving fluid resuscitation, and simultaneously in those patients who after maybe initial 500 ml to 1000 ml of fluid, they do not respond in terms of blood pressure, you can start norepinephrine, particularly in resource current situations, alongside, rather than waiting for 30 ml per kg resuscitation to finish by. If you can measure lactate, it's fine. If you do not have those facilities, go by, as Dr. Reshu really nicely pointed out, go for clinical parameters, and they are as important as lactate, because when you have in absence of clinical endpoints, what are the problems of over GLS fluid resuscitation? The biggest problem is that non-bacterial sepsis is not going to respond the way bacterial sepsis responds to fluid. When it comes to dengue, over resuscitation may end up killing your patient rather than saving your patient. So we have to be realistic about what the ground realities are in one's institution, rather blindly trying to replicate guidelines from the West. So This brings me to Dr. Roy. Dr. Roy, we have tried to resuscitate a patient. We have given somewhere around 3 to 4 liters of fluid. And mind you, it's like anything which goes above 4 liter or 5 liters in the initial 24 hours has been shown to be associated with increased mortality and increased ICU length of stay. So what we need to do here in these patients? What are the kind of challenges and what are the kind of recommendations that you can give it to this crowd? Please illuminate us on that. Dr. Roy. Hello. Hello. Is Dr. Roy there?
Is it okay? Am I audible?
Yes,
Yes,
Yeah, now you're audible. Yeah.
Yes, thank you. The main thing is that it's a bundle. You cannot choose one, you have one at a time. You have to be together, antibiotic, resuscitation, fluid therapy, your lactate clearance, everything to be together. And first thing, as the patient is having a high lactate level, you have to target the organ. You have to diagnose what is the disease, and you have to choose an appropriate antibiotic. This word appropriate is very important because according to the organ specificity, your antibiotic protocol also change. It should be broad spectrum, it should be widely covered, and this specific antibiotics gives you a very important outcome. Then next thing is that it is a dose and the frequency. You have to have a proper dose and proper frequent in terms of antibiotic uses. This, you have to take a proper clearance of the allergic mismatch of these drugs which have been prescribed to your patient. If antibiotic, what?
So I mean, it's like I have a patient who is there in ICU after 24 hours, and as everybody for now has pointed out, one needs to cover the source of infection. If you see, as comes from this paper from Dr. Sodi, that almost half of the infections are coming from respiratory tract. So we need to choose a drug which will at least have penetration in the organ from where the infection is coming. And almost 1/10 of these patients had a tropical illnesses. So we need to cover for those tropical illnesses as well. So what's the role of biomarkers as it comes, Dr. Roy, to our armamentarium? Can we use them judiciously, titrating our antibiotics at 24 hours and 48 hours, particularly something like procalcitonin?
There are so much of biomarkers available here. One is main thing what we use as a clinician is procalcitonin, IL-6, and all other markers which has been used to diagnose whether the patient is having severe sepsis a thing. But only one test doesn't give you an exact figure that this patient is sick and this is the marker, he is sick enough, absolutely not sick like this. Definitely your procalcitonin is a marker which will end with and which will precipitate that you have.
Thank you so much. And I've included this particular paper. This paper it throws some novel points when it comes about.
You cannot choose your antibiotic according to your procalcitonin level. You have to give an empirical broad spectrum coverage to the patient who are in septic shock, because the primary outcome is you have to get over and full biological and microbiological coverage to them.
Yeah, perfect. So this paper highlighted 3 very important points, particularly in old patients, that there is a decent incidence of in certain geographical areas about gram positives. Secondly, when it comes to elderly, you have atypical presentations. 1/3 of these patients presented as delirium, but while they were in severe sepsis. And finally, you have only 25 to 50%, maybe 1/4 or 1/2 of your patient, they will be having some kind of culture positivity to guide you about about your empirical antibiotics when it comes to whether they are really effective 24 to 48 hours. So to me, the role of biomarkers at 48 hours is if your procalcitonin hasn't started to come down even by 20%, that means we need to either look at the dosage of antibiotics, or the organ where the infection is coming by antibiotics is not able to penetrate there. And finally and foremost, perhaps my antibiotic coverage is not comprehensive enough to deal with the infection that patient is suffering from. So this brings me to the final point. So when Dr. Tapas, when we talk about initial resuscitation, the things are getting more and more clearer. But as Dr. Roy and even I feel, after 24 hours, it's so less to guide us, because at 24 hours, we need to talk to the family as well. We need to tell them what kind of realistic chances my patient is having. So prognostication and care post-initial resuscitation, this is where I want your inputs about. Dr. Tapas.
So, to start with, it's a very tricky question. Like the prognosis markers, we have already discussed. It's maybe in Indian setup, we can rely upon the CRP or procalcitonin, and all the studies which have been most of the studies which have been coming up with the prognosis markers, they have been conducted in Western world, where the tropical illness is not a very important emphasis on sepsis management. In India, we are having malaria, dengue, and all these tropical illnesses. So that the deciding factor. CRP is actually elevated more in patients with malaria compared to the other sepsis of patients. I'm going to detail. It's very prognostic marker, and we can rely upon that because it can differentiate between the inflammatory, non-infectious causes, as well as the bacterial versus viral versus the fungal infections, and also the new recent markers which are like the IL-6, TREM1, and IL-8 and IL-27, which we are not using in all the developing states, or maybe the poor and the resource limited settings. Coming to the post resuscitation care, yes, definitely we have to think about how we can go if the patient
Suppose our next speaker is waiting, so just conclude the session early. Dr. Neeraj, I'm requesting the next speaker is waiting. Yeah.
Okay.
So you just conclude the.
Okay, so as Dr. Tapas said, there are certain prognostic markers which are universal. You have SAPS score, SAPS 2, SAPS 3. If a high Apache more than 22 is again has related to mortality. But one must remember some things which are particularly important in India's population. If you look this paper which comes, it says if you are already anemic, and if you have effects of hemodilution due to overzealous fluid resuscitation, that can also worsen your mortality. So to conclude, I'll say guidelines are really important, and we integrate certain things like procalcitonin to guide us for finding good antibiotics. But what one must understand is local geography. India is as large as European continent. So what happens in Denmark does not happen in Italy, and it doesn't happen in Greece either. So local variations, our geographical constraint, our local microbiological data, and seasonal variability, they should be considered all the time. Overzealous fluid resuscitation, which comes from West, it should not be dwelled upon too much. Initial choice of antibiotics and giving them early in each and every patient within first hour of presentation and sepsis is most important. So this is how I conclude. I thank all my panelists who have taken such a huge effort in joining us from all across India. And congratulations, Dr. Asif. Thank you so much.
Thank you, Nita. Thank you. Our next session is optimum therapy for patient with bronchiectasis, and speaker is Dr. Rajadhar. I will request Dr. Rajadhar, please share your presentation.
Asif, someone needs to unshare for me to. Thank you.
Yeah.
So I'm happy to start whenever you want me to.
Yeah, thank you, sir. You start just.
Okay. So thank you very much, Asif. Thank you, Ashokda. Absolute pleasure to be speaking on this platform, and congratulations for arranging a meeting in the middle of a pandemic. I know how much of a challenge that is. In the next 15 minutes, I'll be talking about optimum therapy for patients with bronchiectasis. I start off by showing you this definition of bronchiectasis, which is from the ERS guidelines. And it's a simple clinical definition. It talks about a chronic respiratory disease, which is characterized by cough, sputum, and bronchial infection, and then radiologically by abnormal and permanent dilatation of the bronchus. So when you look at this definition, you can see there's a conundrum, there's a complex number of cystic bronchiectasis. And for people interested, do read this review article published as an editorial in Nature. It will give you an bronchiectasis across continents, across the globe, and we have participated as India in this particular review article. Which brings me to another publication we're very proud about. This is the Embark India Registry, which we did across multiple centers. We had about 2,200 patients in this, and we published in Lancet Global Health. And I was extremely pleased, flattered to be the first author of this article. And I take you to the management based on this particular paper. So we found that out of the 2,195 patients in this registry, 63%, so that's 1,387 patients, were on inhaled corticosteroids. About 56% of patients were on bronchodilators, either bronchodilators by themselves or in combination with an inhaled corticosteroid. The evidence-based treatment, the N-acetylcysteine, the low-dose macrolides, etc., were far fewer in number. So the mindset of the Indian physician is still that bronchiectasis is an obstructive airways disease, and you would treat them no different to what you would treat your asthma and COPD. And that's the mindset that we need to change together as a community of pulmonologists, as a community of physicians, when we are trying to treat this disease process. So this is more of what we said a little while ago. So long-term antibiotics infrequently used, low-dose macrolides infrequently used, long-term antibiotics, drugs like coamoxiclav, fluoroquinolones, tetracyclines, also used in very small numbers. What we did well, similar to what the West has done, what Europe has done, is bronchial clearance technique. So airway clearance, we did in about 40% of patients. So while that's a small number, it's not what we want to achieve, we were actually much better as compared to prescribing evidence-based treatment in our patients. So what are the treatment principles? The treatment principles are that you should prevent or suppress acute bronchial infection. You should improve mucociliary clearance, and doing these will reduce the impact of structural lung disease. So I take you to this cartoon, the flow diagram that you see on the right. So this chronic bronchial infection results in ongoing inflammation in the airway. Ongoing inflammation results in destruction of the cilia. Destruction of the cilia results in structural lung disease, so spill over from the airway into the lung, and hence structural lung disease. And when we think about treatment, you try and target each of these steps. So the chronic bronchial infection, the inflammation, the impaired mucociliary clearance, and the structural lung disease is how you target. And how do you target these things? You target them, but for bronchial infection, it's the low-dose antibiotics, the low-dose macrolides, eradication of the pathogenic organism. For inflammation, it's anti-inflammatory treatment. For impaired mucociliary clearance, it's the airway clearance techniques that we spoke about a little while ago. And for structural lung disease, it's bronchodilator treatment. It's sometimes surgery in rare, small number, but still a significant number of people, and then pulmonary rehabilitation. So that's how you think about the gamut of management of bronchiectasis. So this is again from the ERJ 2015, good friend James Chalmers who came up with this wonderful diagram. I won't go into great detail because it will take time, but I want you to give you the principles of what shows up on this slide. So there's airway clearance techniques that we talked about. There's long-term antibiotic therapy. There's small place for anti-inflammatory therapy, and there are therapies advanced disease. So those are the 4 different modalities available: airway clearance techniques, long-term antibiotics, anti-inflammatory, and therapies in advanced disease. Of this, like you would think of step-up treatment with asthma. So mild disease is just chest physiotherapy. Moderate to severe disease, you would think of agents which act as adjuncts in improving expectoration. So devices, flutter devices, for instance, the acapellas, the aerobicas, etc., hyperosmolar agents which make the sputum less viscid and hence easier for patients to cough it up, the use of macrolides, and in some patients, the use of inhaled corticosteroids. And then the final step for the severest of bronchiectasis, you use long-term oxygen, use the inhaled corticosteroid, you use the macrolides, and again, the physiotherapy adjuncts that we spoke about a little while ago. So one slide on airway clearance techniques, the fact that this is safe, there's no drug to take. Hence, there's no envisaged side effect from having airway clearance techniques. You remove the sputum, you reduce hyperinflation by removing the plugs within the airway which cause air trapping, and hence, because you reduce hyperinflation, you improve quality of life in these individuals. And the mechanical modes are the autogenic drainage, the postural drainage that we all know about, the huff and puff techniques, and active cycle breathing techniques, which your physiotherapies will tell you about, and hence to engage your physiotherapy colleague if you have to do airway techniques well, and if you have to treat bronchiectasis well. Then there's the inhaled hyperosmolar agents and the mucolytics. Won't read through this, but this is my gist of the ERS recommendation on use of inhaled hyperosmolar agents. So the mucoactive treatment that we talk about, the N-acetylcysteine, the hypertonic saline, etc., should be continued for a period of more than 3 months at least in adult patients with bronchiectasis who produce less of sputum in spite of having a lot of sputum and hence a poor quality of life. However, dilators only for patients who have an overlap with COPD, significant breathlessness because their airways are narrow, and use bronchodilators before physiotherapy because your mucoactive drugs, your hypertonic saline, can actually cause bronchospasm. So if you have to use bronchodilators, shock-acting levosalbutamol, for instance, nebulize the patient and then give the mucoactive drugs that will help better expectoration and also reduce the chances of bronchospasm that you have by using these agents. And again, like I said in the previous slide, the BTS recommendations are similar to what you have with the ERS recommendations. Couple of slides on the most evidence-based treatment, which is use of antibiotics. And the use of antibiotics is in reducing exacerbations, in trying to eradicate the pseudomonas which people have, use the low-dose macrolides long-term to reduce exacerbation frequency, and also to use in mycobacterium other than tuberculosis, the non-tuberculous mycobacteria, which seem to be far more frequent in the US as compared to what it is in India or in Europe for that matter. Couple of slides about exacerbation. Exacerbation definition is not very different to exacerbation definition in COPD. So worse from what you are at baseline in 3 of the following criteria, at least for 48 hours, which requires change of treatment, is what an exacerbation is. And the clinical parameters that we're talking about is cough, sputum production, purulence of the sputum, breathlessness, exercise tolerance, and hemoptysis. And that is the stepwise management of an exacerbation. I won't dwell on this. I'll leave these slides with you, but I won't dwell on these because of want of time. But the steps again in an exacerbation is airway clearance techniques, vaccinating people to prevent an exacerbation. And when we talk about vaccination, we are talking about influenza and pneumonia, having a self-management plan for the patient with antibiotics, something similar to what you would do in patients with asthma. The other management modalities are bronchodilators, a course of oral steroids in people who have an overlap with obstructive airways disease, and then inhaled antibiotics, the tobramycin and the colistin, which is used in these patients. The treatment of an exacerbation depends on the bug that you isolate. And this table shows you, this flow diagram shows you that the strep pneumoniae would respond to a benzyl penicillin or an analog. The H. influenzae would respond to an ampicillin. The Pseudomonas would respond to a piperacillin tazobactam or a ceftazidime, and so on. So the bacteria needs to be isolated. Microbiology is extremely important, more important than spirometry in patients with bronchiectasis. And there's good going evidence that long-term antibiotics is the way forward in patients with bronchiectasis. And when we talk about long-term antibiotics, we are talking about low-dose macrolides in the form of azithromycin, either 500 milligram 3 times a week or 250 milligrams daily. And you would use this for a period of at least 3 months, ideally for 6 months to a year. Remember, QT prolongation can happen in these patients. So you need to have an ECG at baseline and an ECG after a month of starting the drug. Ask the patient about their hearing. And remember that if you use low-dose macrolides, you probably sacrifice the anti-inflammatory, the antibiotic effect to purchase the anti-inflammatory effect in these individuals. So that's something which is worth remembering in these patients. This is the algorithm for Pseudomonas in our country. Even according to the EMBARK registry, the commonest organism still remains Pseudomonas. We also have other Enterobacteriaceae. We also have Klebsiella quite commonly, but Pseudomonas remains the most common organism at about 14% in patients with bronchiectasis. And the first line treatment here is a fluoroquinolone. You need to remember about TB. You need to remember about drug resistance when you prescribe it. But still, in this indication, a fluoroquinolone would still be mandated. The second line treatment would be IV anti-pseudomonal antibiotics. And we've spoken about the piperacillin tazobactam. We've spoken about the IV aminoglycoside. And then the nebulized antibiotic we spoke about, which is mainly colistin and tobramycin. So this is the flow diagram for a new isolate of Pseudomonas aeruginosa, and it is in lines with what we said. The oral fluoroquinolone, the IV antibiotic, and then the nebulized antibiotic is what you would do in these individuals. So I'll skip a few slides and give you the bottom line again from the ERS guidance that all these trials show significant reduction of exacerbation frequency compared to placebo, and the improvements are improvements in quality of life, and even small improvements, which we have learned recently in spirometry. The FEV1 seems to improve in these individuals. So that's my take-home message for all of you from the ERS recommendations. Long-term treatment with macrolides is what is mandated in our patients with bronchiectasis, especially the gram-negative bug. For adults with bronchiectasis and chronic Pseudomonas, an inhaled antibiotic is to be given unless there is a definite contraindication. In addition to or in place of an inhaled antibiotic with chronic Pseudomonas infection, long-term inhaled antibiotic is what is advocated, and oral antibiotics, either in a rotation regime or with low-dose macrolides, is what we would warrant for our patients. I'll skip these and come to my final slide. So that's my take-home message for all of you. The fact that bronchiectasis is a common condition with permanent widening and dilatation of the bronchus. Pseudomonas, Klebsiella, and Acinetobacter are the commonest microorganisms in our country. Pseudomonas, like the West, remains the commonest. The other organisms in India are something which we have learned of as we have gone along. Long-term macrolide antibiotics have the highest level of evidence in reducing exacerbation. Inhaled antibiotics like tobramycin and colistin have good use in patients with bronchiectasis. And remember, administering these antibiotics or even these hypertonic saline as hyperosmolar agents can cause bronchospasm, and hence using a short-acting bronchodilator in these individuals would be something which is worthwhile. Thank you very much for listening. I think I've done my 15 minutes, and thank you again for the kind invitation.
Thank you, Raja, for this excellent talk in a nutshell, but you have covered everything, I presume. We will wait for just a couple of questions from the audience, if there is any. Any questions? Now that we have learned quite a few important things, that not all bronchiectatic patients are for inhaled corticosteroids or bronchodilators as such. Antibiotics needs to be used very judiciously. We need to use more of nebulized antibiotics for long-term management, for long-term control of the infection. And if there is no other question, we will conclude the session. Thank you, Raja, again for your wonderful talk. Thank you.
Thank you.
Good afternoon. Our next session is newer therapy in MDR TB. That is a panel discussion, and Dr. Angshuman Mukherjee is a moderator, along with Dr. Seli Samim, Dr. Monotos Khara is a panelist. So I will request all of you, please start the session.
Good afternoon, Asif. Am I audible?
Yes, sir.
Okay. Am I audible and visible?
You are audible and visible both, sir.
Thank you so much. And in the middle of these difficult times, it's very nice to see that such a long program on respiratory and critical care has been arranged by your end. It's indeed heartening. And I welcome my two co-panelists, Dr. Shelly Shamim and Dr. Monotosh Khara, to kindly join in with their videos and audios, please. And it is indeed something very interesting has happened during the last 1 year, that the revised National Tuberculosis Control Program has been now renamed as the National Tuberculosis Eradication Program. So from a point of view of control, we are changing our gears to a tuberculosis eradication program, and to maintain this steady state of decline of incidence of TB, I think we need to focus our energies on treating and managing drug-resistant TB very sincerely. And keeping that in mind, I think we would start our small discussion on treatment of drug-resistant TB with two small illustrative cases, so which we can discuss, and that I think will highlight the problems and the challenges and the way forward in treating drug-resistant TB. So, Dr. Shelly and Dr. Monotosh, I think, Monotosh, are you there?
I'm here.
Yes, fine. Shelly, then we'll start with you.
So I think Dr. Monotosh is also there.
Monotosh, are you there? That's fine. So, let us hypothetically take two situations, and these are two very common situations that we have in our day-to-day lives. So let us consider a patient who is a patient we had a few months back, a laboratory technician who is a microbiology technician, works with all sorts of samples, including sputum samples, and he was diagnosed as having a left axillary lymph node TB. So he had one lymph node in the left axilla, which was a discharging lymph node. And this gentleman went to a surgeon who did an excision biopsy of that lymph node and sent the biopsies for both the pathology and also samples in normal saline for microbiology. And all the samples for the current microbiological tests were sent. And this lymph node showed that this tissue from the lymph node showed that the CBNAT was positive. It was done on the expert and integrated platform, and he had rifampicin resistance. Now that is where the story starts, and he comes to Shelly you. So what will you do from this point of time?
Although this is not very common to find MDR tuberculosis in extrapulmonary tuberculosis like lymph node or pleural TB, but still we see at least in a few percent, maybe 4 or 6% cases, we see primary resistance as we see in general population in sputum positive tuberculosis.
So if there is, we do the CBNAT and it suggests that there is rifampicin resistance, that per se indicates that this is a MDR tuberculosis, probably primary one, acquired probably from the lab where they are using MDR pathogens also, I think. So we have to consider this as MDR and proceed accordingly. Now, whenever we see a rifampicin resistance in CBNAT, ideally we should also consider for other drug resistance pattern by second line LPL, line probe assay, but in lymph node tuberculosis where there is the smear is not positive often, it is very difficult to do line probe assay. So we may send a liquid culture for DST or from the sample apart from this CBNAT. And from the CBNAT.
I would like to, yes, that's the right approach. I would like to interrupt you here and bring in Monotos, because Monotos, you have been working in a government institute and you are very much a part of the National TB Eradication Program. So let us also look at the perspective from which a private practitioner like Dr. Monotos would look at it at this point of time. So I would request Dr. Monotos. So we have now at this point of time a patient who is having a probably extrapulmonary drug-resistant TB. So what is your ease of access to line probe assays? As a private practitioner, what do you think is your take on this? Monotos, please unmute your mic. I think
unmute yourself.
I think Monotos is unmuted.
Okay. Okay. Is it audible now?
Yes, audible.
Okay. First of all, I want to know really, thank you, Dr. Ungshuman and other teams member for asking me to be a panelist in this group. I just want to have some questions regarding the GenExpert or CBNAT report. What was the bacterial load? Was it low, very low, or medium, or high? Because in low low bacterial load, the rifampicin resistance in CBNAT may be false positive. There are two papers I have gone through just recently, as high as 85% cases of rifampicin resistance cases in very low bacterial load cases are false negative, false positive. So we have to repeat the case.
Yes, you have correctly pointed out that in this patient, especially with low bacterial count, low microbacterial levels, you can have a rifampicin indeterminate or indeterminate may be there, and or you may have rifampicin resistance. So I quite agree with you, Monotos. So the next slide. Part.
So thank you, Ungshuman. One thing, if it is low, bacterial load is low, our approach should be to repeat the CBNAT to see whether really it is again positive. I mean, rifampicin resistance. If resistance is there, definitely we have to follow the MDR guidelines. Now, one thing I want to know, whether the patient has any past history of antitubercular therapy. That is important. That is exposure to other drugs, particularly chlorochlorines and others. And is there any comorbidities like that? Is there any comorbidities like that?
In this particular patient, in this particular case scenario, he did not have any exposure to previous anti-TB drugs. He was a laboratory technician, so might have been exposed to difficult drugs. So, to take this forward, I think, what is the next step? So, as Dr. Shelley was saying, he would like to confirm this CBNAT test by doing a line probe assay. And my question to you is, as a private practitioner, what is your access to line probe assay? How easily do you find an access to line probe?
Very difficult. We don't have any easy access to this line probe assay. Maybe a second line or second line. It is very difficult to have this one. Ideally, the patient should have also to see the resistance patterns to fluoroquinones. It is better to know, so that we can, if there is fluoroquinolone resistance, then we have to go to the BPAL regimen. But if there is no resistance to fluoroquinolone, if it is not detected, then we can go as per the WHO guidelines, that is all oral short course MDR therapy, that is for 9 to 12 months.
Yes, Dr. Shelley. So right at this point, supposing you are able to do a line probe assay on this patient.
Exactly. Now again, in limnotuberculosis, you see, they will not do the line probe assay directly from the sample, because it is not smear positive most of the time.
Exactly.
So that's why it is very difficult. We have to go for liquid culture, in particular in this case. And from liquid culture, it comes positive within 2 weeks or 3 weeks. Then from that sample, we can go for line probe assay. Or we can do from culture, drug sensitivity result from the liquid culture itself. So that might be the approach here. And also for whether false positivity of rifampicin resistance in CBNAT, I agree that yes, but most of the time the report comes indeterminate resistance. So in extrapulmonary tuberculosis, the report comes indeterminate resistance. Most of the time these are actually sensitive, but due to low viral load, bacillary load, the report comes indeterminate resistance pattern. So we can ignore in this case according to clinical perspective.
Right. Supposing in this patient, we actually get a true rifampicin resistance.
Exactly.
So what would be the pre-treatment workup for these patients, and we'll take it forward from there. What pre-treatment workup would you like to do on these patients?
Ideally, the patient, we should know whether the patient is suffering from INH resistance. This is one. Whether the patient is suffering from fluoroquinolone resistance, these two. We have to exclude the presence of other comorbidities like diabetes mellitus, renal failure, HIV, liver, and this one. We have to calculate the body weight, everything. And is there any history of close contact with MDR TB patient or not? That is important. So okay, this if there is no comorbidities, okay, simple case, then we can go start for the all oral short course chemotherapy as directed by WHO.
So Shelley, I think paradigm shift in treatment of drug-resistant TB in these times are to move away from injectable-based regimen to all oral regimen. So how do we decide on what drugs do we choose? What is the method of decision?
Currently, most of the situation we can consider short course therapies if we use bedaquiline. Now, a particular example in this case, we can start. Patient is adult. Patient, there is no other contraindication as I see. No prior use of long-term fluoroquinolones is there definitely for more than one month. So unlikely to have resistance to fluoroquinolones. Still, we have to see from the drug sensitivity result. But if it is not there, then we can go for short course regimen, including bedaquiline. So mainly the regimen consists of 4 to 6 months of bedaquiline, our fluoroquinolones, maybe levofloxacin or moxifloxacin. We have to add high dose INH. We have to consider ethanoamide and pyrazinamide ethambutal for initial period, and then later we have to continue with the along with clofazimine. So we have to continue with the only after 6 months we have to discontinue the bedaquiline, and we have to continue for 5 months other drugs like the pyrazinamide ethambutal along with clofazimine and our fluoroquinolones. So that might be total duration of 9 or 11 months, 9 to 11 months may be sufficient, and the cure rate is rather excellent, I would say, nearly 90% or 80 to 90% in these cases.
Yes.
Cure rate.
So I quite agree. So Manotosh, what do you think is the biggest impediment of using bedaquiline? So I think have you used bedaquiline, Manotosh?
No. I have not used so far.
So
because it is not available in our part. Because I have sent quite a number of patients to Howrah District Hospital regarding this, bedaquiline and others. But they actually they are very reluctant to start because they are having some queries and everything like that. The patient sometimes refused, and they usually come back to me. So I don't have any experience, not with the bedaquiline or any other drugs like this.
I think for practitioners, this is also becoming a problem. Access to drugs is becoming a problem. Although I think bedaquiline containing regimen should be the right choice for this drug. So bedaquiline, I think the ECG abnormalities associated with bedaquiline is the biggest impediment. So when do you think bedaquiline cannot be used? What are the situations where bedaquiline cannot be used?
Definitely, age is important. If the age is less than 17 years, so there is a very conditional recommendation for use between the age of 6 to 17. But it is better to avoid using bedaquiline below the age of 17. That is one. Second thing is the cardiological problem, because the patient has to be, it is better to admit the patient at least to do ECG daily for the first 2 weeks. If there is QT prolongation is okay, that we can continue it, and then we can do ECG at 2 weeks or 4 weeks interval. But if there is a QT prolongation, QTC prolongation more than 500, then we have to discontinue. Probably this discontinuation may be the permanent discontinuation. Other drugs we have to monitor the effects.
Prolongation, UTC prolongation, age and pregnancy, I think, are the biggest impediments in using bedaquiline.
Yes, pregnancy.
So let us take another case scenario. Supposing there's a
Dr. Ankuman sir.
Yes.
Sir, we are running shortage of time, sir. Please.
Okay, fine. So to conclude, so to summarize from this particular case, we have 2-3 take-home points. One is the drug regimens are changing. So, as you know, as you have spoken to 2 practitioners who are treating difficult tuberculosis day in and day out, especially Dr. Monotosh Kara, who is treating a lot of HIV and tuberculosis, and Dr. Shali Shaming. So, from both their interactions, we have come to know that there are new drugs like bedaquiline which have been included in the treatment of tuberculosis, severe tuberculosis. They are indeed very effective drugs, giving very high rates of cure, but unfortunately, availability of bedaquiline and melamine beyond the program conditions is very difficult. So, although we have new drugs, we have new regimens, availability of drugs is a problem. So, the message that should go forward is whenever you are dealing with a patient of MDR tuberculosis, send it to centers or send it to persons who have access to drugs, who can give the patient the benefit of the best drug regimens, and also know the side effects and the difficulties in managing these drugs. These drugs are difficult to manage, their side effect profiles are also difficult, and the counseling for these drugs and the monitoring is difficult. So send it to centers where they are adept at managing these drugs. And finally, for all practitioners who may be listening to this program, make it sure that TB is a notifiable disease. Please notify TB, or please send it to someone who can notify TB, because without notification, it is likely to become a penal offense for a physician if you are not notifying TB. So this is very important. So take everybody along with you and notify all patients of TB. So thank you very much. I think I will bring this to
Thank you, sir. Thank you, Dr. Ankuman. Thank you, Dr. Shali Shamim and Dr. Monotosh Kara for wonderful session. Our next session is acute ILD management, and the speaker is Dr. A.G. Ghoshal, and the chairperson is Dr. Ashok Sengupta. Sir, please proceed the session. Dr. Ghoshal?
I'm here. Okay.
Yes, sir.
Who is going to start? Ashok or me?
Say you.
Oh, it's me? Okay.
Yes, sir.
Then Good afternoon, everybody, and thanks for making us again coming together. And I can see Dr. Iqbal, Ashok, Subhasis, Dr. Indrajit Tiwari, and I was there with them also, Usman, Shelly, and Munatos. So today I am going to discuss on acute ILD management. That has been the topic given to me, and so just taking a little time. I'm not that conversant. Okay. Yes, it is fine now. So thanks everybody, and let's get to the subject. So acute ILD management practically is an extrapolation of our concept of managing acute exacerbation in idiopathic pulmonary fibrosis. And taking every together, because I remember what happened in 2000, that we thought every acute exacerbation is acute exacerbation of IIP and probably IPF. Now we understand that it is very difficult to differentiate between the entities during acute exacerbation. So it would be better to call it AEILD to have a holistic approach to these acute exacerbations. And this is important because acute ILD as such is cause for uncommon presentation or admission, but again with a very high hospitalization, ICU admission, and mortality. So incidence is low, but the fatality is high. And we usually get to see them in three circumstances: acute exacerbation in a known patient of ILD, acute exacerbation in a patient where the DPLD diagnosis has not been before, and another is very devastating acute interstitial pneumonia. Am I audible, Ashok? Can you hear me?
You are very much audible, sir.
Okay, thank you. So the DPLD tree actually, first we have to get to the diagnosis of IIP, idiopathic interstitial pneumonia, and then the different causes, known cause or association. Known means one is this rheumatic vasculitis, hypersensitive pneumonitis, this group. Another by histopathology, the granulomatous sarcoidosis, Chuxters, Wegener's, the names have been changed. There are other groups. So when we take out these all other groups, what remains is the big chunk of idiopathic interstitial pneumonia. And though idiopathic pulmonary fibrosis is the big boss in this group, but others cannot be neglected as well. And anyone in this group can present with acute interstitial pneumonia or acute exacerbation. So for the sake of diagnosis, there was an effort to define acute exacerbation of idiopathic pulmonary fibrosis. We started with IPF. So Kolar tried it in 2007 and then modified it in 2016. So here was the change. So basically, for it to be acute, anyway, for it to be the acute, it has to be within 30 days. That has been modified a little to make it more flexible, that typically of less than 1 month. You have to get the clinical part, acute worsening or development of dyspnea. You have to get the radiology part, new bilateral ground glass opacity on the background of a chronic ILD pattern. But in the previous one, the infection has to be excluded. Here, this exclusion has been withheld. That means infection is part of AE. It should be taken as a triggered AE ILD, triggered event. Taken together, this is the presentation. Whenever you get the patient, acute exacerbation, you rule out the alternative diagnosis, Parenchymal say pneumothorax, pleural effusion, pulmonary embolism. You rule out other causes like congestive heart failure. What remains is radiologically confirmed bilateral GG or consolidation is acute exacerbation of IPF, and there two groups. If you can get a trigger, definitely then it's a triggered acute exacerbation, and when you don't get anything, and most of the times we honestly don't get anything, it is acute idiopathic exacerbation. Same thing, same concept extrapolated to the AEILD. So acute respiratory deterioration, rule out the extrapulmonary diagnosis, get to the computer tomography of the chest, rule out the other diagnosis, pneumothorax, pleural effusion, and then you have to go for the acute exacerbation. Trigger identified, okay, triggered acute exacerbation. Triggered no, it is idiopathic acute exacerbation. Now, IPF is not that common compared to diseases like COPD, asthma, but the mortality is very much high compared to these diseases. And similarly, the incidence of acute exacerbation has varied between different series depending on their methodology, definition, standard accepted, so 0 to 21%. But the mortality is very high in the acute setting and also higher 1-year mortality after hospitalization for acute respiratory worsening compared to patients with other fibrotic ILDs. So it's a devastating disease. The highest acute exacerbation occurs in patients with a histological or radiological pattern of usual interstitial pneumonia. So it happens in IPF, but in others, in chronic hypersensitive pneumonitis, say NSIP, and even CTD-ILD, say rheumatoid lung, presence of UIP actually is more conducive to development of acute exacerbation. Usually advanced disease, mortality highest among the AIP, then the AI acute exacerbation in IPF group, then acute exacerbation in the non-IPF DPLD group. This is a registry from North India, and where they got these hospitalized cases. So the most common type they got was CTD related DPLD, followed by IPF, and then non-specific interstitial pneumonia. 11% were diagnosed with acute interstitial pneumonia. They tried to draw a thin line by articulating that acute respiratory failure in IPF was primarily due to acute exacerbation or progression of the disease pathology itself, while acute respiratory failure presenting as acute exacerbation in non-IPF DPLD was most commonly due to infections. Triggers, again, in most of the cases we don't get any external trigger, but there is limited evidence to suggest that it may be precipitated by infection, microaspiration, and again definitely by interventions, whether it's surgical lung biopsy, whether it's cryobiopsy, or even just bronchoscopy with bulb, we have seen precipitating acute exacerbation. And we don't have to go for winter to discuss viral infections among this pandemic. Everybody is presenting like acute exacerbation of ILD. The term that is going in the circle for say last few years is progressive fibrosing ILD. So intuitionally, they should have more acute exacerbations, but still there is limited epidemiological data on their incidence and prevalence. Diagnosis. How do we diagnose acute exacerbation of ILDs? The diagnosis relies solely on clinical and radiological finding. The clinical part is very impressive. Dyspnea is the predominant thing, acute worsening, so that patient sometimes even forget to tell you his other complaints of cough, fever, and flu-like symptoms. And as we said, the time period typically less than 1 month in duration. It may be a little over, a little under. And our mainstay of diagnosis with this clinical picture has to be imaging. Imaging means what? Long back, we thought imaging was primarily done with chest X-ray. And so, this was very, very long back, prehistoric times. This was a lady, 34 years female, very fair complexion. So the Malarious could be seen and presented with acute worsening of dyspnea, and she had fever as well, only 4 days duration. And as we protocol, we took the blood, sent it for lab reports, and we started the therapy. The lab reports came later, very high lupus antibodies. So this was a presentation of acute interstitial pneumonia of SLE, practically lupus pneumonia. And same time, see the dates as well, just look at the X-ray and look at this X-ray. Almost similar X-ray, another lady, 42 years. This was a case of ARDS in a patient with sepsis. So little to choose radiologically. So ultimately radiology is very sensitive, very non-specific. It has to be always interpreted with the clinical scenario. Do we have any role of this chest X-ray even at the present moment? We do, because at least you can exclude other precipitating causes like pneumonia, pleural effusion, or pneumothorax before calling it acute exacerbation of interstitial lung disease. Naturally, HRCT chest is a precondition now to the diagnosis of AEILD. It has to be newly developed bilateral alveolar infiltrates, which may be peripheral, multifocal, or diffuse, and expectedly there should be a background evidence of chronic ILD. Very angry looking, and again there is everything is possible. Very bizarre at times, very atypical at times. So the CT imaging of the patients should show new bilateral groundless opacity and consolidation superimposed on a background pattern consistent with fibrosing ILD. This is the definition has been used in the recent trials to define AEILD or AEIPF. It can be very atypical, very bizarre. Even we have seen unilateral, where you call it suspected acute exacerbation of interstitial lung disease. And when you see this, the patient probably 35 years coming from the hills, very dyspneic. You could have diagnosed acute exacerbation of idiopathic interstitial pneumonia, AILD, and then you got the previous CT. Now you understand, particularly the pre-test probability in this pandemic. RT-PCR for COVID-19 was negative on repeated occasions in this patient. But again, do we have a differential diagnosis here? So our approach to ILD when it is known, if it is known, then again, identify contributing factors. And most predominant of them will be infection by imaging, blood cell count, CRP, may go for procal and others. You exclude congestive heart failure, fluid overload, that's a preliminary exclusion. You exclude drug-induced lung toxicity. So you get to the diagnosis of acute ILD and you go for the treatment. Depending again, triggered or idiopathic, it's very difficult to differentiate at the bedside even. Sometimes we get these cases where we see the CT and we understand this is actually acute presentation on a previous chronic ILD which has not been diagnosed before. So there you have two tasks simultaneously. One, to look out for the acute exacerbation, the trigger and the management. And two, to go for the basic chronic ILD and diagnosis of that with history and with previous radiological records. The most devastating is this part, no history, nothing before, straight comes with this acute interstitial pneumonia. Now that is the most threatening, but all present here can present with acute exacerbation of ILD or acute interstitial pneumonia picture. We don't have time or even attitude to do pulmonary function test in these patients. Bronchoscopy is frequently taken, at least to rule out infection. But again, there are studies to suggest that the outcome is similar whether you go for an identified trigger or not. Lung biopsies are practically no, they can precipitate acute exacerbation. Someday we'll have biomarkers, not at present. Now our all biomarkers is related to the triggered events, anti-proBNP, procalcitonin, different triggers, and we go for the different biomarkers. Management. What do we have in management for this devastating disease? Unfortunately and surprisingly, we don't have enough controlled trials and randomized studies to base optimal management of acute exacerbation in ILDs. What we have is this: anti-infective, anti-inflammatory or immunosuppressive, recent addition, antifibrotic, still questionable. So basically what we have is supportive treatment. And we'll come to that later. Lately there has been a reappraisal only for supportive treatment without anything else. So what do? The current international guidelines give a weak recommendation with the treatment of corticosteroids, emphasizing that recommendation is based on anecdotal reports of benefit and again nothing else to do, high overall mortality. But again, in other ILDs also, corticosteroids may confer a benefit, particularly in those groups of CTD ILDs and in selected cases of sarcoidosis and hypersensitivity pneumonitis. Usual intravenous pulses of high-dose methylprednisolone, not exceeding 1 gram per day for 3 days, followed by oral and then slow tapering over the days. But high-dose steroids should be used with caution in patients with SSC-ILD due to the associated risk of renal crisis. Antibiotics we all give. On what basis? We cannot exclude infection. So empiric broad-spectrum antibiotics often administered to rule out difficult to identify infectious agents. So frequently we keep the atypical coverage as well. And then if we are fortunate enough to have specific infective causes of exacerbation, they can be treated with specific agents. Antibiotics we usually do not prolong for more than 7 days. We stop it there unless we have evidence that there is ongoing infection. Other immunosuppressive agents, I remember particularly in the early 2006, 7, 8, we used to give a lot of cyclophosphamide. But this has been tempered with time. Probably not much evidence in our hand, but still we use it, intravenous cyclophosphamide, 375 milligram per square meter. There are others, in addition to systemic corticosteroids. The others, as we can see, cyclosporin, tacrolimus, recently rituximab, we have not used them. So we are still predominantly on glucocorticoids with or without cyclophosphamide. But there has been a conscious effort to promote just supportive care. That means broad spectrum antibiotics, palliation of symptoms, and stopping immunosuppression if it is already there. And it said the better 1 year survival. Still, there are different opinions on the exact regime and the length of supportive care. And this is very important. In all cases of AE, potential exposure to causative toxic agents on a case-by-case basis, particularly when you cannot exclude hypersensitivity pneumonitis. Oxygen supplementation, we know we try everything from nasal cannula to mask, bag mask, venturi, and then HFNO. HFNO, there was some concern about the spreading infection in corona pandemic. The initial reports actually came from Wuhan, but later is that we diagnosed that carefully applied HFNO is really a good tool. And again, comparable to NIV, no differences in the rate of intubation and escalation of respiratory support. And NIV also, we call one thing called NIV responsiveness. That means NIV responsiveness associated with less severe disease presentation and early NIV initiation. And NIV in one study showed to improve oxygenation in patients with pneumonia, but not in those without pneumonia, only acute exacerbation. Debatable, this. IMB is something, invasive mechanical ventilation is something like a fast bowler. We don't like it, but we have to face it. Fortunately, the prognosis has improved over the years, say from 2000 to 2020. So IMB is a difficult tool to handle, but the prognosis has been improving over the years because of our concept and understanding of the pathogenesis. We know that use of recruitment maneuvers and applications of high PEEP cannot be applied to the stiff lung and not to do the over distension of alveoli. So taken all together, we don't like it, but we have to take recourse sometimes in a desperate condition. Preventive strategies. These two new drugs are doing the rounds. Pirfenidone in a meta-analysis of 5 trials, and also nintedanib. Even nintedanib has been tried in acute exacerbation of IPF. Other potential preventive measures should not be overlooked. Timely influenza pneumococcal vaccination, ILD and IPF cases, and again, as we have stressed now, hand washing, avoidance of sick contacts, and avoidance of airborne irritants and pollution. Different drugs used for preventive measures, different trials for nintedanib and pirfenidone. But again, there is a problem there. Most of them are sponsored trials. A little about this, because we knew that microaspiration is one of the precipitating factors. So anti-reflux therapy has a role there. But again, antiacid treatment may increase the risk of infection. So a balanced view, if the patient is already on antacid, we do not stop it, and we give the preventive stress ulcer prophylaxis in all patients.
We are running.
Slide. Okay. This is the last slide. So, is there a take-home message there? Taking everything together, in AILD, there is still a pattern in the wilderness. Better stick to a protocol. There should be a ready-made protocol for dealing these cases. Rule out triggers, particularly infection first, and then consider immunosuppression, say with pulse steroids. And prognosis is very much related to the management. So may salvage a lot from the ruins. Thank you all for your time.
Thank you very much, Professor Ghoshal. Thank you.
Thank you, sir.
Okay, am I delaying, Sandeep?
No, sir. No, sir. Okay.
No, I tell you, we had some.
So please carry on. Please carry on.
No, I am his chair.
Yes.
So he has to go again. I am the chair. Okay, Sandeep, please.
Yes, sir.
Sir, our next topic is challenges in liver transplantation in Era, and the moderator is our beloved Dr. Along with Dr. Indrajit Tiwari, Dr. Ramdeep, Dr. Sumit Gulati, and Dr. Vikas Prakash. Sir, this dais is yours.
Thank you, Ashraf. I'm audible?
Yes, sir.
Okay. First, let me thank Asif and Dr. Ashok Sengupta for involving us. We are not really a cream of pulmonology or ICU for involving us for this panel discussion. What I promise to you is that we will save 5 minutes from your delayed program, and we'll finish it in 15 minutes. Very crisp discussion. You have already introduced the participants, but let me just quickly run through. We have Dr. Ramdeep Roy and Dr. Sumit Gulati, who are our liver transplant surgeons, and they are doing excellent work. Recently joined back to Calcutta and to Apollo Clinicals Hospital. I have Dr. Indrajit Tiwari, who is like my younger brother, and he has been working with me for more than a decade now. He is possibly the only qualified GI intensivist in the town. He has been managing our ITU and SDU for a very, very long time and very efficiently. And we have Dr. Vikas Prakash, who is one of the rare species of a hepatologist.
340 you said was my talk.
Who has done his DM from ILBS. I promise you, Dr. Asif will finish in 15 minutes.
This session has just started, so I think it'll go on for another half an hour.
Let me set the ball rolling. We are in a very difficult time of COVID, but the program of liver transplant has to go on. And my first question is to Dr. Sumit Gulati, that we all are aware of the indications of doing liver transplant, whether it's a cadaver transplant or life-related transplant, whether it's acute liver disease, whether it's a chronic liver disease, cirrhosis, or liver cancer. But do you think in this COVID era, we have to change the indication? Do we need to wait in some cases for more time, or you think that we should go with whatever the textbook teaching has been? Dr. Sumit.
Yeah, thank you for having me over here in this panel discussion. What is important in COVID time is that what we need to remember is liver transplant requires a huge resource not only in terms of equipment, ICU, manpower, but also the number of people involved in COVID, the healthcare workers, doctors, nurses, paramedical staff. So there is a risk of these people getting COVID. We have to remember this. Second is the liver transplant recipient. If he gets COVID during or after the transplant, what is going to be the outcome? And the donor, whether it's a living donor or cadaveric. So cadaveric is okay, but for living donor, if a healthy person gets COVID during the transplantation, what is the impact of this? These are the three things which we need to keep in mind when we are thinking of doing a liver transplant in patients of CLD or acute liver failure. But at the same time, the risk of not doing the liver transplant, the risk of mortality or losing this patient because of the fear of COVID is much more, especially in patients who have got acute liver failure, not responding to the medical therapy, or a chronic liver disease patient who have developed an acute failure. In these patients, I still think that what is the recommendation worldwide is that we go ahead with the transplantation, keeping in mind whatever the safety protocols are required for COVID. And patient with hepatocellular carcinoma, especially the size is more than 2 centimeters, recommendation is that you continue the standard therapy. You don't change the therapy because of the COVID time, because of the metastatic potential of SCC. And depending on the donor, if the donor is a cadaveric, then if the cadaver is COVID negative, we can harvest that organ. And if the donor is a living donor, in that the donor has to be tested for COVID just before the hospitalization. And if possible, the donor should be in quarantine for 2 weeks before we are planning for transplantation.
So I think very important points raised by Dr. Gulati. If I can summarize what Sumit is trying to say is that even in the COVID area, the indication for transplant in acute liver failure does not change. It doesn't change much for SCC, but maybe for chronic liver disease, you can wait for some time, go with the stabilizing with the medical treatment, because as he rightly pointed out, it's a huge risk involved for both donor recipient and for the people taking care of it. Dr. Sumit, you have anything else to add, or should I go on to the next question?
Please go to the next question.
So next question is to Indrajit. I think Indrajit, we have done about 4 cases of liver transplant in this COVID era. Now, can you summarize for us what are the safety measures which we need to take for the donor and the recipient, as well as for the staff, knowing it very well that the vaccination has started only recently? So how do we test them? How do we prepare the team for that? So can you dwell on this? Please, let's not talk about the vaccines. We'll talk a little later. But short of vaccine, what are the precautions you would take in your unit?
Yes, sir. It is very important to look up to the matter in this COVID era, because there is no specific guideline available to protocolize the thing. Only guideline available is from India. It is the Liver Transplant Society of India. They have published the guideline in the month of March. But at that time, scenario is different. Now it is different. Since we have done the 4 transplant in this COVID era, including 1 DDLT and 3 LDLT, in that, what we have protocolized, basically based upon the study available from China and few papers from the Europe and America. So according to that, we have to divide into 3 groups. One is the recipient safety, one is the donor, and third is the professional safety, doctors and other staffs available. So for the recipient safety, what we do, we try on admission, we try to isolate the patient, minimize the visitors, and allocate the staff who are either tested COVID negative or who has developed COVID antibody. This is the usual protocol on admission we follow with the recipient. But we have to keep in mind, since in CLD per se is a immunocompromised state, so viral load is very high, even in asymptomatic patient, and since sensitivity is almost 70%, a 30% chance your patient may be carrier and high viral load. With this high viral load, that can infect a lot of professionals or healthcare giver as well. So that is the one important point. Second, for the donor part, donor may be a symptomatic carrier, even false negative COVID patient. So that is a vulnerable chance that the patient may transmit this, donor may transmit, may give the virus to the recipient. So that is the one aspect we have to, because apart from the aerosol generation, we don't know the exact other mode of transmission from the donor. So in that
So
point of
Indrajit,
view,
if I can interrupt you, we know that PCR can be false negative in about 30%. So do you think in a donor in this situation, you should test them more than once?
if any symptoms is there, definitely we have to test twice. But if a patient is clinically asymptomatic, usually we do the once. But if any query or doubt, we should usually test twice. Be sure that it is not COVID positive. And third part, what we are discussing about the professionals. So what we do before the transplant and during the transplant, we try to give all those staffs who are have IgG positive or being tested negative, all the doctors, assistant, and other technician in the OT theater. Also, usually we test for the COVID test, and in the post-operative care unit, we adhere for the PP protocol. PP protocol is mandatory and very much scrutinized. And staff pattern, as I have discussed, usually follow in that pattern.
So Indrajit, what would be the right time to test these individuals for PCR, the healthcare workers who are going to be involved in the transplant? The same day morning, or will you do it one day before or any day in the last 5 days?
No, sir. It is, if you have tested within 3 days, that is validated. Anything more than 5 days, we have to repeat the test. And as sooner the transplant timing, it is better.
So I would just tell you, the people who are listening to us, that when we did our first transplant in this COVID time, we had to do about 100 healthcare workers were tested for PCR before we could organize the transplant. So it's a big issue. At that time, in April and May, doing a PCR was a much bigger issue than what it is today. Today, it's much less costly and easier to do, but it was a huge exercise in the first transplant. Thank you, Indrajit, for clarifying that. Ramdeep, we have in Apollo itself, as we just discussed, have done 4 transplants, and you have been involved with 3 of them at least completely. So is there a difference in the strategy while you are operating on them or in the post-operative period, particularly because in the post-operative period, again, there'll be physiotherapists who are going to come, ultrasound machine is going to come, Doppler is to be done every day. So is there any change of strategy from the surgical or the post-surgical aspect? Ramdeep?
Thank you very much for having me here. And as we all have been emphasizing, there are a plethora of unknowns in the equation of CLD, transplant, donor, recipient, COVID vaccine. And initially there was a knee-jerk reaction, and we were erring on the side of caution. We were practicing over caution in most cases, as you gave the example of 100 health workers being tested for PCR. So we had to do those things. But essentially, initially, once we started the transplants in the middle of after the ease down started, we were being more careful. So universal protection is mandatory in all cases of transplant to protect the healthcare workers. And that by itself means that the healthcare workers do not infect the patients as well. Only thing was new to us was the aerosol, so generating procedures. We were initially very careful about use of diathermy energy sources, and we would use the suction very close to the diathermy. There has been no really reported data to support all that, but we were careful on that front. With time, I think the basic surgical principles remain the same. Nothing really has changed, except, yes, we would not go in for a transplant without testing the donor, without testing the recipient, without testing the person, the family member who might be staying in the post-op period after a few days once out of the ICU. The biggest concern remains the people who work very closely, and closely are not the doctors, but closely are the nurses and the physiotherapists. And we would at least clinically keep monitoring them. They have been vaccinated now, but clinically we would monitor them. But surgically, really speaking, I think there is very little change in the strategy that has been followed.
That's very reassuring, Ramdeep, that we do not need to change our strategy for the surgical and the post-surgical thing. We need to follow the general principles of protection. Now, my next question is to Dr. Vikas Prakash. As a hepatologist, we know that all these patients require immunosuppression, and this includes steroids often in very high dose, sometimes pulse therapy, as well as other immunosuppressants. We also know that these immunosuppressants may increase the risk of having COVID as well as the severity of COVID. So is there any take home for changed protocol in the present time for immunosuppression post-transplant in this COVID era? Vikas, you need to be brief. We need to wind up soon.
Good afternoon, sir. The major guidelines come from the American Transplant Society. Other transplant societies still are clueless, and they are based on their judgment, based on the outcomes of patients in Italy, Spain, States, and China. So there should not be any anticipatory or prophylactic change in the immunosuppression regimen which we are following. That is definite. This finding is based on the previous pandemic of SARS in 2003, MERS in 2012, which has said that these viruses don't increase the severity of disease in our patients. They just make them more prolonged infections, and they just act like super spreaders, and they have a more viremia is more in these patients. The suppression regimen should not change. Of course, if the patient is very sick, if the patient is in ICU, case-to-case patient basis, the immunosuppression can change. If the patient is having, even in patients who are having autoimmune hepatitis and having a transplant, and if patients with rejection, they should be closely monitored, but the immunosuppression regimen doesn't change. Only one study of 112 patients from Spain, they saw use of antimetabolites immunosuppression, likely a mycophenolate methylphenidate. If it is using more than 1000 milligram, there was increased mortality event, but this was only in this 112 patients. Of the 111 patients in Italy and China, there was absolutely no difference. Even in our country, there was a recent publication just 20 days back from AIT Hyderabad of 6 transplant patients. They were given full immunosuppression without any change and without any increase in mortality. So there is absolutely no change as of now.
So I think it's a very important message, Vikas. When we started knowing about this virus in March and April, there was an IBD collection of data in inflammatory bowel disease, and that was calculated that anybody who is on more than 20 milligram of prednisolone, there's a high risk of having COVID and having a severe COVID. So I think over a period of time, we have learned that you just need to be very careful, but you don't need to change your strategies for immunosuppression. And you were talking about AIG 6 and I think even in our own setup, in all the 4 cases, we have not modified immunosuppression. In fact, we were very active. One of them had a rejection, and we gave very high dose of methylprednisolone to control the rejection, and we could control the rejection with high dose of methylprednisolone without any problem. My last question is to Indrajit, and I think this is a very, very pertinent question, and I know that this question is a little open, that we do not have much knowledge about it, that what should be the strategy for vaccination of these patients before transplant and after transplant, as well as the vaccination of healthcare workers.
Yes,
I can
sir,
see that all five of us have received the first dose of vaccine, but not everybody is fortunate. So what should be the protocol for getting the vaccine? Essence Singh, just wait. Dr. Singh, you need to wait for 5 more minutes. I know you are getting bored with our topic.
Yes, sir. For the liver transplant recipient and donor, there are 2 guidelines available. One is the British Society of Gastroenterology and BLS. They have published in December, although they do not have the data to suggest, but considering the immunogenicity and available vaccine, whatever available, they recommend you take whatever available. That is in the British Society of Gastroenterology. Whatever the vaccine at that time, basically in Europe and in America, there are messenger RNA related vaccine, that is Moderna and Pfizer. These 2 were available, so they recommend they can take it. Timing, they said ideally it should be given 1 week before or 1 to 6 months after the transplant. That is, they recommend according to the other vaccine given to the transplant patient. According to that, because they don't have the data to prove or no study available. From the Indian pertinent, whatever we have available is the Covishield and Covaxin. It is basically one is vector mediated, one is recombinant. So either of the vaccine is according to that guideline. If AST guideline also suggesting in the same way, either of the vaccine is safe. Only two things has to be keep in mind. One, the antibody formation is expected to be low and it delayed. So any vaccination, if you think that it will cover you, it is after second dose, 7 days after the second dose. That means almost 35 days from the first dose. After that, you can expect the full protection. For the messenger RNA, that is Moderna, they are suggesting that it is 94% effectivity, but they are suspecting it is being less in case of this compromised patient.
So thank you, Indrajit. I'll just like to point out that we have started a study in our own department, and we are going to test 2,000 Apollo individuals, Apollo healthcare workers, doctors, nurses, technicians, executive. We are doing their baseline titer, and we'll be doing one titer just before the second injection, and then third antibody testing 1 month after the second injection, and then after 5 months of second injection. So we'll have some of the answers will come out from this study, which have been planned well and has been approved, and we are already started conducting it. I think I got a few antibody tested after 2 weeks of the first, and most of us are becoming positive of antibody. So I think the message is that the vaccine which is available with us, and we have all been given Covishield, is possibly working. On that note, any final comment from any of the panelists, Ramdeep, Sumit, Vikash, or Indrajit, before I wind up? And I must get a chocolate from Asif for finishing before time.
Only thing, surgical tactic, that is robotic donor hepatectomy, they are not preferring. So that is the only modification they have done in the COVID time.
Ramdeep, any comment on that? You are muted. You are muted. You are muted.
I am not sure about the data on that, but yes, hepatectomy does lead to immunosuppression. Whether that is the concern or the extent of the personnel involved and all that, I really don't know.
That is robotic liver donor hepatectomy. Because of the leakage of the gases and aerosol generation, they are not advocating. I don't know what the data is.
So laparoscopy as such, because that would be the main reason of the aerosolization, that can be a concern. But initially laparoscopic surgery was avoided. But yes, such a prolonged surgery can be an issue, definitely.
So thank you very much, all the four panelists. I think we had very little time, but we could carry some take-home messages. Again, thank Dr. Ashok Sengupta and Dr. Asif Iqbal for involving us, not really a hardcore intensivist or pulmonologist, except for Indrajit Tiwari in this discussion. Thank you very much.
Thank you.
Thank you, sir. Thank you for the wonderful session. So we'll move to our next session, that is phenotype and management of the COPD. And the speaker is Dr. Sandeep Salvi, sir, and the chairperson is Dr. A.G. Ghosal, sir. So, Dr. Salvi, the session is yours.
Sandeep, let me just thank you for being there, and we will continue now. Thank you.
Okay, Sandeep, please. No wasting time.
Sir, you are mute.
Can you hear me? Yeah, can you hear me now?
Yes, sir. Yes, sir.
Okay. Perhaps the very first description of something that sounded like what we today call COPD was first found by Dr. Theophil Bonnet in 1670. And he was able to show in autopsy specimens of human beings that there is a condition where the lungs become big in size and they do not collapse very easily. Something that we would now accredit that to underlying emphysema. There was no name given at that point of time, But that was perhaps the very first time a description of what we now call COPD was made. It was then subsequently later on in 1793 when Matthew Bailey, for the first time, apart from looking at the histopathology, looking at the autopsy specimens, also performed histopathology on these lungs, and he was able to show for the first time on histopathological examination that there is a presence of damage and destruction of these alveoli that are very classical of this disease, which today we would still call it as emphysema. Even at that point of time, there was no name that was given to this disease. In 1814, Charles Benham from the UK gave a very clinical lung disease that was associated with excessive mucus production, cough with excessive mucus production. And he called it as catarrh, which was subsequently replaced with the word chronic bronchitis. So our first introduction to what we today call as COPD was based on autopsy specimens of what the lungs look like, and then a clinical presentation by Charles Benham. Later on in 1821, when René Laennec discovered the stethoscope, he also described clinical presentations of what today we would call as emphysema. And he was perhaps the first one to suggest that in this lung disease, there is not only damage and destruction of the alveoli and the alveolar walls, but also presence of inflammation in the bronchi. So there is some element of airway disease as well as some element of parenchymal disease. And for a very long period of time since Laennec's period, there were two names that were actually given to this disease. The British, who were led by Dr. Charles Fletcher, called this disease as chronic bronchitis, and the Americans, who were led by Dr. Burroughs, called this disease as emphysema. And as we all know that the British and the Americans, they never get along well with anything in life, so they refused to accept each other's name for this chronic lung disease. So the British said, we will continue calling this as chronic bronchitis, and the Americans said, we would continue calling this as emphysema. At around that time, in the 1960s, Frank Netter, who was a surgeon and a medical illustrator, put some beautiful images of the human body and the diseases that are associated with it. So the Siba Gaigi collection of medical illustrations shows these two phenotypes of COPD. Very classical description. You can see visually both of the patients of COPD look very different. The one on the left, called as pink puffer, is the one that is associated with what we would today call emphysema. And the one on the right, whose skin looks blue in color, has got a handkerchief in his hand because he's coughing up phlegm, is called as a blue bloater phenotype of COPD. And so these were the very classical descriptions. The pink puffer were the American emphysema, and the blue bloaters were the British chronic bronchitis. And from until the year 1965, there were so many names that were associated with this disease, like emphysema, bronchitis, chronic obstructive lung disease, chronic obstructive bronchopulmonary disease, chronic obstructive airway disease, and so on. Now, because of the fight between the Americans and the British, the disease suffered a lot. Because what do you call this disease? If I read an American book, I would call it as emphysema. If I read a British book, then I would call the same disease as chronic bronchitis. And as a result, the disease was suffering a lot. So in 1965, at the 9th Aspen Lung Conference, a very wise American doctor called William Briscoe brought all the Britishers and the Americans together and said, look here guys, the disease is suffering because you are refusing to budge and because you are also refusing to budge. So let us come to a common consensus and give it one name. Rather than have two different names for the same disease, let us give one name. And that was in 1965 that the term COPD, or chronic obstructive pulmonary disease, was coined, because there were two distinct phenotypes at around that time. So look at this, very interesting, isn't it? COPD is a very new term that was introduced only in 1965. This is how the healthy lung looks like. This is how a COPD lung looks like. There is damage and destruction of the small airways as well as of lung parenchyma. And just to show that very visually, I have drawn the same bronchial tree with the airway branching pattern and the alveoli in pink colors over here, just to make you feel how a normal healthy lung looks like. In COPD, the alveoli are replaced with black colored lung parenchymal tissue, and the total number of small airways they disappear. So it's a very classical description. There is a damage to the airways, and there is also damage to the lung parenchyma or the alveoli. Now, the reason why I'm coming back to this two phenotypes of the pink puffers and the blue bloaters is I think there now seems to be a resurgence into these two different phenotypes of COPD. We know that the blue bloater over here, as you can see here, compared to my previous figure, this is a person who has predominant disease of the airways, what we would call as pure chronic bronchitis. And then the pink puffer is the one who has damage and destruction of the alveoli over here, what we would call as pure emphysema. Now, it is important to know these two different phenotypes because the pharmacotherapy now seems to be getting changed. So, for example, for chronic bronchitis, the airway predominant type of COPD, the drugs that seem to work well is a combination of inhaled corticosteroid and a long-acting beta agonist, or the triple drug combination of ICS, LABA, and LAMA. In contrast to that, the drugs that work very well in the emphysema pattern or the emphysema phenotype of COPD is a dual bronchodilator therapy of long-acting beta agonist and a long-acting muscarinic antagonist. And I think that is a fundamental difference in pharmacotherapy between the chronic bronchitis phenotype and the pure emphysema phenotype. Pure emphysema, you would predominantly give them bronchodilators. Pure chronic bronchitis, you would give them a combination of ICS plus LABA. For a very long period of time, at least 40 years, the cause of COPD was believed to be only tobacco smoking. And perhaps many of you may not know that it was only in the 1970s that we understood that COPD was caused by tobacco smoking. Before that, nobody knew what was causing COPD. And it was these two great people from the UK, Charles Fletcher and Richard Peto, who actually, for the first time, showed that COPD is a disease that is caused by tobacco smoking. And for 40 years, COPD was believed to be a smoker's lung, nothing else. Until in 2009, when we were able to show that there is something called as non-smoking COPD. And you can see over here, if you can see quite well, the different colors of the countries, they represent the different economic wealth. So the sky blue colored countries, like you can see the United States or the European countries, are the ones that are rich countries. The red colored countries are the ones that are low socio-demographic index or the poor countries. India, which is in green color, is the middle socio-demographic index countries. Now, the reason why I'm showing you this is the latest global burden of disease report that showed us the prevalence of COPD and the risk factors associated with it makes a very, very interesting observation. In the high socio-demographic index countries, COPD is predominantly caused by tobacco smoking. And as you go to the right, to the poorer countries, the contribution of tobacco smoking becomes less and less and less and less. And then the non-smoking risk factors become more common. Globally now, non-smoking COPD accounts for 65% of all the COPD cases, whereas in India, it is about 70 to 80% of all COPD that is accounted for by non-smoking COPD. Now, again, you've got two phenotypes, tobacco smoking COPD and non-smoking COPD. And these were the articles that we wrote in 2009 for the first time, highlighting the fact that you don't need to be a smoker to have COPD, and that other risk factors are perhaps more important than tobacco smoke. And then these are the images of the non-smoking risk factors, other than the one that you can see here, which is body smoking, exposure to biomass fuel smoke, ambient air pollution from motor vehicles, occupational exposures during farming, road sweeping, building and construction, indoor air pollution due to the use of mosquito coil or dhupa garbatti, or the incense, previously diagnosed cases of tuberculosis, now developing COPD. This unique phenotype is now called as TOPD or TB-associated COPD. Chronic asthma that is poorly treated very poorly treated, can get converted into a COPD phenotype. So this is poor asthma treated COPD phenotype. And then other occupational exposures like temple pujaris who are exposed to smoke on a continual basis. So this, I believe, seems to be the new classification of COPD. Not tobacco smoking COPD now is on the top because it affects more number of people in the world as compared to tobacco smoking COPD. Even within tobacco smoking COPD, we have a different varieties of tobacco smokers. So cigarette smokers, bidi smokers, hookah smokers, and others. And it is likely that each one of this may have a unique different phenotype of COPD. When you look at the non-tobacco smoking COPD, you have the exposure to other noxious stimuli, like tobacco smoke exposure. This is household air pollution, ambient air pollution, or occupational exposures. And then no exposure to noxious stimuli, such as poor lung growth during childhood, recurrent respiratory tract infections during childhood, previous history of tuberculosis, or previous history of asthma that is poorly treated. They all become risk factors for COPD. We compared the phenotypic differences between smoker COPD and non-smoker COPD in a very large population here in Pune. The blues are the healthy individuals, red are the tobacco smoke COPD, and the green are the non-smoking COPD. Now, this is comparison made using spirometry. So if you look at FEV1 or FVC, well, not much change other than a slight decrease in FVC in the non-smoking COPD population compared to the smoking COPD population. This is all corrected for age, gender, height, and everything. And perhaps a trend towards a smaller FPF 25 to 75 in non-smoking COPD. When we look at airway resistance using body plethysmography and impulse oscillometry, then we start seeing some differences over here. So there seems to be more using body plethysmography and impulse oscillometry, then we start seeing some differences over here. So there seems to be more small airways obstruction in non-smoking COPD phenotype than the tobacco smoking COPD phenotype. Very beautifully seen in this last graph over here between as measured impulse oscillometry. When we look at impulse oscillometry parameters, you see nice distinct differences between tobacco smoke COPD and biomass smoke COPD. What is the message that is coming out? Non-smoking COPD is predominantly small airways obstruction. There is more small airways obstruction in non-smoking COPD than in smoking COPD. When we look at DLCO values, to look at the emphysema component, you can see that there is lesser amount of emphysema in the non-smoking COPD as compared to the smoking COPD. The smoker COPD have got higher prevalence of reduction in lung diffusion as compared to non-smoking COPD. And then these are the high resolution CT images. These are beautiful that shows. So the purple color over here, now this is smoker COPD on the left, non-smoker COPD on the right. Purple color represents emphysematous pattern on the HRCT. And compare that with smoker COPD versus non-smoker COPD. Interstitial lung disease pattern, which we know occurs commonly in smoker COPD. Look at the differences between that, between smoker COPD and non-smoker COPD. And the dark violet over here is airway predominant pattern, which is actually more prevalent in the non-smoking COPD. So just to summarize, more emphysema in the smoking COPD compared to the non-smoking COPD, and more small is obstruction in the non-smoking COPD as compared to the smoking COPD. When we look at the induced sputum and quantified the inflammatory cells in the sputum, you can see that the eosinophil numbers are really greater in the non-smoking COPD compared to the smoking COPD. To suggest that if there are more eosinophils in the non-smoking COPD, this phenotype of COPD is more likely to inhaled corticosteroids. And this is perhaps exactly what we found. This was an open label study by supported by CIPLA, 10 multi-centers across the country, 10 centers. Patients of COPD, when they were diagnosed, they were put on a triple drug combination of tiotropium, formoterol, and cyclosinide, either given by a DPA or an MDI. The treatment duration was for 24 weeks. And these were the ways in which we looked at the efficacy of the treatments: spirometry, the MMRC, CAT scores, and the frequency of exacerbations. We found a fantastic improvement in FEV1 values in the COPD population after treating them with a triple drug. The quality of life significantly improved as measured by the CAT score. But there's something very unique in this. When we segregated that COPD population into smokers, which is in green, and the non-smokers, which is in blue, and then look at the improvement in FEV1 over 24 weeks, you can see that the improvement that occurred in the smoking COPD was about 200 ml or 0.2 liters, but the improvement that occurred in the non-smoking COPD was almost 1 liter of improvement in FEV1 over a period of 24 weeks. Now, what does this tell me? That non-smoking COPD are perhaps have greater improvements in lung function, and that is likely because of the inhaled corticosteroid. And this is the last slide that I just wanted to share with you what I see as the future of COPD management, depending on individual phenotype. So here is a doctor who is asking the patient, Mr. Rao, what bothers you about your COPD the most? And if the patient says, Mr. Rao says, I do not want to die soon, then that is a phenotype for me. And I would treat this patient specifically with long-term oxygen and pulmonary rehabilitation, because these are the two interventions that have been shown to improve survival in patients of COPD. Pharmacotherapy forms the base for all this. If the patient says, doctor, my cough and phlegm are bothering me more than anything, I'm bringing up a lot of phlegm, please help me with that. For me, that is another phenotype. The way I would treat this patient is essentially with long-acting bronchodilators and acetylcysteine for dual roles, the antioxidant properties as well as mucolytic properties, and use of roflumilast, which is a phosphodiesterase enzyme inhibitor, specifically shown to work in the chronic bronchitis phenotype of COPD. So if these are the symptoms, if this is what the patient complains of, this is how I would treat the patient. If the patient says, doctor, I feel very short of breath and find it difficult to breathe at times, my main problem is breath. I'm not of breath for me. For me, that is another phenotype. The way I would treat this patient is I would give them maximum bronchodilation that is possible. Lama in the best possible way, and perhaps even add a little bit of theophylline with the hope that it would have some additional benefit and also improve diaphragmatic. The patient says, doctor, I want to go back. Please do something to prevent my subsequent exacerbation. Maybe this is a patient who has got recurrent COPD exacerbation, and maybe this is one phenotype of COPD that needs a separate treatment. What is the treatment for this patient? Vaccination. There are 3 vaccines that we need to give nowadays: influenza vaccine, pneumococcal vaccine, and the Gold 2021 guidelines have now recommended the diphtheria, pertussis, and tetanus vaccine as well in patients of COPD. So the 3 vaccines have to be given. N-acetylcysteine has been shown to reduce COPD exacerbations. So that would form an important pharmacotherapy. Inhaled corticosteroids, they have been shown to reduce subsequent COPD exacerbations, and obviously rehabilitation. So this is how I would treat my patient. The patient says, doctor, my cardiologist tells me that my COPD is responsible for the heart failure, and this is worrying me. Make sure that you do not stop the bronchodilators. Okay? Give them bronchodilators, but also give them beta blockers, cardioselective beta blockers. It's very interesting. You're giving two opposite drugs, giving a beta and you're giving a beta at the same time. Beta stimulant is by the aerosol route, beta blocker is by the oral route, but a cardioselective beta blocker. Remember that if your patient of COPD has a comorbid heart disease, whether it's ischemic heart disease or cardiac failure, congestive heart failure, do not deny them a beta blocker. That is the best drug that is going to improve the chances of their survival. So that becomes a different phenotype for me. And then finally, the patient says, doctor, my desire is only to drop my grandson to the bus stop and come back. I want to now pack my bags and I'm ready to die. Pharmacotherapy, pulmonary rehabilitation, counseling, other things that I would consider in this patient. So you see how the patient decides what treatment I should use for my COPD. So I think description of phenotypes of COPD. I believe that the future is going to be individual. Kaushal sir. Absolutely, sir. Yes, sir.
Okay. Sandeep, one question. If the patient is perfectly fine on triple therapy and has no exacerbation for the last 1 year, and he's on triple therapy and is very happy, would you, no pneumonia, nothing, would you withdraw the steroid, inhaled steroids?
Well, if the patient is happy with no exacerbations in the last 1 year, I would be happy to continue with the triple drug combination. I would remove the steroids only if I have a worry, if I have a fear that the patient is having pneumonias now more frequently than earlier. That is the only time when I would withdraw the steroids.
But again, Subhasis and Sandeep, probably here, not the patient, the doctor is happy. I would even to withdraw corticosteroids if for 1 year the patient is completely controlled. I will try at least withdraw the corticosteroid.
Okay.
ऑनलाइन है सर 20 मिनट का लेट चल रहा है
Sir, Dr. Kaushal, any other questions? If not, then so thank you very much for chairing my session. And I enjoyed this talk.
Thank you, Alokda, and it was thanks, Sandeep.
Thank
Sorry
you.
for slight delay.
Thanks everybody and thanks Sandeep.
Thank you, sir. Thank you very much, sir. Thank you, Dr. Ghosh. Thank you, Dr. Asif.
So we have to move the next session. Next session is traumatic brain injury. I welcome Dr. Arijit Bose. He's a head of emergency medicine, Apollo Clinical Hospital. He's moderator of this session. And I will welcome Dr. S.N. Singh. He's a HOD surgery in the department in the Apollo Clinical Hospital. And Dr. Oren Banerjee is chief intensivist in Nutia Hospital. And Dr. Kopil Jipre sir is a director critical care in Ruby Hall, Pune. And Dr. Bibhu Kollani Das, he's a intensivist in in charge of pain medicine in Institute of Neuroscience, Kolkata. Arijit Bose, sir, this session is yours. Dr. Bose. Dr. Bose.
Can't see a moderator online.
Asif? Dr. Asif?
Sir, the session has
Mad-
already started.
Madam, not sir.
Where are
Asif?
you?
Asif? Asif? Do you hear me?
Yes, ma'am. Yes, ma'am.
So you introduced me as pain medicine and anesthetist. You forgot about it. You are the
No,
student
sir.
of anesthesia under me. Huh?
No, ma'am.
How you forgot that? I'm checking this. I'm the director of anesthesia also here.
Yes, sir.
9K.
Yes, ma'am. Sorry,
As an
ma'am.
academic director, you must properly
Sorry, ma'am.
introduce. Huh?
Where
I
is
can't see
Arijit Bose?
moderator is not online.
It's already so late. Then I'll ask that I'll be excused. Kapil is there, he will manage.
Good evening, madam. Welcome to all the
Good evening.
panelists.
Yeah.
Good afternoon.
He's online.
Good afternoon.
Dr. Bose.
Yes.
So you start.
Good afternoon to all the panelists. Now, today the discussion is on traumatic brain injury. I will start with the scenario. A 65-year-old lady has been brought to the emergency room when she was hit by a car when she was crossing the road. After the accident, she lost consciousness and an ambulance was called which rushed her to the hospital. In the emergency room, she was unconscious and her Glasgow coma score was 9. Pupils were bilaterally equal and reacting to light. Heart rate is 112, BP 108/66, respiratory rate of 22, and a saturation of 91%, which went up to 98% on 2 liters of oxygen. I would like to invite Dr. SNC, who is a senior consultant neurosurgeon, to enlighten us about what he would focus on in the golden hour of the management of this patient regarding the traumatic brain injury.
Yeah, as you have already narrated the history of the patient, she is unconscious with GCS of 9, and pupils are well reacting on the both sides with a normal size. So first thing after the resuscitation is the patient. I think you have not intubated the patient, right?
No, patient has not yet been intubated.
Not intubated. So if the respiratory distress is not there, you must get a CT scan first, and based on the CT scan finding, we definitely decide the further mode of treatment. So it is the CT scan. Definitely after the CT scan, we can decide what kind of treatment the patient receives, what kind of injuries he has sustained, whether it is the diffuse kind of injury or any intracranial hematoma, whether it is subdural, extradural, or ICH. So the treatment decides after the CT scan, and then after the CT scan, we decide the further mode of treatment.
Okay. Now, upon further resuscitation, his GCS drops to 7, and it has been decided to patient.
Yes. There is a drop in GCS, but is there any change, any focal deficit or pupillary change in the patient? What was the pupillary
The right
change?
pupil is slightly more dilated than the left.
So you definitely suspect some kind of hematoma inside the brain, whether it is an extradural. Old lady, we always suspect some kind of acute subdural hematoma. So after resuscitation and putting her on the ventilator, we, as soon as possible, we do the CT scan, and after the CT scan, we know what to do next.
Okay. So I would now move on to Dr. Vibhu Kollani Das. How would you proceed to do rapid sequence induction and intubation of this patient?
Okay. So rapid sequence intubation is very important here because the patient had a road traffic accident. So we should exclude any cervical injury there. So unless it is proved, then you always, if the patient is having a Glasgow coma scale of 9, you said, no? So, hello?
Hello?
Coma scale is 9 and the respiratory rate is more, and we always give precaution in this COVID era. We have to take precautions to intubate the patient. I think we must intubate the patient, and the rapid sequence intubation now we can use if the patient is not hypertensive, then we can go for ketamine. Ketamine is now very well accepted. Previously in 1970s, we have to have ketamine is will increase the ICP and is not contraindicated in head injury. Nowadays, we can use ketamine and we can go for rapid sequence intubation with cisatracurium or atracurium. If there is no history of any convulsion, we can take the history of convulsion, all these things. So with all precautions, the nebulization should be avoided, pre-oxygenation for 5 minutes with only bag and mask, not any high flow, and then go for rapid sequence. It should be done by very good hand, expert hand, the rapid sequence intubation with analgesics and this induction agent, whatever. If the patient is hypertensive, then you can go for etomidate. Etomidate is the ideal induction agent in that case. So the rapid sequence intubation can be done very rapidly and without the surge of ketamine is very helpful because in hypotensive patients, it helps in the hemodynamic stability and also it provides analgesia and it protects the brain. NMDA receptor antagonist, so protection of brain is there. So, and there is no effect on HR and MAP, and we must aim at a CPP, adequate cerebral perfusion, because brain damage is due to hypotension and hypoxia. So we have to avoid hypoxemia and hypotension. So in these cases, we should go for ketamine if not contraindicated.
Okay, thank you. In the further resuscitation of this patient, we use intravenous fluids. So I now invite Dr. Kapil Zilpe to enlighten us about the intravenous fluids that can be used in such a trauma patient with particular reference to traumatic brain injury.
Good evening and thanks for inviting me. Let me first go back to our emergency situation when patient was brought to the emergency department. I think it should be attended by the EMS person or the intensivist in a casualty to regarding the optimization of the patient. The first thing when any traumatic brain injury or any accident victim comes to the casualty, the alignment of the cervical spine and the stabilization of the cervical spine is the first thing to do. Then you will assess the airway, breathing, circulation in airway. Though your age is 65, it hit and run. There is an airway obstruction. Saturation was 91 on admission, and there was a GCS was 9. In view, I will be very optimistic before sending him to the CT scan. I agree. My colleague friend would like to go ahead with the CT scan, but before that, my personal or my concern with me is the airway obstruction, because most of the time in CT scan they may go ahead with the mild sedation and you landed with the airway obstruction and the arrest in the imaging. So in such borderline cases, I would prefer to intubate in a casualty only and send the patient to the CT scan. After the CT scan, what madam says is a perfect. Ketamine is a drug of choice because ketamine, there was a myth about the ketamine, it causes the rise in ICP. Nothing like that. Studies are now adequate evidence is available that ketamine is very safe and choice of the drug for the rapid sequence ventilation. Now regarding the fluids, if you see in 2002 meta-analysis, it was very clearly mentioned one of the predictors of mortality in a severely brain injured patient is the your fluid balance. So you need to have an adequate fluid balance, not the overload, neither the underload. Choice of the fluid should be the balanced fluid. Again, there is a you can go to the SMART study, or you can go to the SAFE study, where the 9% at the traumatic brain injury subset, where the mortality was almost 22% versus 32 in a colloid group. So colloids, no for the resuscitation. Crystalloids, yes. In crystalloids, again, normal saline versus balanced solution. Normal saline is known to cause the hyperchloremic acidosis, dropping pH, and your soda white carb index will be more. So in such cases, the choice of the fluid, now there are enough evidences available for the choice of the fluid is a crystalloid, and in crystalloid it should be the balanced fluid, balanced solution, and your target should be euvolemia. Neither the hypervolemia nor the hypovolemia is good for this thing. And please note down, in traumatic brain injury, there is no role of the permissive hypotension or something like that. You have to adequately this thing, because one of the predictors of mortality in traumatic brain injury is the mean arterial blood pressure less than 70. We cannot afford hypotension in traumatic brain injury. That's what I will say about the fluid management in traumatic brain injury. Thank you.
So, what mean arterial pressure would you aim at in 65, a traumatic brain injury?
65. It is now adequately studied. The 65 mean arterial pressure is more than enough. You should not target 85 or 100. So more than 65 to 85 is okay. Your target in traumatic brain injury is the 65 mean arterial blood pressure, ICP less than 25, and CPP less than 60. That's what the in between 60 to 70. That's what the targets for the fluid management in traumatic brain. And I told you, so when we chase the 85 mean arterial pressure, so naturally we'll overdo with the fluid management, and that itself is a itself will affect in an adverse way in a severe traumatic brain injury. We are talking about severe because his Glasgow Coma Scale dropped from 9 to 7. So now when you are talking about a severe traumatic brain injury, you have to be very careful with the fluid management choice, type, as well as your targets.
Thank you, sir. I would like to invite Dr. Oyan Banerjee to enlighten us about how he would proceed with osmotherapy in reducing the intracranial pressure of this patient, and also a few words on the role of anticonvulsant therapy in traumatic brain injury.
Good evening, and thanks for inviting me in this session. See, osmotherapy is one of the main cornerstones in managing ICP, raised ICP in a TBI patient. So, since 1960s, we have been using mannitol, which is most commonly used in the ICUs in emergency wards to manage ICP, raised ICP. And other agents which are available is hypertonic saline, which is also preferable nowadays. So mainly there are both has some pros and cons. In the Brain-Trauma Foundation guideline, in the 4th edition, there is no clear-cut preference over any of the preferred modality of the treatment. They have not advised any kind of preference. Either mannitol or hypertonic saline can be used. Mannitol problem is that mannitol is an osmotic diuretic, and there will be, if the patient, usually trauma patient comes with may come with blood loss and hypotension. So in this scenario, mannitol may cause more dehydration of the patient, which may again culminate into hypotension and less MAP and in less CPP. So it is better to avoid mannitol in this scenario. Rather, I would prefer hypertonic saline, 3% ACL, through a central venous line, if possible, for the osmotherapy.
Sorry, Dr. Aryan, I don't agree with you. We should have the either mannitol or this thing. Both are osmotic acid. So we cannot comment on the basis of the brain dehydration. We should mannitol because your GCS is rapidly dropping. It's from 9 to.
I'm just generalizing. I'm discussing with any general perspective, not
because the message should not go in either way. That hypertonic requires a lot of monitoring of the sodium, monitoring of the osmolality. If it is possible, then only you suggest. But I agree with you completely. The choice is now both, either hypertonic saline or mannitol. Okay, thank you, sir.
And regarding another thing was as requested by Dr. Bose, whether to give prophylactic anticonvulsant or not. In a severe traumatic brain injury patient, chances of early seizure is there, and in as per the recommendation, we can use phenytoin or levetiracetam system for controlling of early onset. That is, within 7 days, whatever seizure happens post-traumatic, that can be prevented by prophylactic anticonvulsant. But there is no role of prophylactic anticonvulsant for prevention of post-traumatic seizure which occurs after 7 days. So this is the current recommendation.
About hypertonic saline also, you have to be very cautious about the sodium. And you see, if the patient is dehydrated, then you have to see whether the sodium load is more or not, because it is the sodium load which causes your hyperosmolar therapy of the hypertonic saline. So sodium should be monitored.
How much time you take to infuse this 3% saline?
Again, there is no specific recommendation. It can be given in bolus. In most of the studies, there are many studies considering with 23.4% saline or 3% NaCl. There are many studies, but they have whatever they have used. It is mainly bolus doses, but we can use it in infusion also 1 ml per kg per hour dose with frequent sodium monitoring, 12-hourly or 6-hourly monitoring. The frequent monitoring of sodium is very much essential, and our aim should be not correcting sodium more than 6 to 8 milligram over 24 hours.
We are not correcting the sodium. We are using to decrease
Yeah, but the rise of sodium should not be more than 6 to 8 milligram over 24 hours. There is a specific guideline regarding how much sodium should be given over how much period of time. There is no specific recommendation.
Yeah. So, what is the difference between this mannitol? Both these drugs, mannitol and hypertonic, acts the same? Has got a effectivity is the same both the drugs? Because what I clinical practice, I guess the mannitol, if you give mannitol, the reduction of ICP is quite faster. Is it the same with the 3% normal saline?
It's very difficult to say. I have not come across any specific study to comparison both gradation of decrease in ICP comparing in comparison to mannitol versus 3% NaCl. But obviously we use mannitol frequently in ICU or neuro ICU regularly for routine purpose. But 3% NaCl can be used.
Yeah, it can be. Is there clear indication?
Dr. Singh,
yeah.
Dr. Singh, can I
Yes,
add something? Because
yes,
this
madam.
hypertonic saline, it takes some time to act. Unlike mannitol, it takes some time. I think begins within minutes, but it peaks between 15 to 120 minutes. So it will take time to have its effect.
That's what I'm talking about.
But the effect lingers.
Yeah, that's what I'm concerned about, madam, because the patient, suppose patient has started coding due to the raised ICP, at that point of time, the mannitol acts better than the 3% saline.
Yes, absolutely.
But in severe traumatic brain injury, where there may be the blood-brain barrier may not be intact, in that case, mannitol again cause rebound cerebral edema.
Yes, you have to evaluate the advantage and disadvantage. If the patient
that is always there, but rebound usually happens after 72 hours, not in the initial phase.
So if you have the patient is coning, then you should go for the mannitol, because you have to buy time, no? Because in first hours you cannot do hyperventilation or anything else, because it is the ischemic hour, past 24 hours. So you have to use the hyperosmolar solutions. So in that case, mannitol will be helpful. If the patient is in impending coning, you should go for that. I agree with Dr.
Yeah, in fact, madam, if it is patient has come to the emergency with signs of coding, we don't wait for the CT scan to be done, because we suppose something has happened. Either it is extradural, subdural, or ICH or diffuse injury. In all the cases, to buy time, we always give mannitol before the CT scan is done, so that we have some time. If it is extradural hematoma, it is not going to harm within next half an hour, 1 hour time. So we always prefer mannitol if the patient has signs of coding, like focal deficit or pupillary dilatation or GCS is dropping fast. So before CT scan also, we can, to buy time, we can give mannitol.
Okay, my next question to Dr. Zippe. What is the current status of targeted temperature management in severe head injury?
In one sentence, there is no role of the targeted temperature management in the head injury. There was a research trial, I think, in 2019. It's an early targeted therapy for the severe traumatic. It is negative. So there is no role of targeted temperature management in prognosis of severe traumatic brain injury.
Yeah, what do you mean by severe brain injury? It is a diffuse.
When we are talking about the traumatic brain injury, generally we divide into mild, moderate, severe. Mild to moderate is up to the 9 GCS, and the severe is the less than 8. Even your traumatic brain guidelines change, management change regarding the fluid management, regarding the osmotherapy, regarding everything change from mild to moderate to severe. So even the tranexamic acid, which might be the next question, it changes for mild to moderate to severe. It is not useful in a severe, but it might be useful in a mild to moderate. So when we are speaking, we should speak whether you are talking about the severe traumatic brain injury or mild to moderate. Our case is the severe traumatic brain injury, because he dropped the GCS to the 7. So in such cases, there is no role. And even in any mild to moderate also, there is no role of targeted temperature management. Till 2019 evidence is available.
Even if severe head injury, if there is no intracranial hematoma, whether ICH or acute subdural hematoma, then if it is a diffuse injury, then we can think about the alternative treatment, hypothermia, coma, barbituration, all these things.
It is not evidence-based therapy. We can try selective.
It's all trial. If the severe head injury without patient needing, if the patient is not needing any surgical intervention, then there are so many conservative treatment comes into play.
I agree, but there is no evidence for this therapy. So when we are
that's true.
There is no evidence-based hypothermia or temperature, as Kapil said. So, but there is this HOPES trial. They have said that it is in US and China and Japan. They are saying that if you go for decompressive craniectomy, along with that, you can have some mild to moderate hypothermia, which will help, which will protect the brain. That is the thing. But along with your decompressive craniectomy, what Singh will say, I don't know. But this is their recommendation.
Sir, we are running late up. We are running shortage of time, sir. Please concise and conclude, sir. Arijit sir.
Dr. Go, summarize.
Probably
please summarize.
He's a muted.
Okay. Ma'am, you and Kopil sir, please summarize this session. Yeah, Kopil sir.
Okay. When we say the management of traumatic brain injury itself starts from the outside the hospital, that is in the emergency medicine. So first 3 hours management before, generally the more important, that is the golden hour. When you are in an ambulance, what type of the resuscitation, oxygenation, intubation. When you go to the casualty, your target should be, there should not be the hypoxia and hypotension. These are the two main parameters you should monitor during your EMS as well as in casualty. Even one event of the hypotension change your prognosis in the severe traumatic brain injury. When it reaches to the casualty, you have to see first thing is the stabilization of the cervical spine, then airway, breathing, circulation. If you are a doubt, please intubate. Don't give too much your experience into that. I will manage with the airways. Then once you manage the airway protection, fluids, crystalloid is the choice. In crystalloid, there is a balanced fluid is the choice.
avoid colites, avoid albumin, then maintain the mean arterial blood pressure more than 65. Go ahead with the scan as per the neurosurgeon's this thing. After the scan, if there is a hematoma, you need to go ahead with the evacuation. If there is a non-operative thing, you have to manage the ICP. Now, ICP targets in the traumatic brain injury is more than 25. Previously, it was 20, but now if it is more than 25, then only you need to have a osmotherapy. So you can go ahead with the ventilation and osmotherapy and management of the rest of the part in traumatic brain injury. I'll summarize. There is no role of the hypothermia. There is no role of the barbiturate. There is no role of the steroids. There is regarding the biomarkers. There is still a lot of we need clarity. Which biomarkers, which set of the biomarkers, which will prognosticate, which will help for the management of the head injury. There are almost more than 20-30 biomarkers you can do it, but there is a lot of clarity need. In maybe we are in a good situation to talk about the biomarkers in a traumatic brain injury. And regarding the rest of the management, I think most of the things I have covered. Thank you.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you.
I thank all the panelists for their contribution. And
Thank you.
Thank you, sir. So next session is this is the Parfenidone versus Nintedanib in a post-COVID lung fibrosis, and our speaker is Dr. Deepak Talwar. He's a director of Metro Institute of Respiratory Diseases, and the chairperson is Dr. Dhruv Chaudhary. He's a senior professor and HOD PGI Ratak, Department of Pulmonary and Critical Care Medicine, and also sir is our current president in Indian Society of Critical Care Medicine. I welcome Dr. Deepak. Sir, your please start your session.
Hello. Yeah. Thank you, Asif, and thank you, organizers, for having me here. I can not see Dhruv at the moment, so I think he will join in a minute or so. So my job is to tell whether to use nintedanib or pirfenidone in COVID fibrosis. And I think my answer simply would be quite difficult here. But then how do I answer this? We do lack evidence. And the first question which comes to mind is that do antifibrotics have any role in COVID-19 pulmonary fibrosis? And in case it is, then which antifibrotic to use, whether nintedanib or pirfenidone? Which one works? Which one works better? When to start and when to stop it? Everything is at the moment waiting for more research and evidence to pour in to guide us. And what we have at the moment is the evidence which has come from whatever have been the studies of antifibrotics in the past, and whatever has been the experience of previous pulmonary fibrosis post-viral infections, particularly MERS and SARS-CoV-1. We all know that the COVID infection goes through these 3-4 phases, and lung fibrosis is the last one, which is after the dysregulated immune response, which leads to a lot of cytokines, which is trying to not only damage the lung parenchyma, but also propagate fibrosis. And this fibrosis is primarily due to overexpression of the pro-inflammatory cytokines, which is TGF-beta, TNF-alpha, and predominantly interleukin-6. And they call for fibroblast and myofibroblast, which are basically the cells which will lay down the fibrosis in the lung parenchyma. And if goes uninhibited, unchecked, it will lead to development of more and more fibrosis, primarily due to the deposition of the collagen in the extracellular matrix. We all have seen that the COVID-19 lungs go through various phases, and perhaps fibrosis is the last one. And it has been seen that in fatal cases, pulmonary fibrosis is generally present in the lungs of these patients who undergo autopsy. But we also know certain facts that there are restrictive lung functions in patients who have got post-COVID pulmonary fibrosis, and it is to the tune of almost about 1/3 of the patient who manifest not only the decrease in lung capacity, but also the predominantly decrease in the diffusion capacity, which is primarily both because of the decrease in the diffusion, the alveolar volume, as well as the KCO factor. The pulmonary fibrosis is definitely a long-term complication. It has been seen 39% of patients at discharge, but how long it lasts is what we are learning on the way. Fibrosis has definitely been shown to be proportional to the duration of illness and the amount of damage. And this is also related to the age and the severity of illness of the patients. But we do need large data, which is not available at present, to make any conclusions on not only the presence of pulmonary fibrosis in SARS-CoV-2, but also how long it lasts and what are the measures which are taken, which will be of evidence-based to tell us that they improve. But ARDS is considered as the main cause of pulmonary fibrosis. So this is just a summary which tells us that there are a lot of patients at the time of discharge do show changes, which even the reticular changes, which looks like fibrosis, are not permanent because they considerably reduced over a 1 month period. And almost 2/3 of the patients who have significant findings on the CT scan, they disappear at 4 weeks follow-up. So fibrosis, which happens in MERS and SARS, has been also shown in their survivors to significantly decrease over a period of months, and finally at 1 year, minimal changes are left behind. And there is a follow-up of 15 years of this SARS-CoV-1 patients, where it shows that this fibrosis does significantly reduce without any treatment. And that happens in Corona too also. So does all of them heal? May not necessarily, and a lot of them have significant abnormalities even at month 3 and month 6. So when do we need to intervene, and what should we do for there, and what works there? It all depends upon our understanding of fibrosis. How does the fibrosis occur? We know that there is initially an injury followed by inflammation, which manifests as consolidation, which undergoes organizing and is organizing pneumonia, which is very typically seen with COVID-19 infection. From there, if it recovers, it will leave nothing behind as far as the lungs are concerned, completely clear, but some of them do go on to develop pulmonary fibrosis. So we know the pathway to fibrosis is from injury to inflammation to consolidation to organization, but then the path either goes to fibrosis or it goes to clearance. And that is what makes the difference of an individual patient who will whether develop fibrosis or go into complete clearance. But anyways, if you have a pulmonary fibrosis post-COVID infection, what do you want? We want a resolution or stabilization, or we do not want it to go anyways in progression. And luckily, we know that this is a kind of viral infection which does not progress and does not lead to progressive fibrosis, except for few cases which have been reported so far. We need to improve their lung functions, we need to improve their quality of life, and we also want to have an endpoint as when to stop the therapy, because this is not IPF where the treatment has to be lifelong, and we want to improve the survival of the patients. So can it be achieved with antifibrotics? And the idea comes from what has been seen in IPF. IPF is also a disease with, when we see as a honeycomb lung UIP pattern, this is the end stage. When it starts with inflammation, and that inflammation goes through pneumonia and organizing pneumonia, which ultimately leads to development of fibrosis, because it is going unchecked mechanism of fibrosis in these patients. So if this is the process which happens and the drug works there, then perhaps there is a role where you can use these antifibrotic drugs. We have two of them, pirfenidone and nintedanib. Pirfenidone has got multiple actions. It is a pleiotropic drug which has got antioxidant, anti-inflammatory, and of course it has also got a significant effect of decrease in collagen synthesis, which is primarily because of TGF-beta down stimulation of TGF-beta. And we know that TGF-beta is one of the cytokine which pushes the patient of COVID-19 into more and more fibrosis. So obviously, theoretically, it would work. As far as nintedanib is concerned, it is a triple kinase inhibitor, and it also decreases not only the proliferation and migration of fibroblasts, but deposition of the extracellular matrix, which is perhaps the collagen, which is basically the building stone for the fibrosis and the fibroblastic foci, which happen later on. When we look at these two drugs, nintedanib and pirfenidone, we have at the moment the trials which are going on to look at whether they work in taking care of fibrosis which is happening in the patients of moderate to severe COVID-19, and they are expected to come by the mid of this year. We do not have the data, we do not have any preliminary evidence to tell us which one works and which one works better. We need to wait for the evidence. But we do know that if we look at the various actions by which these two drugs occur, Pirfenidone has been shown to reduce the effects of the acute lung injury which happens experimentally in the animals, and it has been shown that the injurious agents which have been used in the animals, if they are pre-treated with Pirfenidone, the injury effect is reduced significantly. However, this has not been described by nintedanib, but we also know that nintedanib and Pirfenidone both inhibits IL-1 as well as IL-6, which are again the pro-inflammatory cytokines, which are primarily driving force for the fibrosis. So what do we need to look for, whether these antifibrotics work or not? We want to see acute effect of antifibrotics because it's a disease where we cannot wait like IPF. We also want prevention of exacerbations or worsening, which happens post-discharge in patients with moderate to severe COVID fibrosis. We want to look for a drug which should have a broad spectrum of antifibrotic effects. And then, of course, we need to match the side effect profile because these are sick patients and they should be able to tolerate these drugs. So coming on to these two drugs, which we are discussing today, we can only have a data from what has been used in the fibrosing lung diseases. And we know that time to effectiveness of antifibrotics, it depends upon when the therapeutic dose is being administered. And we all know Pirfenidone needs to be taken 1800 to 2400 milligram per day. And it is slowly escalated in all the clinical trials over 2 to 4 weeks time. Do we have that much of time as far as the post-COVID fibrosis is concerned, where the early initiation is being considered as the key? As far as the nintedanib is concerned, because the therapeutic dose starts from day one, but it also takes about 4 to 8 weeks to be effective. So there's not much to consider between them. As far as the acute exacerbations post-fibrosis are concerned, they are decreased by both the drugs. And if you see the tolerability and safety profile of people who have used these two drugs, and there's one country where it has been studied in Britain, it doesn't make any difference. So both the antifibrotics may be similar as far as their usage in COVID pulmonary fibrosis is concerned, because we do not have any evidence as far as their clinical endpoints are concerned. So what about the patient characteristics? So when we think about the patient characteristics, we look at Pirfenidone and nintedanib from various other aspects. We know that Pirfenidone cannot be used in patients who have got poor kidney functions, as well as patients who have got liver compromise or a chronic liver disease, because it is more hepatotoxic as compared to nintedanib. Nintedanib, on the other hand, is to be avoided in patients who have got therapeutic anticoagulation, patients who have got unstable coronary artery disease, and of course those who have lower GI side effects. Is there any guideline as of day to day to tell us which drug to use? So I will refer you to the post-COVID-19 Respiratory Management Expert Panel Committee, which contains almost 50 plus pulmonologists all across India, published in Indian Journal of Chest Diseases and Allied Sciences. And as far as the antifibrotics is concerned, there is a line which has been written that since Pirfenidone has a pleiotropic action, and it can probably be used for post-COVID-19 patients showing clinical, radiological, or physiological evidence of fibrotic lung disease. So I think although there was no consensus as to when to use, how to use, and it has to be individualized for the patient, but there has been a little recommendation which has gone more in favor of Pirfenidone over nintedanib. But I would be saying that it is not that it cannot be debated. It can be debated easily. And the cardiology guidelines, ESC guidelines, has already written that if the antifibrotic therapy has to be instituted soon after the anti-inflammatory, earlier the better. Obviously, there are certain surrogate markers to look for them. But as far as the choice of antifibrotic is concerned, whether since in nintedanib versus Pirfenidone, there is no clear-cut consensus here also. So just to take a glimpse, you look at the lung functions as well as the CT scan of a patient with post-COVID fibrosis in the first month. And you can see that just at 3 months, how much the lung functions have improved, the CT scan has cleared, but still there is some effect as far as the lung capacities are concerned, which are not recovered even after 3 months of nintedanib therapy. So there is a fibrosis paradox. Those patients who die of ARDS after prolonged suffering, they do at autopsies show significant fibrosis. However, those patients who develop ARDS due to any cause, particularly viral infections, and then this is being connected to the COVID-19, that these patients have a little evidence of fibrosis 1 year down the way. There are other agents, and there is a good news that there's a novel inhibitor as well as fostamatinib, which are being tried. And again, we are expecting the results by the end of this year, but perhaps that's the time when it will be too late. We need to take a call right now. And I think the patient's characteristics is the most important point. And the second point will be how much is the tolerance of the drug to the individual patient and how soon you can escalate the dose of the drug to the therapeutic level. With that, I would like to thank you all, and I'm open to questions.
Thank you, sir. Thank you. Thank you very much for such a wonderful session. Next session, this little modification that next session is the neutropenic sepsis, but due to some other emergency, we are starting post-COVID fungal infection. After that, we will start the neutropenic sepsis, back-to-back 2 sessions. Thank you, Deepak sir. And I will request Dr. Arunalok Chakraborty. Sir is a HOD, Department of Medical Microbiology in PGI Chandigarh. And the panelist is Dr. Subhas Todi. He is a Director, AMRI Hospital. And Dr. Deep Narayan is an ID specialist in the Woodland Hospital, and Dipankar Sarkar is an intensivist in Columbia, Asia. And Dr. Ujjayani Khan is our HOD Medical Microbiology in Apollo Clinicals Hospital, Kolkata. I would request Dr. Arunalok sir, please you start the session.
Okay, thank you, Dr. Asif, and good evening, ladies and gentlemen, or rather good afternoon. It's a post-COVID fungal infections which have to be discussed. Basically, if I just give a few line of introduction, that in the early COVID period, we used to see low rate of bacterial and fungal infection, possibly due to improved infection control, because we used to do the hand washing repeatedly and we used to take care of the infection control. So Spain showed very low rate of infection, rather fungal infection almost non-existent. Even UK had the same picture. Fungal infection rate shown to be 0.35%. USA, it had shown that there is no antifungal increase use, rather there is decrease in echinocandin use in case of the ICU. But what it had been seen after that, and during this period as well, the bacterial infection was quite less, but a lot of antibiotics had been given. Like if you see in US, the study which had been conducted by 24 centers study combined together showed bacterial infection only 6.9%, but 72% patients were on antibiotic, though they were not clinically indicated. But this situation later changed, and what we have started seeing, like this is UK data, which showed that invasive fungal infection rate had been shown more than a quarter, 26.7%. Aspergillosis 14%, yeast infection 13%, and overall mortality also in this group was very high. So with this brief background, first question to my friend Dr. Todi. Dr. Todi, what is the reason, or what are the reasons you think that early COVID era and post-COVID era, in case of prevalence of fungal infection, what is the need of this change happening?
I think one of the major reason could be that use of dexamethasone and tocilizumab. These two are very severe immunosuppressant, and patients who are mechanical ventilation for a prolonged period of time in ICU. I think the combination of these two, sick patient on ventilator, they all, after the dexamethasone study being published, and there were a lot of tocilizumab were used in the earlier period. So I think these two combination is causing this problem.
That's a good important point you have raised, that rather it is steroid use increase. Did you see similar changes in our Indian patient, Dr. Sarkar? I hope Dr. Sarkar is online here. Dr. Dipankar Sarkar. If he is not there, Dr. Todi, can you see, can you tell us that whether you have seen the similar situation here?
You know, the awareness was not there initially till the reports started coming of kappa getting published. And even we were not very sure about how to diagnose invasive aspergillosis because none of the patients were getting bronchoscopy. Almost all the patients CT scan had bilateral infiltrate. None of them had a very classical these nodules or cavitating lesions of aspergillus. But then we realized that you might not get this classical features and you have to depend on galactomannan. And since bronchoscopy was not being done, we were not very sure how to interpret non-bronchoscopic galactomannan. But recently with the consensus guideline, we have started seeing quite a few possible kappa. I have yet to see a definite kappa or a probable kappa, but lot of possible kappa I have seen.
So now if I can ask Dr. Ujjain, Dr. Ujjaini, can you tell me what are the prevalent COVID-associated invasive fungal infection in India? Dr. Ujjaini, I saw that you have been connected.
Yes, yes. It was muted. I think I am audible now.
Yeah, you are audible now.
Yeah, in my experience, what I have seen that the most prevalent fungal infection in the COVID patients is the candidiasis, candidemia rather, followed by aspergillosis and followed by I think mucor, but we haven't seen any cases of mucor in our institute, but there are reports of few mucor from India.
So the thing is that, is it the problem in case of the diagnosis? That was the major issue? That you have not seen so much of aspergillus or something?
Yes, probably it is because as Dr. Todi told initially, we didn't know how to diagnose invasive pulmonary aspergillosis, kappa, in this group of patients. Candidiasis was easy because we picked up in the blood culture, but for aspergillosis, like bronchoscopy was never done, and sometimes we grew aspergillus from the ET secretion, but that may be a colonizer. At that time, the algorithm was not very clear how to diagnose or label these cases as kappa. So there were a lot of possible kappa cases, or it may be colonizer. Some now we have started doing more of the galactomannan, serum galactomannan, but still bronchoscopy is not done. So the diagnosis becomes difficult to establish for kappa patients.
Dr. Todi, here I would rather ask you that in case of this, there are two issues. Like suppose influenza, where we came to know that those in case of the ICU, they develop the invasive aspergillosis. But Dr. Asif has told me that post-COVID fungal infection. So do you think that this fungal infection is happening while the patients are on COVID, or it is happening later in part of their disease? Or it is sometimes when the patient had been discharged and they are coming with some diagnosis of this fungal infection? What is your impression about it?
You know, most of the time we have seen in the acute phase, all the literature of kappa is a median duration of 8 days on mechanical ventilation. That's where the kappa is being described. Not much report, but there are now patients of, as mentioned in the previous lecture, of COVID fibrosis on very prolonged steroid treatment. So as you know, there have been literature on prolonged steroid treatment of aspergillosis, but I have yet not come across invasive aspergillosis in patients who have been on home steroid for COVID fibrosis. Almost all of our invasive aspergillosis has been on a ventilated patient while in ICU.
So, you know, in the newspaper we have heard, and a lot of people have started speaking about this mucormycosis issue even from our Fungal Infection Study Forum as well as Clinical Infectious Disease Society, a combined study had been planned about mucormycosis. Because if you see, this was the first report which came from India. That was there were 2 centers from India. One in case of the Maharashtra, another is in case of the Hyderabad. Combined together, they have first highlighted the 6 cases. Then Dr. Prakash is, I am seeing his face, they have reported around 13 cases which have been there. So have you seen such rise in case of mucormycosis in Kolkata, Ujjaini?
No, sir, as we told you, we have not seen any cases of mucormycosis in COVID patients or in post-COVID patients, though we have seen 5 or 6 cases of kappa, probable or putative kappa, but mucor, still now we have not diagnosed any.
I think there is a need of the awareness and some issue. Like I have heard from Dr. Atul, in one center they have got in Gujarat more than 50 cases within 4 months of mucormycosis. So that's a very important thing, because this session is mainly attended by the Calcutta people. I would rather say that please look into this mucormycosis issue. I'm not very sure whether Dr. Sarkar is there, but then I will have to ask. Yes, Sarkar is there. So what is the reason for the rise in number of mucormycosis in India? Though the question is difficult for you, as Dr. Ujjaini mentioned that they have not seen mucormycosis in Calcutta. So possibly it is difficult to answer in that. But if you see that newspaper reports and throughout the country, there are so many awareness in case of mucormycosis had come. So do you think what may be the reason in case of this rise in mucormycosis?
So I have 2 points to make over here. Number one, a rise in mucormycosis, you keep aside the COVID, the rise in mucormycosis probably is directly proportionate to the rise in diabetes. Okay. India is a, what should I say, capital of diabetes or whatever you say. Even in other way, you can say it's a capital of mucormycosis also. The personal hygiene, the unabated control of blood sugar. Blood sugar is really poorly controlled over here. And moreover, there are certain other diseases like, malignancy, chronic renal failure, use of steroid. All these things are attributed to the cause of mucormycosis, including climate and the so-called not good hygienic practice in Indian population and closeness of stay. Now, regarding mucormycosis in Calcutta, I must say I have got a patient, only one patient, and incidentally, it's a very peculiar history. If you go through the history, actually, his wife was admitted under me with COVID, and he was in home quarantine. He's a diabetic subject, but he never took steroid and anything, and he recovered from that COVID, uneventful. After 1 month, again, her wife called me up that her husband is having epistaxis, and it has been checked, followed up, and it has been found that it's basically a maxillary mucor, and he is under treatment right now. He's recovering. He's under treatment under the your ENT specialist.
Okay, thank you. Because we have got running short of time.
So I can show the, I have got the slides, but
no, please, because
make it short.
Very short period of time, a lot of things to be discussed, but we are trying to restrict this issue. Dr. Mukherjee, I'm coming now first time to you. Can you just say how you manage this? I know it's a very big question, but if you can, in short, can answer this, that how you manage such cases of mucor? Do you have some, which is the standard therapy? Do you want to modify it, something like that?
Yes, sir. So basically, as we are not working in a immunocompromised hospital unit, so the isolation rate of mucormycosis is probably not significant in our hospitals, sir. But still, we have some examples or some experience of handling mucormycosis. and not in post-COVID mucormycosis, but previously with some other disease, maybe some immunocompromised patient. Couple of years before, we got one patient with a sinus or a sinoorbital mucormycosis. So we also have not been very much successful on the treatment part. Very polite confession, sir. But we tried with three things basically. Number one, the control of the basic disease, which was a uncontrolled diabetes in a post chemotherapy patient, and that part should be very much important. If the sugar is not controlled, the disease process will not be able to be controlled. Number two is that we have to give proper antifungal drugs, and we all know the antifungal drugs are now available. IV posaconazoles are there, sir. Amphotericin B lipid complex is there. And also we can try with casfofungin. Sometimes we give a combinations of all these antifungal drugs as a sort of combination therapy. And last but not the least is a surgical control, means source control. So maximum of the times we have to go for a surgical control, surgical exploration. Either if it is lung, we may go for lung lobectomy, or sinus, sinotomy, or in sometimes we have to explore the central nervous system. So in nutshell, we have to go for the control of the source. We have to go for the surgical exploration by that, and antifungal management, and definitely the baseline disease control. That's also.
I would say not to say it's a surgical control, rather it's a extensive debridement, which I would be rather interested to hear. Now, going to the Candida issue, if you see, these are the pictures which have been shown in Spain, India, Italy, UK in COVID patient, and of course Candida auris, which was really bothering us quite a bit because of the drug resistance in nature, which was spreading throughout the country of this. We have also seen in COVID large number of cases. So here again, I'm coming to Dr. Mukherjee. Do you feel that any additional risk factor for COVID development? Because you know about the risk factors in ICU, but in case of the COVID association, do you feel that there is some risk factor added to it in case of Candida?
Exactly, sir. There are the common risk factor for Candida infection, Candida bloodstream infection, but associated with that, especially for the COVID, I am totally agreed with Dr. Todi, what Sarah was telling, that we are giving steroids. Sometimes the dosing may be a higher dosing, and along with that anti-COVID management, tocilizumab. So we are giving those drugs. Parallelly, we are misusing antibiotics. Many of the patients I have come across, sir, the patient is unknowingly getting a long duration of antibiotics, and that is also a broad spectrum IV antibiotics.
Sir, these are already known risk factors. I was just looking for any additional risk factor because of COVID. Already I have seen that there is issue that in case of the US, only 7% bacterial infection, but 72% patients were on antibiotic. These are all known risk factors, but I was just trying to say, like suppose the management wise, as you have mentioned about the steroid use would be an important issue.
Yes.
And of course, anti-IL-6 possibly another factor which can be important here. So do you see Candida auris, Ujjaini? Have you seen that? You have seen any of this Candida auris in case of Calcutta? Means
Yes,
in
Candida
COVID,
auris.
of course, you have seen Candida auris, but in COVID patient.
Yes, COVID patient, Candida auris was not there. Initially, we used to isolate Candida albicans or tropicalis, but with time, auris became the predominant Candida being isolated from these patients. One of the reasons may be the higher use of the steroids, as was suggested by the recovery study. So that may be a factor, and maybe poor infection control practices in these units. The people were heavily attired with the washing was not optimal, and the patient management with the chlorhexidine, patient bathing with chlorhexidine. This may be poor infection control practices led to colonization of these units with the Candida auris. Later on, it became the major Candida which was being isolated from the Candidemia patients.
I would say that in general, what it happened, initial part of COVID, we are very careful in case of infection control. And later part, we started protecting ourselves, not the patient so much. And that is one of the factor possibly the increase in case of candida happen. Now, there is question is case of COVID-associated pulmonary aspergillosis. I would take a small lecture on this in the later part. But if you see that in case of the Europe and Asian countries, this ICU patient, they have got this COVID-associated pulmonary aspergillosis. So, Dr. Todi, do you see such kappa cases in Calcutta? Though I know you have planned to do a study on these aspects. So, do you see any kappa cases in Kolkata?
No, as I mentioned, we have seen a lot of possible kappa cases as was defined by the present consensus which was published in Lancet. Basically, it is a non-bronchoscopic lavage of galactomannan of more than 1.5. But initially we were very impressed that quite a few patients had that, and we started those patients on anti-kappa, anti-aspergillus medications. But recently I am a bit disillusioned in the sense that the incidence of galactomannan in non-bronchoscopic specimens is so high. Almost all of my patients are having a galactomannan index of more than 1. Which have made me perplexed that it can't be such a high incidence of invasive aspergillosis in our kappa, in our COVID patients. Serum galactomannan is again, though in this guideline is saying more than 0.5, but again we have reservation on non-neutropenic patient of serum galactomannan as an indicator for invasive aspergillosis. We have couple of patients with a very high galactomannan of non-bronchoscopic lavage of more than 4.5, which was the cutoff given in the guideline to diagnose possible kappa. And couple of those patients did respond well to voriconazole and isovuconazole. So I think it is a learning curve. We have to learn more about this non-bronchoscopic cutoff, because even the world literature based on which these guidelines are given are very rudimentary. So more work needs to be done on this non-bronchoscopic specimens of galactomannan.
Dr. Todi, the problem that the taste, both this beta-D-glucan and galactomannan is so sensitive and difficult test to be performed. I'm just giving you example a week back. Dr. Dhruv Chaudhary referred a patient, VIP patient, who had galactomannan, beta-D-glucan more than 600. Same day, when we performed, the beta-D-glucan was less than 0.7, means less than 7. So I'm saying you this particular two tests in India, all the laboratories need some standardization. That's very important factor. I'm sorry, this is more job of a microbiologist, but clinician must be sensitive to this particular factor, or should be aware of this factor, that there can be a lot of false positivities coming from the lab as well. So coming to this issue of kappa versus mucor, Dr. Mukherjee, do you feel that any differentiation is possible when the patient, because that the diagnosis, both of, as Dr. Subhash has mentioned, diagnosis is difficult, and mucor you are not getting cases. So can you suggest the clinician how to suspect when it is mucor in that sense?
So in primarily that patient's clinical presentations or the history will be more or less same, sir. But ideally, yes, if there is a chances, we can find out in the CT scan, reverse halo sign, or maybe lung destruction, or maybe pleural effusion, or rhinocerebral involvement. So we can rather more go in favor of this CAAPM, means rather than the kappa. And parallelly, we have to definitely go for a standardized galactomannan assay by bronchoalveolar lavage. And if the bronchoalveolar lavage fluid contains a good amount of galactomannan, then probably we can say it is a kappa than a CAPM.
Real sample in case of COVID may be difficult. Whatever it is, I know this is a very difficult thing. But Dr. Dipankar Sarkar, can you radiology help in diagnosis, differentiating, say, suppose this kappa versus mucor? Of course, Dr. Mukherjee has just mentioned that there can be reverse halo sign. Do you have any idea how to suspect the differentiation between these two? Again, we are losing Dr. Sarkar possibly. I would rather say that really there is so much difficulty. I will come to this when I discuss on kappa itself in case of radiology, how to go for it. But because of the time constraint, let me go to the next. In case of Ujjain, can you suggest some diagnostic algorithm whether the patient is in COVID or post-COVID fungal infection?
There is some algorithm that has been published recently. One is that the modified ASP ICU, that algorithm that works very well. It takes into account the clinical condition, and because these patients may not have the classical host factors as described by the European Society for Cancer Research. So this modified ASP algorithm that takes into account the comparable signs and symptoms, as well as this entry level criteria is that aspergillus being isolated in culture, and from there, if the patient has compatible clinical signs and symptoms and a galactomannan positive either in the BAL or in the serum, then we can stamp the patient as a putative, otherwise it's a colonizer. And there is the recently, which was published in the Lancet, which is the proven, probable, and the possible invasive pulmonary aspergillosis. In case of proven, there is histopathology confirmation of tissue invasion. In case of probable, which is difficult in case of COVID patients, in case of probable, again this serum or BAL galactomannan along with this culture or a PCR or positive. And in case of the possible, there is a culture positive, and in a non-bronchoscopic sample, if there is the high index of the galactomannan. So these two diagnostic algorithms are there for kappa, but the problem is that in many of these cases, bronchoscopy is not done or cannot be done because of the risk of aerosolization and infection. That becomes a limiting point for establishing the diagnosis of kappa.
Okay,
Sir, we are running shortage of time.
Last question to Dr.
Yes,
Todi. I understand this is a big question, but just last, if you can just highlight one or 2 points in this area instead of discussing at length.
Yeah. One is empirical and another is definitive. Most of the time we'll end up giving empirical treatment and basically on galactomannan. And basically what we do, patient persistent hypoxia and having persistent lung infiltrate while on dexamethasone, and patient is usually on antibiotic at that time but is not responding. So it's between voriconazole and isobuconazole. With the recent launch of isobuconazole, we have been using more and more of isobuconazole because these patients sometimes have renal problems, lot of drug interactions, and so isobuconazole has become the mainstay. But yes, we have given voriconazole as well to quite a few patients, and few patients were treated with amphotericin as well. So these are the three first line therapies, either Vori or ISA, and the second line therapy is amphotericin B.
Okay, I understand that we have to rush through all these. There are several points which have been there, and somebody may contact any of the panelists and also can contact me for any problem which happens. That would be really helping. Thank you very much, all the panelists. I understand that this had to be rushed, and thank Dr. Asif for giving us this earlier opportunity. Just Dr. Prakash Shastri told me that he has given us this additional benefit of going beyond. Okay, thank you very much.
Thank you, sir.
Thank you, sir.
Thank you. Sir, thank you. So our next session is on neutropenic sepsis. It's a panel discussion, and the moderator is Dr. Anirban Home Choudhury. And Dr. Anirban Home Choudhury is a professor of critical care and anesthesia, GB Pant Hospital. And other panelist is Dr. Ahsan Ahmed. He is a HOD critical care medicine, CCC Hospital, Kolkata. Dr. Anupam Chakrapani is a hemato-oncologist, senior consultant in Apollo Gleneagles Hospital. Dr. Shulagna Bhattacharya she is a associate professor in AIMS Delhi, and Dr. Prakash Sastry is a senior consultant, vice chairman of the Department of Critical Care Medicine in Gangaram Hospital. Anirban sir, I'm requesting you to please proceed. And we are running short.
I can understand, Asif, that we are running short of time, and I promise that I won't exceed the time limit. And I thank you very much for inviting me in this panel discussion, and it's my pleasure to invite all the panelists here on a very intriguing and enigmatic topic, and I shall feel myself successful if I can maintain this enigma even after the end of this panel discussion. Now, let me start with this case scenario.
And
slide is not moving. Sorry, yeah. So this patient, he's a 50-year-old male patient, a locally advanced pancreatic mass with multiple peritoneal deposits. Biopsy has revealed moderately differentiated adenocarcinoma. Patient receives a combination chemo with FOLFIRINOX, and after 9 days of a first chemo cycle, presents to the emergency with weight loss, nausea, vomiting, and severe diarrhea. On examination, patient is found dehydrated, tachycardic, blood pressure is borderline, maybe slightly towards hypotensive, is having fever of 38.2 degrees centigrade, grade 3 oral mucositis along with alopecia. I will start with Shulagna here. Shulagna, in this case, what is your initial suspicion and how will you proceed with this patient?
Thank you, sir. So, sir, I think this patient, firstly, patient is having a temperature of 38.2 degrees Celsius. So, by definition, febrile neutropenia should be considered as a single temperature, oral temperature of 38.3 degrees Celsius or more than 38 degrees Celsius for 1 hour. So, here it is a borderline, but I will consider this to be 38.3 for all practical purposes. Secondly, this patient has received the chemotherapy of oxaliplatin, 5-fluorouracil, and I think irinotecan. So this regimen is known to cause febrile neutropenia. This is a common regimen which causes more than 20% chance of febrile neutropenia. So according to the recent reports, it is around 35%. So I will consider to be a case of febrile neutropenia post chemotherapy.
I get your point, Shulagna. So clinically you will suspect febrile neutropenia and you will proceed with further investigations.
Yes, sir.
To put it in simple terms.
Yes.
Now, as you move on in the blood investigations, you find the hemoglobin of 5.5. Your WBC ANC is 100. Creatinine is borderline 50 by 1.8. CRP is 183. Patient is having a normal chest X-ray as well as ECG. I move on to Hassan. Now, after suspecting clinically a patient of febrile neutropenia and seeing these findings, what would be your initial plan of treatment? Yes, Dr. Hassan.
So this patient fits into the criteria of a neutropenic sepsis.
Okay.
With an absolute neutropenic count of less than 500. And so one side treat on the line of sepsis management. This patient is dehydrated. So you have to give fluid resuscitation and also plan for empirical antibiotic therapy while sending all the cultures. So for this patient, I will send all the cultures and then start antibiotics. This is a patient of this group because he's absolutely.
Okay. So you will now next plan to take on the cultures, but in the meantime you will start your. Right. At this point, I want to take it to Dr. Shastri, sir. Dr. Shastri, I just wanted to ask you in particular about the creatinine values in this patient, which is seem to be 1.8. Now, are you concerned about this, or you think that this is very much still in the reversible domain? Yes, Dr. Shastri.
Born intensivist, we are optimists. So
I would give it a benefit of doubt. I would definitely give it a benefit of doubt because I have a habit of saying that I need 24 hours to get a feel. So first 24 hours, I am going to do everything possible. I'll pull the shop and I do everything possible for this patient. Like his hemoglobin is 5.5, I would give blood to the patient. The counts are less than 1,000. I would give a Neupogen to the patient, and I would possibly hydrate this patient. And if possible, I would even start enteral nutrition in this patient, depending upon the vasopressor requirement of this patient. So yes, for the moment, I would do the routine ABCs that I would do to any other patient. I know for a fact that I'm dealing with a neutropenic sepsis, but as I told you before, as intensivists, we are born of believe that we are gods and we can reverse a lot of natural phenomenon. But though, of course, I will know in the back.
Great, sir. I will cut you short because we are running. I can get your point, but I would also like to state just get into your notice that CRP value of 183 because I will be coming on to the question at a later stage.
Yes, see, I'm aware of that. That's what I said. I will pull all stops. I will do everything for the patient. This patient would be on broad spectrum at least 2 antibiotics and an antifungal as well. So
okay, we will have more interesting questions and comments from you, sir. I will move on to the next stage now. Over the next 3 to 5 days, the patient continues to remain neutropenic and thrombocytopenic. The fungal cultures are negative on the Dr. Shastri growth from the blood cultures after 10 days. 10 days I am counting from the beginning. So there is also negative urine culture considering that the patient was have presented on 9 days. Now at this stage I move on to our oncologist, Dr. Chakrapani, if you are there. That suppose we all know that in neutropenic. Yeah, someone has muted me. Anyways, Dr. Chakrapani, over the next 3 to 5 days, as you can see, the patient's counts are reaching a nadir. And from there that the counts to further rise. Because 3 to this stage, how will you identify the patients who are at increased risk for severe disease? Yes, Dr. Chakrapani, if I am audible. Dr. Anupam Chakrapani, please. Can I connect with Dr. Anupam Chakrapani? Is he there? Dr. Anupam Chakrapani, if you are there, can you please respond?
I think Dr. Chakrapani has connection issue. Can you move on?
I can ask the same question to Dr. Shastri for that matter. That at this stage, which patients would you suspect when the neutropenia count is going down, the patient is at the rock bottom, that they would like to have a more severe disease? Yes, Dr. Shastri.
All the parameters that you are telling me would suggest that this patient is having a severe neutropenic sepsis, but that is besides the point. As a clinician, what I'm concerned about is what is the primary diagnosis. The primary diagnosis is CA pancreas, and CA pancreas with local metastasis, even if I say peritoneal studded metastasis.
No, sir, we are not looking into that part because these are looking at advanced malignancy. We are looking mainly in this context. I'm just asking
there are certain scores available to us which would definitely say that this patient is in severe sepsis. I won't even bother to look into my internet and see what this patient has, because clinically I know that he is in a severe category. I stopped there.
Okay, that's a good point. Is Dr. Chakrapani available now? Asif, can we have him for the next question? Yeah. Well, anyways, I will discuss with Hassan, because this is something an oncologist would have been more useful in appreciating the MASCC grading. They identify the patients who are at low risk of febrile neutropenic patients. They never identify high risk. So those patients who don't follow a score of more than 21, they are considered to be not to be low risk, but not that they're high risk. So not low risk and high risk is something which is a borderline issue. And again, one important aspect of the scoring system that they use here
is in contrast to the Karnofsky performance status, which is more commonly performed in the cancer patients, where an increasing score indicates severity, and here an increasing score indicates well-being of the patient. So probably the performance status and the risk of neutropenia do not always seem to match. I know it's a bit difficult, or it cannot be worked for an intensivist at this point.
Anirban, you can add by saying that these have a good negative predictability.
Yeah, maybe that can be
positive
a very yeah, absolutely, sir. Yeah, Dr. Ehsan, would you like to comment on this aspect of the MSSC score?
Yes, sir. Clinically, if you look at this patient has a relative hypotension. His systolic blood pressure is 90. He has tachycardia. He has oral mucositis. So these all indicate that this patient falls under severe category, as already told by Dr. Shastri.
Yeah,
I consider this patient as a severe.
Fine.
I
move on.
So the score is around 16. If we can calculate, so I think the score is around 16. So it's a severe.
5 plus 3, 8. 8 plus 5 is 13. 13 plus 4 is 17. 17 plus 4 is 21. 21 plus 3 is 24. 27 to 29. 26. So highest possible score is 20.
This page, yes. Yes,
okay, you are talking about this patient.
Score of 16. Yes,
well, we will go on to that later on. Shilagna, more importantly, I have an important question for you. That we have moved beyond that MSSC score and the Karnofsky, although Karnofsky performance status remains gold standard for other reasons also. We are looking into the newer models, and if you look carefully into this scoring system, you see Procal more than 0.5 gets 5 points. The 0.5 of Procal is something very common in non-neutropenic. But considering a neutropenic sepsis, a score of more than 0.5 of PCT getting such a huge weightage in the scale, would you like to comment on it, on the usefulness of procalcitonin? I will come to Dr. Shastri next time. That is why, Dr. Shastri, I had requested you to observe the CRP values. Yes, Shilagna, you can comment.
Sir, actually, in the recent years, so after the 1990s, there was an increasing trend in gram-negative infections in the neutropenic patients. So after the recent, like 2000, after 2000, the gram-negative infections is having a resurgence. So between 1990 to 2000, there was a predominantly gram-positive infection because of all the patients received the antibiotic prophylaxis with fluoroquinolone. So the gram-positive infections, and also because of the use of CVCs, more increased use of CVCs, the gram-positive infections have become more common. But nowadays, again, the gram-negative research is there.
Gram-negative infections because of CVCs is something
No, sir. What I was saying is in between, so during the late 80s and 90s, use of CVCs and use of antibiotic prophylaxis made gram-positive infections more common in such patients. Okay. But after the 2000, this era, so we are again seeing a resurgence of gram-negative infections, and it is around 50 to 40.
We will come into that in our next questions. But before Dr. Shastri, just I want to mention that we have to simply wipe out CRP from our calendar, because see, at 183 values, it doesn't mean much for us. But a 0.5 value means a good 5 points in this prognostic model. So we should focus our mindset entirely to Procal rather than doing or attributing too much of meaning to CRP. Yes, Shastri sir.
I couldn't quite agree with you, because whatever has happened, especially now that we were following up CRP in the COVID patients recently, and the correlation of CRP was fairly good. And as a matter of fact, the only place where I put a procalcitonin in this management of these septic patients is to rule out the possibility of a bacterial infection. If the procal is low and the patient is still very sick, I would think of an alternative source of infection other than a bacteria. That is what
that is from. I can understand. Do we have Dr. Anupam Chakrapani here now? Can you use your mic, Dr. Chakrapani, if it is there? Well, I think he is still not with us, or maybe there is some problem with the connection. So I move on to Ehsan. Ehsan, how different would be the course of neutropenic sepsis from non-neutropenic sepsis in a patient who is otherwise low risk febrile neutropenia?
So,
Yeah.
neutropenic patient is always difficult from non-neutropenic sepsis in the.
Absolutely. No two doubts or minds for that.
The more mortality is more, the in risk of ARDS is more, the risk of acute kidney injury is more, and even hospital stay and the mortality is very high because these patients are more difficult to treat. They are more difficult to respond to antibiotics because they are the fighter says those neutrophils are less. So these
Okay.
are common problems.
I get your point. I get your point. But Shastri sir, I want to move a specific question that whether when these patients, the moment their neutropenia gets abated, they move on to the neutrophilic phase. Do their prognosis change? Now they are becoming a normal sepsis. These patients, after 14 days, as the count starts rising, after a certain time it reaches that 4,000 mark. Do their prognosis become the same or at par with the other normal patients, or still there is some difference?
I would deviate from your direct question. I would say that neutropenia is just an indication of the net state of immunosuppression that the patient has. Now, if the same neutropenic patient would have a CMV positive, for example, then obviously his net state of depression goes even down further. So it is a total condition of the patient which really decides. And most likely, if the patient's underlying status is all right, like the patient with having multiple myeloma, for example, they undergo chemotherapy within a span of 2 days or maximum in 5 days time, they bounce back and they don't need any treatment at all. So the question is that you have to tide over this period of neutropenia, and but that all depends upon the underlying condition that the patient has. The condition, the patient that you have described in your previous slides, this patient is not likely to change over
No, I'm talking about sir,
the
normal,
neutrophilic
not
state.
normal.
That is why. But
Yeah.
if it does, to come to your question, if it does, then obviously I would breathe easy and I would feel that yes, maybe the crisis period is over.
Okay, so I think that's a fair enough. You all have to accept that if the underlying disease is not severe, the moment a patient recovers from neutropenia, probably the prognostication would become similar to that of the non-neutropenic sepsis. Now, I'm going to Shulagna for an important question that if you see, the neutropenic sepsis is associated with the distinct clinical and biological characteristics, and in the study, they have found the profile of very high IL-6, IL-C, and GCSF relative to non-neutropenic. When we think about neutropenic state, comparatively less immune response is to be mounted by response to that infection. How do you are able to correlate with this high level of IL-6 and IL or GCSF for that matter? Yes, sure.
Sir, actually, neutropenia is not just about defect of phagocytosis. Neutrophils are antigen-presenting cells. So, deficit of neutrophils will lead to deficiency of the recognition of by B and T cells, and also there is a dysfunction of monocytes and alveolar macrophages. So there is
Absolutely, I fully count.
so there is the lung, even tissue repair is hampered because neutropenia, neutrophils are also involved in the repair mechanisms, activation of repair mechanisms. Also, there is in such patients usually are with pancytopenia, and in pancytopenia the patient have due to thrombocytopenia.
I get you.
Yes, sir.
I will come to it later on.
Yes, sir.
Shastri sir, on that note, I just want I will come to you later. I want to ask Dr. Shastri sir one important question: that how do you attribute this higher AKI risk during neutropenia of exaggerated inflammation of the immune response leading, or is it the infection per se? What is the cause of this higher AKI risk? Yeah, that is independently associated with neutropenia.
I mean, as of now, my knowledge in this area is limited, but I can only say that it is a whole gamut of things. That it is basically what happens is, as Sulagna was trying to implicate, that there is that apoptosis thing which has started to begin, and this is just a manifestation of multiple organs getting involved. And I would not attribute to a sepsis per se. I would attribute it to the general destructions of the organ dysfunction that is leading to organ failure. This is one aspect. And when the patient develops a renal failure, I would perhaps go to palliative care than an active therapy.
I think even Ahsan would I agree with that. Now, Ehsan, we are doing good because I think Asif is started countdown. So I move on to you for this, that in the patients who are at low risk by any means, as by any of the criteria that we have used, either the newer ones or the older ones, would your empirical antimicrobial therapy be same, or is it going to be different? I mean, low risk patients versus high risk patients.
No, sir, as per your guidelines and also as per our clinical practice, if it is a low risk patient, we usually start a beta-lactam, either the anti-CD1 or beta-lactams like ceftazidime,
Yeah,
cefepime, or
everyone does
5%
that. Yeah, sure, I know.
If the patient is in high risk patient, if the patient is hemodynamically unstable, then we straight away go to the carbapenems plus gram positive covers like vancomycins, and also sometimes add antifungal empirically, and later on decides the we deal with the thing. So we go for with the antibiotic stewardship program like that.
Okay. Shastri sir, I just want to bring to your notice, because this is 3-year-old data. This is 2018 data from a good journal from which I have not mentioned the name. But you find that most of the time among the frequent pathogens, if you see, the coagulus, the CNS, the coagulus negative the staphylococci, the origin is unknown. So what this picture means? Bacterial sepsis in a neutropenic patient, CNS, either coming from CVC or coming from some unknown source. Are these the normal commensals which are flaring up in the neutropenic patients, or are they coming from somewhere we have probably not been able to check? Yes, Shastri sir.
I mean, to answer the previous question, the gentleman from the medical oncology was not here. One area where the medical oncologists are given a free license is to use the antibiotics. Whether it is low risk or high risk, they don't bother. They pump the patients with the highest available antibiotics which are available to them. And the reason precisely is because of the possibility of these organisms that you have mentioned. Now, coagulase negative staphylococci in the kind of patients that I deal with, I would have labeled them as contaminants and not even treat them. Now, if a patient has an implant in place, a patient is having, I'm suspecting endocarditis or those kind of situation, and the patient might be having a central line in place or a PICC line in place, though there I can't ignore.
Absolutely. I think that's a very practical aspect.
And that is where probably I'll have to treat it. I will not treat it. I will not treat it. I will remove the offending implant that the patient has. And because whatever treatment I might give to this patient is not going to work unless the offending prosthetic device or implant.
So that's the question. That's the question. That's the question actually. Ehsan, as Dr. Shastri was telling, do you think that we need to remove the offending agent? But how to remove the offending agent when the origin is largely unknown? When the origin is largely unknown, so you tentatively start removing the catheters, your central lines, or everything, or whichever you on a random basis. So, do you think that it is easy?
No. If you go to the guidelines, then it is clearly told that you cannot remove the offending agents until it is the evidence of source is from there. So it should be both the clinical judgment as well as the laboratory findings. If my CVC is very valuable, we don't have another access, then I will think twice before removing that agent.
Absolutely.
I think.
Yes.
If I may add, so we can also go for antibiotic lock for CLABSI or with a coagulus negative staph if we don't have cases of endocarditis.
But does that really work in neutropenic patients?
Sir, actually, yeah, that has to be determined also. But that is a probable. And some centers have reported it. So.
Okay, Shastri sir, I
running
I can agree. I cannot agree more with my colleagues saying that you can't label the central lines as the source of infections all the time, because these patients probably have.
Actually, sir, also there is role of different time to positivity.
I can understand.
You are growing an organism in blood. And when you are growing an organism in blood, I can accept. You have grown something from the sputum, it could be a colonizer. You have grown something from the abdominal.
Right.
Yeah, it's sir. I know that it is a big
colonizer. I mean, any other source I can accept it as a colonizer. Grown something from the blood. How can you ignore it? You have to treat it. And once, and if you have failed your initial 48 hours of therapy, then the degree of suspicion.
It is not. Sometimes it is not easy, sir. It will be difficult.
The decision is.
Yes.
The justification whether you need the not is a different point.
Sir, I will cut short
But it has
because we are running time. We have more important questions for you, sir. So I'm showing you this chart about I know about your depth in fungal disease. Now, following this, now we have flu cytosine in India. Now, do you think that in neutropenic patients the use of flu cytosine can increase because it finds place in most of the times, especially in patients with unstable candidemia? One-line answers. Yeah.
Only in CNS infections.
Only
in CNS infection.
Not elsewhere. Not elsewhere.
I would agree for a combination, sir.
Okay.
Its penetration in the CNS is pretty good.
Okay.
Or maybe ophthalmic eye, which is those areas where caspofungin is unlikely to reach at all.
Fair enough. And I know that there are good references for that. Ehsan, I want to ask you that this is a recommendation for antimicrobial stewardship. Now, it is very good to read, but how easy or how difficult it is in actual practice, recommendations like this is from an international organization. Limit antibacterial prophylaxis, encourage target specific therapy, create guidelines and clinical pathways. Now, out of this whole long list, can you tell me that two which you think are very easy? Any two from this list?
First is the choice of antibiotic and its optimized dose and duration.
Choice of antibiotic is probably the most difficult. Yes, Shulagna, what is
Anirbandha, we have to conclude.
Okay, I'm moving on with this.
Sir, please. Sir,
yes.
in our institute and in mostly in our scenario, so we start with in a patient who is high risk. We start with the anti-pseudomonal penicillin, that is either piperacillin tazobactam or with a carbapenem like meropenem, along with patients with having pneumonia or other signs like oral mucositis or having history of previous.
Shulagna, I'm asking two easy means out of this long list, which you think is easy to follow.
Okay, so the two easy is one is dose optimization, and the other one I think is de-escalation.
Okay, or parenteral to oral conversion. Even that is also according to me is quite. I will not go further because we had some interesting questions on the duration of treatment, about which I had results, especially for Dr. Shastri, about the role of GCSF and the GMCSF. Now, without much, I will go to Dr. Shastri because I'm going to the last part of the question. That, sir, in this flow diagram, I just want to make attention to this patient, a patient with a hemodynamically unstable patient. If you can see, my cursor is pointing yes, where you are using meropenem plus vancomycin, considering aminoglycosides antifungal. So, if the patient is not hemodynamically unstable or patient is hemodynamically stable patient, then even when you suspect pneumonia or soft tissue, there is actually no place for antifungal therapy. Do you agree to this? Yes, Shastri sir.
I would agree with it.
Great. I think that counts.
Because if I were to give antifungal to these patients, I'll be giving all my patients of neutropenic sepsis. The point is that the indications for prophylactic antifungal usage in this setup is fairly well established, so I don't have to speak on that. So prophylactic antifungal would be in any case mean azole, and azole we know may not be reaching all the areas and may not be effective in quite a few indications in these patients. So the option is to give an antifungal would be either amphotericin B or a caspofungin, depending on the site of infection, and which is something which is I find it very.
I fully agree. So I move on to Ehsan. Ehsan, your last.
We have to conclude the session.
Yeah, Ehsan, your last question. So I think you accept that in hemodynamically stable patients, probably we have to think twice or thrice before starting antifungals. Are you accept it, Ehsan?
I could not understand.
Okay. No, I'm saying that if a patient is hemodynamically stable, then probably there is, because these are the patients who are the hemodynamically stable patients, we have very little scope for antifungal unless we know that the patient is very sick or something else. So I think we have already too much of rebuttals from Dr. Asif. So we have to end our discussion. So probably we have not been able to discuss at length many of the issues, but I hope that this was a useful discussion. And If I am able to keep you perplexed and intrigued, I will consider this panel discussion successful. I once again thank all the panelists for sparing their valuable time, and Asif and its entire team for giving me this opportunity. Thank you very much. Thank you.
Thank you, sir. Thank you, sir. Thank you so much.
Thank you.
Thank you all. Sorry, we are running very shortage of time. Otherwise, it is a very wonderful session. We have to move the next session, that is optimum PEEP in ARDS, because we know that there is a lot of ARDS treating in this session. And Saswati Sinha ma'am is a senior consultant in Amri Hospital, Kolkata, is a speaker, and ma'am has done a lot of care of the COVID patient. And Sudipto Mukherjee is a senior consultant in Tata Medical Center, Kolkata, is the chairperson of this session. Shaswati ma'am, please start your session.
Take it.
Are my slides visible?
Yes, ma'am.
Good evening, everyone. Thank you, Asif, for the opportunity. Because we're running late, so I would try to conclude mine in 10 minutes. So we'll be talking about optimal PEEP in ARDS. And as we understand that ARDS is not a benign phenomenon, it kills. And there is a dramatic mortality, which used to be about 70% earlier. However, since the advent of lung protective ventilation, that has reduced the mortality of severe ARDS from 70% to around 35 to 40%. However, what we need to also understand that over the last 15 years, there hasn't been any further decline in the mortality, and it is still quite staggering. So now the paradigm is shifting more from the treatment of ARDS to the prevention of ARDS, because we know a large population of our intensive care unit patients have a propensity of moving on to ARDS. And hence, the ventilatory strategies are not only therapeutic in ARDS patients, but we also now apply preemptive ventilatory strategies to even normal lungs in patients. So when we talk about ventilatory targets in ARDS, that is lung protective ventilation, an attempt is on one hand to reduce alveolar overdistension by ventilating at low tidal volumes. And the second aspect is what I will need to focus on, which is my topic, is to minimize the recruitment, de-recruitment, and the injury which occurs subsequent to that by optimizing the level of PEEP. Now, as we all know that PEEP comes with a set of advantages as well as disadvantages. Among the advantages, it helps to improve oxygenation, thereby allowing us to titrate the CO2 downwards whenever it's permissible. It recruits the alveoli. It prevents recruitment, injury. It improves the ventilation perfusion match, and it decreases LV afterload. And therefore, it's also advantageous in patients with pulmonary edema. However, it comes with a set of adverse effects, like it can impact hemodynamics in a patient, especially if the patient is underfilled and we are using high levels of PEEP. It can increase dead space if we are applying too much of PEEP. It may hamper CO2 elimination, and we need to be very careful, especially if we are dealing with a patient with a neurological trauma, because if a patient has an elevated ICP, high levels of PEEP might further raise the ICP. So what we need to keep in mind when we talk about applying PEEP, that all ARDS lungs are not same, and which has been very clearly shown, especially in this COVID pandemic. When you see onto your left, we have a lung which has a near normal lung compliance, which is going to be less recruitable, and hence this patient might not react to PEEP in the same fashion as the patient on the CT scan you have on your right, which has a low gas volume and is more likely to have more recruitable lung, and hence this patient is more likely to be PEEP responsive. So like when we want to optimize ventilation, it usually should work like a closed loop feedback system where we have a target, and if there is any abnormality in our target, there is a sensor which, in terms of physiological changes like a decrease in the compliance, a drop in the oxygen saturation, any of these things which allow us to again make certain ventilator changes and thereby come back to our acceptable level of lung stability which we are looking at. So when we talk about what the evidence is about the higher versus lower PEEP in patients with acute, it's no longer acute lung injury. This is a meta-analysis which was published way back in 2010, and it included 3 major trials, about 2,300 individual patients, and it included the alveoli trial, which we all know, and the LOVES trial as well as the EXPRESS trial. And in all these trials, there were different methods of setting PEEP. Like in the alveoli trial, we can see that the PEEP was set according to the PEEP FiO2 chart. And there was a subset of the patients, the first 80 patients in whom they used recruitment maneuvers. The LOVES trial also set the PEEP according to the PEEP FiO2 charts. However, the EXPRESS trial titrated the PEEP depending upon the inspiratory plateau pressures. They kept increasing the PEEP till the plateau pressures were about 28 to 30 centimeters of water. And what was found, if they took the entire subset of all the patients, so they included ARDS of all kinds of severity, there was no statistically significant difference in overall mortality. However, what is important to know is in the patients who met the criteria for ARDS, that is a PF ratio of less than 200, there was a 10% relative mortality reduction. And it also went on to show that in the patients with the higher PF ratios, that is the patient in the PF ratios of 200 to 300, that is patients with mild ARDS by today's definition, higher PEEP may be harmful in these particular subset of patients. And also there was a small increased risk of pneumothorax in the subset of the patients who were treated with higher PEEP. There were few more studies which were added to the second meta-analysis and the systematic review, which was published in 2017, and it included 8 RCTs, about 2,700 patients with ARDS. The mean PEEP here in the higher PEEP group was 15 centimeters of water versus 9 centimeters of water in the lower PEEP group. So these are the 8 trials which were included. It's very important to note that there were 2 trials. First was the Amato trial, which used 12 ml per kg in the control group, which is very high. Now we know that it's overtly injurious, as well as this Villard trial, which also included a high tidal volume in the control group. So their primary analysis was eliminating the data from these 2 trials. And as we can also see that there were several methods by which they titrated PEEP in all these trials. And when they took the entire group of patients, that is, they excluded those 2 patients, the 2 trials in which they had higher tidal volumes, they showed that it did not meet statistical significance, although it shows that there might be a slight trend towards benefiting the higher PEEP strategy. However, it did not meet statistical significance. The other results, it showed that a higher PEEP definitely improved the oxygenation significantly. However, there was no difference in barotrauma, organ failure, or ventilator-free days, irrespective of whether the patients were ventilated with high versus low PEEP. They also tried to do a subgroup analysis, whether it made any difference in the recruitment maneuver groups versus no recruitment maneuver groups. So there was no difference there. And when they went on to analyze if the method by which the PEEP was set, that is the PEEP FiO2 table versus physiological parameter based setting of PEEP, it was found to have no difference. So again, they went on to conclude that when they included all the 8 trials, they found a mortality benefit in the group, in the higher PEEP group, with the greater benefit seen in the trials in which who did not use low tidal volume in the control group. So they concluded that higher PEEP is not universally beneficial for all patients with ARDS. The crux lies in identifying the subset with greater recruitable lung. That is most likely the patients with moderate to severe ARDS, which is almost similar to the results which were from the earlier systematic review. So there are different methods of selecting PEEP. in the earlier days, it was, they have, especially in research situations, and they used to titrate the PEEP depending upon the pressure, the respiratory pressure volume curve. Again, it is technically very challenging. The patient will need to be paralyzed or at least heavily sedated, and it is quite logistically challenging. There have been trials in which they have used the transpulmonary pressure-based PEEP selection, which might actually sound very intuitively very interesting, because there are certain patients with ARDS who have decreased chest wall compliance, like someone who is fluid overloaded or who has a raised IAP, in whom setting PEEP just based on the plateau pressure may not be appropriate. However, we know that there was this event trial which used transpulmonary pressure in order to set PEEP. However, it was seen that there was no difference in the outcomes whether the PEEP was set by the conventional PEEP FiO2 table as opposed to transpulmonary pressure-based PEEP selection. CT scans, again, there have been studies in which PEEP has been titrated based on CT scans. It is logistically almost impossible in our scenario. However, it has also been seen on this trial by Cressoni et al. That it really did not make too much of a difference. However, it caused a huge increase in logistics. There are several other methods which have been mentioned in literature. So recruitment strategies with decremental PEEP, compliance guided PEEP selection, something based on stress index, electrical impedance, pressure volume loop like we discussed, and dead space guided PEEP selection. And finally, we come to something which we do on a almost on a day-to-day basis, something which has already been shown to be effective. That is the ARDS net PEEP FiO2 table. We actually have it printed and stuck onto our ventilators. So if we go on to see, there have been studies trying to compare, and we find that the PEEP FiO2 table works perfectly well. And what we need to understand in summary, that like most tests or like most medications in an intensive care scenario, the ideal does not exist. We need to do with the optimal. So the optimal PEEP should have a reasonable balance between improving oxygenation, prevention of recruitment, de-recruitment injury, at the same time not be too harmful on the hemodynamics. So the best compromise, especially from all the literature we have so far, in patients with severe ARDS, we use a higher PEEP, about 15 to 20 centimeters of water. In mild ARDS, to avoid using higher PEEP, and in moderate ARDS, use somewhere in between. At every step, whatever we do, we need to go back and see what effect it is having on the oxygenation, lung mechanics, and hemodynamics. And the ARDS net PEEP FiO2 table is a reasonable guide. The other methods are laborious and offer no extra advantage. So thank you very much for your attention, and stay safe, all of you.
Thank you, ma'am. Thank you, Chairperson. And we are running shortage of time, so we will request our next speaker. The topic is quality indicator in ICU. The speaker is Dr. Rajesh Chawla. He's a senior consultant in the Department of Respiratory and Critical Care Medicine, Indraprastha Apollo, Delhi. And sir is a past president of ISCCM and ACCP. And the chairperson of this session is Dr. Ajoy Sarkar. Is a senior consultant, HOD, and clinical director, respiratory and Department of Respiratory and Critical Care Medicine, Peerless Hospital. I will request Dr. Chawla, please start the session.
Thank you, Asif. So I'm going to talk about the quality indicators in ICU. I think last about 20 years, a lot of ICUs have come up all over India. And the quality is the least consideration in most of the smaller ICU. In bigger ICUs, of course, people have some system in place, in particularly the corporates. 44,000 to 98,000 patients annually in US hospital, they die due to the medical error. First, I think let's understand the concept of quality and safety. Quality and safety are the two sides of this same coin. Quality reflects the measure that should have been taken but were not taken. Safety reflect action that were taken inappropriately or error of commission. So a 70-year-old Parkinson patient admitted to the ICU in confusional state. He fell from the bed on the night of admission and suffered scalp injury. How do you ensure that similar accidents do not happen in the future? So this is a quality issue, as proper precautions were not taken, which led to the compromise in patient safety. Similarly, another patient with hypertensive intracerebral bleed who required ventilatory support on 4th day of admission, he developed ventilator-associated pneumonia. So this also reflects need for preventive protocol for VAP to be in place, another quality control issue. Another case, a male patient admitted to the hospital with gastroenteritis. He was inadvertently administered high concentration of potassium in intravenous infusion through central line and suffered a cardiac arrest. So this reflects not only an error of commission, clearly a safety issue, but also lack of protocol for intravenous potassium infusion, a quality issue. So these are the important things which one must understand. So it is becoming, as I said, more and more mandatory for the institution to monitor the quality indicators, parameters, and compare their performance level with the national standard. Due to a variety of reasons, these are not monitored. Indian Society of Critical Care Medicine came out with guidelines in 2009, almost 11 years ago, which needs some revision. So quality means doing it right when no one is looking. The basic three components of according to this theory of quality control are structure, processes, and outcome. Structure, what we have, processes, what we do, and outcome is what we get. So if we look at the structure indicators, closed model of ICU care, availability of critical care consultant, 24/7 intensivist coverage, adequate trained staff, nurse-patient ratio, ward design, infection control nurse, infectious disease consultant, written policy, daily goal sheet, structure handover. And if we see the processes like compliance with the hand hygiene, compliance with antibiotic policy, compliance with central line insertion bundle, compliance with ventilator bundles, and compliance with end-of-life support policy. In family conference, and the outcome, mortality, standardized ICU mortality, which is considered better than the crude mortality. ICU length of stay, hospital length of stay, incidence of nosocomial infection, antibiotic consumption, family satisfaction, all these are the quality indicators. For this, you need to have a standardized data collecting and reporting system. It should follow the SMART principle, that is specific, measurable, achievable, reliable, and time-bound indicators. And all data, whatever you collect, has a numerator and a denominator. Numerator is population affected, population got infection, and denominator is population at risk. And you have to prioritize. There are n number of quality indicators. So fundamental quality indicators could be early administration of acetylsalicylic acid in acute coronary syndrome, early reperfusion technique in ST elevation MI, semi-recumbent position in patients undergoing invasive mechanical ventilation, prevention of thromboembolism, pneumonia associated to mechanical ventilation, early enteral nutrition, pain management in unsedated patients, compliance with hand washing protocols, information of patient families in the ICU, perceived quality survey at discharge from the ICU, and adverse event register. So these are, but if you see these, the one which you see are the one which I'm going to discuss, and they are the important: the mortality, hospital-acquired infections, MDR organism, antibody consumption, hand hygiene, cost of care, family satisfaction, nutrition adequacy, and glycemic control. SMR is a very important indicator. It allows the comparison of the performance of the institution with the predicted performance. The risk of death varies with severity of disease, state, age, and morbid condition. Crude mortality is not a sensitive indicator. So mortality rate can be obtained from predictive models such as Apache, SAPS, or MPM, etc. It's a very useful parameter. And you calculate observed rate divided by the risk-adjusted expected rate, which is the predicted death as per the predictive model. If it is equal to 100, that means you have the expected average rate. If it is more than 100, that means your hospital mortality is higher than the expected average mortality rate. And if it is less than 100, the hospital mortality rate is lower than the expected average mortality rate. Hospital-acquired infection, as I said, the number of device-associated infection for a specific site and number of device days multiplied by 1,000. It could be for urinary tract, it could be for central line, bloodstream infection, or it could be for the ventilator-associated pneumonia. You divide by the number of ventilator days multiplied by 1,000. So it gives you the infection rate in your ICU. And this is, I've got this data from Dr. Todi. You maintain the data over the months as you calculate, and so that you can know what is happening in your ICU. Similarly for central line, for urinary catheter, and you can compare with different ICUs because the infection rate could be different in your different ICUs. And then you can compare with the NNIA standard or INICCC standard. How are your ICU faring as compared to these standards? Like for this, you see the VAP from January to June. If you have been maintaining data, you can see that benchmark is 7. So in May, you had a higher rate, and rest of the times your rate was less than the NNSI benchmark. Similarly, for the bloodstream infections or the UTI, you can know what is happening in your ICU so that you can take measures to improve the quality or improve the prevalent incidence of infection in your ICU. And then they're also important to monitor the device utilization days. Number of urinary catheter days divided by number of patient days. Similarly for central line and ventilator. And then you can compare with device utilization in the different ICUs. And then in the same ICU, you can compare from 1 month to the other month as you go along, if you have been maintaining the data, to know what measures you took and has it made any difference in the incidence to improve the quality of care in your ICU. And these are the National Nosocomial Infection Surveillance, which keeps on publishing. Similarly, the INICC also keep on publishing the standards. Similarly, for antibiotic resistance, number of resistant isolates and divided by the number of isolate tested, it gives you the antibiotic resistant. Antibiotic consumption, you can see in your hospital the defined daily dose per 1,000 patient days, DD of specific agent use divided by the total number of patient days. And you can plot it. It can give you an idea. If you plot over a month, if your antibiotic consumption is going down, that means the infection rate is also going down. Similarly, for hand hygiene, that's another quality indicator that how much is the compliance in your ICU if you have been monitoring from 1 month to like in this you see from Jan to June. Cost of care, you can know by the length of stay. If the length of stay, average length of stay is higher in your ICU, probably you are not shifting your patient early and they're staying in your ICU for a longer time. then you should also the family satisfaction. And for that, you can give a feedback form and nurses communication, cleanliness, noise, class 4 workers. You can take these feedback from the patient and know the quality of care from the patient side and try to improve in future. Glycemic control, the important is the glycemic variability and outcome in critical ill. They have seen that as the glycemic variability is high in your ICU, the mortality rate would also be high. So this can also gives how you are controlling sugar in your ICU. Then nutritional audit, like when are you starting the enteral nutrition, number of patients on parental nutrition. So all this can also give you an idea. Similarly, the ICU readmission rate. If you are not readmitting in the ICU, that means you're keeping your patient longer. So how do you calculate number of readmitted patient divided by the number of patient managed in the ICU multiplied by 100. Similarly, the patient fall rate. This can give you that how much is the care, and you can display in your ICU so that you know that the graph is going down. Similarly, the medication error, number of error divided by number of bed days multiplied by 1000. This gives you the medication error. Adverse events plus error rate, number of error divided by number of bed days into 1000 gives you the adverse event of the error rate. Middle stick injury rate is another quality indicator which can be monitored to know the how much is the improvement. Reintubation rate also is one of the parameters. And does it make difference? So this was a paper published from Calcutta only, impact of quality improvement processes on healthcare associated infection. And as you can see, by implementing this, they could show that from the June 5-6 to January, September 9, there was a decrease in the infection rate. So if you apply these, monitor these, and apply the bundles, apply the methods to improve upon, and you monitor them, that the quality indicators are improving, and it has been associated with decrease in the infection rate. So elements of the right care at the right time do no harm, and you satisfy the customers. So best performing ICUs are the structure and the processes, and the outcome will differ based on the structure and processes. So these are the three pillars. You have to provide good structure, you have to have a good processes, monitor them so that you can know that the outcome is varying. Do your processes correctly and good outcome will follow. Quality improvement through audit should be a religion in the ICU. Thank you very much.
Thank you, Dr. Chawla, for excellent presentations, and probably he has covered all the areas of quality control, and that has been also published in our journal, and he has included that hand hygiene. Probably that was not in our journal really. So this is very important, that audit of compliance with hand hygiene in every ITU or ICCU, and it should be depicted in the chart form. And I think we have got restraints of time, so I like to conclude these sessions. And thanks, Dr. Asif, as well, for organizing this kind of conference.
Thank you, sir. Thank you all.
Thank you.
Very wonderful session. We have to move next session. That is updates in management of chronic thromboembolic pulmonary hypertension. And this session will be moderated by Dr. Supriya Sarkar. Dr. Sarkar is a professor and HOD Department of Chest Medicine in Sagar Datta Medical College, Kolkata. And along with the panelist is Dr. Manos Saha, is a senior consultant interventional radiologist in Apollo Clinicals Hospital, and Dr. Bhavotosh Biswas, former Vice Chancellor of Medical Education in West Bengal Health, and also is a chairman of Pharmaceutical and Research West Bengal. And Dr. Subhasis Ghosh is a senior consultant pulmonologist in Apollo Clinicals Hospital, and Dr. Surabhi Jajoria is a senior consultant interventional radiologist in Apollo Clinicals Hospital. Sir, please start the session. We are running very late of time.
I should thank the Apollo Hospital for giving me opportunity to moderate a very important session on the chronic thromboembolic pulmonary embolism, pulmonary hypertension, and there are very honored and good panelists. Dr. Manas Saha is an interventional radiologist. Dr. Bhavatos Biswas, I am honored to have him. He's a well-known cardiothoracic surgeon. Dr. Subhashish Ghosh, well-known pulmonologist, and Dr. Surabhi Jojodia, she is also an interventional pulmonologist. Sometimes I wonder that the pulmonary circulation receiving same amount of blood as the systemic circulation, but have a very low pressure. And this is because of the more fibrous tissue, elastic tissue, and less muscle fibers in the pulmonary circulation. And the pulmonary muscular layer is so thin that even all the muscles constrict, it is not sufficient to cause pulmonary hypertension. So a chronic insult is required, and that causes modification or remodeling of the pulmonary vasculatures, probably except acute pulmonary thromboembolism. So my first question is to Dr. Subhashish Ghosh. What is chronic pulmonary thromboembolic pulmonary hypertension, and what is its relation with acute pulmonary thromboembolism?
Right, Dr. Ghosh. Thank you very much. Chronic thromboembolic pulmonary hypertension belongs to class 4 of pulmonary hypertension and is due to pulmonary embolus in previously. Now, if you look at the statistics, around 5% of those who have had a PE or pulmonary embolism go on to develop pulmonary thromboembolism, chronic pulmonary thromboembolism. And around 40%, 30 to 40% of those who have chronic thromboembolic pulmonary hypertension do not give a history of PE. So it's silent. So those who have a history of PE, not all, only 5%, but that's quite a number, because if you consider all the PE patients who go on to develop CTPEH, and out of that, that you can you suspect if you continue to treat them with anticoagulants for 3 months, and then after 3 months, they continue to have symptoms, breathlessness, and if you do an echo and you find their pulmonary pressure, mean PAP, pulmonary artery pressure is more than 25, more than 30, even after 3 months of rigid anticoagulation and diuretics in certain cases, but usually anticoagulation, then you suspect. But you also should suspect all patients who come in with breathlessness, and those who have pulmonary hypertension and breathlessness of unexplained nature, you should suspect pulmonary CTPEH also.
There is a term, the recurrent pulmonary embolism. Is there any relation with this?
Yeah, the recurrent pulmonary embolism makes it much more likely that they will develop chronic thromboembolic pulmonary hypertension because of 2 reasons. Now, the thrombus burden is more, and number 3, they are usually on non-provoked pulmonary embolism, which is a risk factor of chronic thromboembolic pulmonary hypertension.
So my question is, Dr. Biswas, sir, is the inferior vena cava filter will help you in the management or what you are recommending regarding inferior vena cava filter?
In fact, that's a nice question. The intravenocal filter was used extensively several years back. Currently, its use is controversial. It may help or may not help. Sometimes it's thought to invite more complications. So, what is the bottom line? We have to establish the indication of pulmonary thromboembolism and pulmonary. We have to evaluate properly pulmonary arterial hypertension with cause, with other relevant information what we need. an aggressive medical treatment to keep the INR within a limit and to discuss the issues which may take the patient to surgery. Role of intravenous filter is not well accepted. It is controversial. It may be beneficial sometimes, it may not be beneficial, but treatment is medical as well as surgical. Role of intervention as a primary treatment of chronic pulmonary thromboembolism is not
Yes, sir, I
well
will come to
established, not
that
well.
later on. My question about the diagnosis, most of the patients have non-specific symptoms, and the physicians usually do a chest X-ray, ECG, echocardiography, and sometimes CT scan, and the CT scan sometimes they do, and lung function also. Lung function is not specific, may show some restrictive pattern, DLC will be reduced, and the ECG is non-specific. So my question to Dr. Shah, by seeing X-ray and CT thorax, how can we suspect that this may be a case of chronic thromboembolic pulmonary hypertension?
The X-rays we are nowadays looking not that informative in chronic cases, but if you look carefully, may get some signs like cutoff of the vessels. Some vessels are not seen. CTPA is the cornerstone of diagnosis, and see why we are discussing chronic pulmonary thromboembolism. Out of all the cases of pulmonary hypertension, chronic pulmonary thromboembolism is the only potential diagnosis which can be cured, potentially cured, right? So that is the importance, and that's why CTPA is one of the main cornerstone of diagnosis, where we can, if see the filling defects, thrombus, chronic thrombus, wave.
My question is by seeing, sir. My question is by seeing CT, plain CT, you can suspect.
Yeah, sure. Why? That's what I'm saying. Yes. You can have so many findings, like pulmonary hypertension itself is diagnosed by arterial diameter, which are enlarged, but in chronic pulmonary thromboembolism, you can see large filling defects, calcified defects, waves, post-stenotic dilatation, stenosis, peripheral pruning, old infarcts, all those signs you can see. And the increase in non-pulmonary circulation, like bronchial artery hypertrophy, those are, and then systemic circulation, some branches increases. Those are the signs, indirect signs, and these are direct signs.
My question to Dr. Jojodia, madam, that the VQ mismatch has a high sensitivity, so it has a 100% negative prediction value. How we are using VQ scan for the screening of this condition?
Thank you, sir,
whether it is possible in our setting?
Thank you, sir, for your question, and also thanks to Asif, sir, for involving me in this panel discussion. So yes, VQ scan is extremely sensitive as well as specific for picking up any sort of acute as well as chronic thromboembolism. And it shows you a VQ mismatch in the sense, even in areas with a good ventilation, we would see perfusion defects, which could be unilateral, bilateral, depending on the thrombus location. So it helps us in picking up the presence of chronic thromboembolism, but the negative aspect of VQ scan is that it does not give us an impression of the thrombus load, A, and secondly, it does not allow us to assess the anatomy of the thrombus. So for that, a CTPA, as Manasar correctly pointed out, is absolutely the cornerstone for diagnosis. And I think both of these investigations are equally important in making a diagnosis and planning further ahead.
My question to Dr. Shah again, how CT angio will be helpful, and what is the difference between CT angio and MR angio? Which one you will prefer?
Definitely, we will prefer CT angios, because MR angios with high contrast and all those still not well you see established, because you in CT and you take 3 phases, for the pulmonary arterial phase, bronchial arterial phase, and then venous phase. All are important for the diagnostic point of view. So, of course, we are very frequent with this CTPA and well established it is. So, our treatment planning is also depend on that. We can treat those pulmonary cases often. So CTPA is,
So my question is continue.
Yeah, please. Yeah, CTPA what we require and good CTPA is what we need always for the treatment diagnosis as well as treatment plan.
My question to Dr. Vishwa, surgery is the main part of treatment, and before surgery, we'll prefer the cardiac catheterization and invasive angiography.
Yes, before surgery, we must evaluate the person properly because this is very, very high risk surgery. Yes. Must be done nicely to get a good outcome. The disease we have to find out the status of clinical status of the patient, and we have to evaluate thoroughly, as we discussed already, that CT angio, then pulmonary angio, echo gives information. Overall idea is to evaluate the status of the heart, that is status of tricuspid regurgitation, then right ventricular function, and overall cardiac function and related parameters we have to evaluate nicely. And once these things have been established, we select the cases for surgery. And if we look at the parameters, the patients with PVR, very high PVR, greater than 300, are good candidates for pulmonary thromboembolism. And once you take the patient for surgery, there are a lot of challenges, pre-op, during-op, post-op, and the surgery has to be done on a cardiopulmonary bypass. And it is to do it nicely, it has to be done under total circulatory arrest and a very, very low temperature, high hypothermia, something between 18 to 20, we prefer to do it. Otherwise, what happens? The area becomes flooded. So, taking the cardiopulmonary parameters in a very right kind of setup, you can do it nicely, and whole pulmonary vascular tree has to be cleaned very nicely. The proper plane to be developed, the thromboembolic materials to be removed, and the pulmonary arterial pressure should come down. And post-op management should be very, very crucial. It may develop, several types of arrhythmia, hemorrhage, a lot of, untoward things may happen. But finally, what we want to tell you, the pre-op evaluation by all the modalities, including pulmonary angio and VQ scanning, that is very important. We have to evaluate thoroughly. We have to plan whether we'll be able to do it nicely. An on-table procedure is very important. The post-op is very important. And if you can do it nicely, outcome is very good. So more than 80% survival, 3 to 5 years on an average. That is very fine outcome. And these patients who are very sick clinically, they improve substantially. And once you have done this surgery successfully, patients are very effective and they have very active life.
Sir, you are recommending the surgery in the distal lesions also, or you are only accessible lesions you are doing this, the pulmonary endarterectomy?
No, that depends on our target is complete removal as much as possible. If we remove only from proximal part, this does not give you very long-standing outcome. So both the basic is both the pulmonary arteries, both right and left, they need to be evacuated. Then main pulmonary artery, branch pulmonary artery, segment and subsegment. Up to that area, clearance is mandatory, and it is not possible to clear everything every time. But outcome depends on clearance of pulmonary tree, starting from main up to subsegmental pulmonary arteries. If it has been cleared nicely, it depends on different stages of the disease and the clinical status of the patient. But target is clearance of pulmonary vascular tree as much as possible. If it is done nicely, and if you come out, patient gets a very good life.
Dr. Ghosh, what is the general management of this chronic thromboembolic pulmonary hypertension? Not the specific drug, general management.
Right, very nice question. The important thing I just wanted to highlight what Dr. Manush Shah said, that this is one group of pulmonary hypertension which is actually curable. If you do a pulmonary endarterectomy, you cure that patient. But 65% to 60% of these patients who've had chronic thromboembolic pulmonary hypertensions are only operable. Because they are very sick patients. So 30-35% are left inoperable because of several reasons, which Dr. Bhagavath Vishwas has said. It's a very tricky situation. And out of those who've had an operation, 1/3 develop pulmonary hypertension. They have a recurrent pulmonary hypertension. Even after, as you mentioned, the distal pulmonary vessels are difficult. They develop again pulmonary hypertension. So in this group of patients, those who develop recurrent pulmonary hypertension and those who cannot be operated, you have to treat them medically. And generally, it is the same treatment with diuretics if there is right ventricular failure, oxygenation therapy if there is hypoxia, but more than that, and anticoagulation, of course. Now there is a new group of drug which has come in, which is the stimulators, guanylate cyclase stimulator, which is Riosigua, which is FDA approved for this group of patients because this functions on the nitric oxide guanosine monophosphate pathway, which is totally hampered in pulmonary thromboembolism. And if you stimulate them, it causes vasodilatation and also has antifibrotic activity. So it just improves not only their physical activity. There was this CHEST-1 trial and CHEST-2 trial, which came out in 2013 in chronic thromboembolic pulmonary hypertension, where they looked at Riosigua, and they had wonderful results in those who were inoperable and those who had a recurrent PH, CTP, pulmonary hypertension after operation. So you can try Riosigua and up to 2.5 milligram 3 times a day. And this on CHEST-1 and CHEST-2 trial, which was a 1-year extended trial, the results were pretty good. Their functional capacity improved. Their 6-minute walk distance improved. Their pulmonary vascular resistance came down to below 200. So that's a good thing we can try. But the first and the only thing, the first choice of treatment is surgery, of course.
My question to Dr. Jodia, that balloon angioplasty, what is your opinion regarding balloon angioplasty in the management?
So percutaneous transluminal pulmonary balloon angioplasty is an entity which was established about 30 years back. And over the last 30 years, now theoretically what we say is that it has almost as good an effect as pulmonary endarterectomy in managing cases. In fact, the cases which are ineligible and ineligible for surgery and inoperable, some of those cases are even eligible for an interventional procedure. So in balloon angioplasty, what we do is we use gradually increasing size of balloons to dilate the stenosed part and to open out the pulmonary vasculature so as to improve the pulmonary circulation. So in short, this is what we do. And they say theoretically that the end results are nearly the same as a surgical intervention. But of course, a lot of trials more are needed to establish this. And perioperative mortality, of course, and the survival of a patient post-surgery has been already established to be very good. So the gold standard remains to be a surgery. But what they're saying is that with these newer developing techniques, we can get the patient to have an equally good life with a less invasive route of management.
Dr. Shah, what is your opinion regarding balloon angioplasty?
Now,
whether it can replace surgery?
Possibly in our settings, so definitely, because as Dr. Bhagavath Vishwas said, you could understand how difficult a surgery is pulmonary endarterectomy. In all the setups, it is not possible to do it and take the same result. Okay, where balloon angioplasty is relatively easier and safer method. Okay, and as we are moving in, we are doing more and more pulmonary interventions. We have documented acute pulmonary thromboembolism, which is with thrombectomy done and thrombolized, and patients survived without thrombolysis, actually, because post-surgery. Then we recently did pulmonary AVF. So we are frequently doing pulmonary interventions nowadays. And so on those track and doing a balloon angioplasty.
We are running shortage of time.
Yes, yes. Yes, my last question to Dr. Bishas. What about the lung transplantation? Whether it is possible? What is your opinion? When we should advise this?
Yes, this is a pertinent question. The subject what we have been discussing in the scenario or in the total horizon of this disease, a lung transplant is definitely a viable option. But lung transplant, whether it is feasible or not, there are a lot of issues regarding lung transplant. Not too many cases can be done. But in end-stage disease, where parameters are too bad, definitely it is an option if you can organize. If other parameters, you can get a donor, there are matching factors, there are mortality, a lot of underlying patient condition. It is definitely an option, but not very frequently feasible. And let me conclude by saying, it is such a disease. It's a combination of therapy, medical therapy, proper evaluation, adequate medical therapy, aggressive medical therapy. That is a fundamental basis of the treatment. Mostly anticoagulation. That has to be done very nicely. And in selected cases, balloon angioplasty, in selected surgery, sometimes hybrid. Combination of balloon angioplasty and surgery, but medical treatment is the mainstay of therapy. And certainly, lung transplant is a feasible option in very, very select group of patients.
So we have discussed many things, and many things has been left, and we think that discussion will help for the future generations.
Can I ask a question? If there is just 1 or 2 minutes time.
Oh yeah, that is not actually, if administrator permits, I can allow.
Okay, it's Dr.
Already we are
One quick
running
question.
late, and I should say, one question. Yes, madam asks.
Yeah, I'm Dr.
To whom?
Sharmili.
You are asking.
I'm an intensivist from Apollo Bhubaneswar. I was listening with great interest to the discussion. It was a very engaging discussion, and you're all eminent pulmonologists. One, just quick questions. Among all varieties of pulmonary hypertension, this is category 4, as you said. What is the percentage of this type of pulmonary hypertension among all cases of pulmonary hypertension that you have seen in your practice? Anyone can, please.
Can I answer that?
Yes, yes. Dr. Ghosh.
Yeah. This is the main problem with this is we don't diagnose chronic thromboembolic pulmonary hypertension. If it is diagnosed, it would be pretty not very uncommon at all. Say those who have had a PE is 5% will develop this, and those who have chronic thromboembolic pulmonary hypertension don't give a history of PE at all. So we miss 40% of those who've had a history of PE. And the only way is to get a perfusion scan for all these patients. If for all patients with pulmonary hypertension, I think this is more common than class 1. And probably the commonest cause of pulmonary hypertension is class 3 or the lung disease. And then you have this either class 4 or class 2, but it is not far beyond. And I think this is because we don't diagnose that often.
Because we see in the practice many times this pulmonary hypertension as an impediment to ventilator weaning. Thank you very much for answering this.
Madam, we have to end.
Thank you.
Thank you, sir, ma'am. And thank you, panelists.
We should conclude by thanking all panelists and also the organizer for giving me opportunity.
Thank you.
And thank you all my panelists.
Sir, we are really running shortage of time. Sorry for that. It is a very wonderful discussion. Thank you to all panelists. Our next session is the lecture that is a 10-based paper which changes our critical care practice. And with us, the eminent speaker, Dr. Srinivas Samabedam. He is the head of the Department of Critical Care and Medical Director of Brinchi Hospital, Hyderabad, and sir also our General Secretary ICCM. And the chairperson of this session is Dr. Amitabh Saha, is a Joint Director, Medical and Critical Care, Medicine and Critical Care Department in Medica Hospital, Medica Super Speciality Hospital, Kolkata. I will request Dr. Shambhidam, please, sir, you start your session. The dais is yours.
Good evening, friends. Are you able to see my screen? Asif, are you able to see my screen?
Yes, sir. Yes, sir.
Yes. Okay. Good evening, friends. And at the outset, I would like to express my gratitude to Asif and his team for giving me this opportunity. Now, the topic given to me is probably one of the toughest I've ever had, in my career. 10 best papers of the decade, right? And actually, when I saw the initial invite, I was shocked to see there was only 10 minutes allocated to this topic. And I wrote back to Asif saying, "Is it really true? You want me to complete in 10 minutes?" Then he said, "No, sir, you can take 20 minutes," which looked like a big concession to me at that point of time. Anyway, thank you very much, Asif, for giving me this challenge. I will try to justify the topic. Now, let's look at what makes a paper best, and this is my perspective. I mean, I'm not going by any evidence or anything. This is my perspective. A best paper is something obviously which will be well quoted because it's well accepted and well reviewed, so it's often quoted. And it changes your practice in the sense that what you would have done or what you have been doing, you tend to sit back, introspect, read what you have read, and then change your practice. There is a lot of background noise. So, but most importantly, any paper, any article, any study we read should be addressing an important clinical dilemma or an important clinical question and should trigger a paradigm change. It should be non-controversial, so it should not touch upon a topic which is a controversial topic. And if somebody else tries to replicate the results of this paper, the results which were obtained in this paper should exactly be replicated in the subsequent studies as well. This, in my perspective, is what makes a best paper. So I will try to put in front of you what I felt were some of the best papers in the last 10 years. Of course, I'm not going to talk about COVID-related papers because they have already been discussed so many times in the last 1 year, and I'm sure most of you are tired with listening to COVID. So let's look at the first one which caught my attention when I was reviewing the last decade's data. The one that is probably a very good one is about the neuromuscular blockers in early ARDS, the accuracy study, which answered an important clinical question that in patients with moderate to severe ARDS, does the early use of neuromuscular blocking agents improve the mortality? And this was a double-blinded, multi-center randomized controlled trial which evaluated the role of cisatracurium 15 milligrams bolus followed by an infusion for 48 hours, targeting to keep an acceptable or a more realistic SpO2 of 88 to 95% or a PaO2 of 55 to 80, which is probably more reasonable and practical target. They looked at an adjusted 90-day mortality as their primary outcome, which the authors found was significantly lower in the cisatracurium group with an adjusted hazard ratio of 0.68, which is a very reasonable, very good figure as far as the hazard ratios are concerned. And what's more important to note is the 2 points now. That is, there were more patients who did not receive neuromuscular blockade who had barotrauma and pneumothoracis. Most importantly, there were lesser non-pulmonary organ dysfunction in the intervention arm. And this what makes it a good paper from my perspective, because this probably in the current context, after 10 years, it explains the fact that the organ crosstalk that happens with inappropriate ventilator strategies and the uncontrolled breathing that happens can trigger acute kidney injury, can trigger hemodynamic compromise, can trigger a systemic inflammatory response, and this is what and this is what and this is what the Cisatracurium group did not have in the study done 10 years ago. So the learning points from the accuracy study is probably that the early use of a neuromuscular blocking agent in severe ARDS might improve an outcome, but the power of this study was much lower. So there may be some question for debate, and there was a higher than usual use of a PA catheter in this study. So these are the two caveats, but still the important questions were answered in this question. And I would probably feel that based on this paper, you would need a good reason not to use neuromuscular blockade in the early stages of severe ARDS. So this is one of the papers that came early in the decade. The next one that happened, that came and which caught my attention, which probably answered another important question, is a trial of intracranial pressure monitoring in traumatic brain injury. Invasive intracranial pressure monitoring with an EVD is standard of care, and you feel that unless you have an ICP monitoring with an EVD or any other invasive device, probably you're not delivering standard of care, especially in resource-limited countries like ours, where infection rates may be a concern which we need to address. So the clinical question in this paper was whether in patients with severe traumatic brain injury, does monitoring intracranial pressure improve the mortality and neurological function? And this was a randomized controlled trial with Latin American resource-limited settings. So they compared an ICP monitoring based treatment versus CT and clinical assessment based treatment, and looking at a composite of 21 components, including survival time, duration of neurological impairment and consciousness, neuropsychological status at 6 months, and none of these showed a significant difference whether you manage with an invasive ICP driven strategy or a clinical radiological assessment of intracranial pressure. And there was no significant difference in the mortality or the Glasgow outcome scales as well as secondary outcomes. However, what is more important is that those patients who did not have invasive monitoring tended to have more use of hypertonic saline, and hyperventilation was used more often in these patients who did not have invasive monitoring. On the other hand, those who had intracranial pressure monitoring had a higher use of barbiturate coma, but neither of these had an effect on the ultimate outcome in terms of mortality or the softer outcomes. So what we could have learned from this paper is that the management guided by ICP monitoring may not be superior to management guided by neurological examination and serial CT imaging in patients with severe traumatic injury in resource-limited settings. However, the study per se was not powered for mortality, and that's a fact we need to remember. But what is relevant for us is that this cohort is from a resource-limited setting, and it also showed that ICP monitoring is not as dangerous as some of us think it is. What I can conclude is that in units which do not have the infrastructure for safe ICP monitoring, management based on clinical and radiological assessment is not inferior, and you're not delivering substandard of care if you are not doing invasive ICP monitoring, if you do not have the infrastructure. It also means that those who are already into ICP monitoring need not change their practice. The third one in this series, which I felt we should be a part of this presentation, is the ProSeva study. I mean, this is about prone positioning in severe acute respiratory distress syndrome. This is not the first study that evaluated prone ventilation. There were several studies in the last 15-20 years which have studied prone ventilation. But what the ProSeva study did do is to give some temporal logistic answers to certain questions, like the early application of prone positioning in these patients and the duration of prone ventilation. This was an RCT where the outcome assessment was blinded, and it included adult patients with severe ARDS who were intubated and ventilated for less than 36 hours at the time of inclusion into the study. And the cohort of patients who were included in this study were prone for at least 16 consecutive hours, for as long as a month, 28 days, or until they improved. So this gave a picture or a number to the number of hours which you should actually ideally be proning your patients with severe ARDS. and they looked at all-cause mortality at 28 days as the primary outcome, which showed a significant advantage in those patients who are prone. And contrary to popular misconception, there was no increase in adverse events in the prone group. But this was a unit which was well used to, these were done in units which were well used to proning patients. So the learning points from the PRO-SEVA study were that patients with severe ARDS had improved mortality with early proning and prolonged sessions of proning. So these were the two answers which were standouts from this paper, and that's what makes it one of the best papers of the last decade. Then the selected group of patients were included with standardized ventilation and weaning strategies when the peak FiO2 table was used to titrate the settings. But the point to note is that the centers all had more than 5 years of experience with proning. Therefore, if a center is not experienced, I do not know whether we can extrapolate the results of this paper. But what we can say is that proning in severe ARDS reduces mortality without an increase in adverse outcomes. So once you have shown an adverse an improvement in mortality with a low-cost intervention which can be practiced everywhere, it makes it one of the best papers which we should consider. The other paper which is often quoted, which is discussed when you talk about traumatic brain injury, when you talk about sepsis and septic shock, is the Albios study. Albumin replacement in patients with severe sepsis and septic shock, published in the NEJM in 2014, which tried to answer the clinical question whether in adults with severe sepsis or septic shock, does 20% albumin solution with a crystalloid fluid compared to crystalloid alone reduce death within 28 days. This again was a multi-center randomized controlled trial in adult population who had at least one organ dysfunction, the background of systemic inflammatory response consequent to sepsis. And the patients got 300 ml of 20% albumin daily, and the target was to maintain a serum albumin at 30 grams per liter or more, that is 3 grams per deciliter or more. And this looked at mortality at 58 days as the primary outcome, which did not differ whether you used albumin or you used crystalloids alone. And neither was the mortality at 90 days any different between the two groups. So the addition of albumin to crystalloids during the first 28 days of treatment to maintain a serum albumin level of 30 grams is probably safe, but it does not confer any survival advantage over crystalloids. So if you look at the added cost of albumin, the cost effectiveness does not justify the end result what you achieve by using the costly intervention. The use of 20% albumin in adults with severe sepsis probably will improve hemodynamic indices as per this study, but it will not reduce the mortality. So overall, again, it's a null effect. There's no benefit from this intervention. Therefore, its use is, though safe, is not recommended for routine fluid resuscitation. And there is a popular belief among non-intensivists that you should try to keep the albumin up above 3 grams by giving exogenous albumin, and that myth has been busted by the Albios study. So that is why I have chosen this paper as one of the best papers of the last decade. A similar concept, whether the so much of hope and hype about buffered crystalloids, the commercially available buffered crystalloid solutions, and their benefit, or the so-called hypothesis of benefit in terms of reducing the prevalence or incidence of acute kidney injury in critically ill patients. So the study published in JAMA looked at whether the use of a balanced crystalloid solution compared to normal saline affect the incidence of acute kidney injury in the intensive care unit. This was again a double-blind RCT, and it was analyzed based on intention to treat analysis. So statistically a very strong method of analysis. But this study had a high proportion of post-elective surgery patients, and nearly 50% of the study group included those patients who had cardiac surgery. And the buffer crystalloid group, which used plasma light, and the saline group received similar volumes of fluid. So fluid overload or the imbalance is not a factor which probably would have influenced the outcome. And the primary outcome was there was no difference in the proportion of patients with AKI, which was diagnosed based on the rifle criteria within 90 days of enrollment. So the buffered crystalloids did not result in the hypothesis of a benefit in terms of reduced incidence of acute kidney injury. And there was no difference in the acute kidney injury patients receiving plasma light to 0.9% saline. The study, however, does provide reassurance that in elective or moderately sick intensive care patients, giving up to 2 liters of saline, 0.9% saline, did not result in an increased incidence of acute kidney injury. So this probably reduces the phobia we have developed for saline at least up to 2 liters a day in patients with post-operative and cardiac surgery. So that's why I chose this as one of the better papers of the last decade. One paper which I thought probably is a prophetic paper, that means it predicted what's going to happen in future, as we have seen last year, is the safety of the high flow nasal cannula, which we used extensively during the COVID pandemic last year. And the Florali study is the one which actually highlighted its efficacy, its and usefulness, and its comparative equivalence with non-invasive ventilation. So the Florali study looked at whether in patients with acute hypoxemic respiratory failure, does high flow oxygen given through a nasal cannula compared with standard oxygen delivery through a face mask or non-invasive positive pressure ventilation prevent intubation, which has been the target of several studies subsequently as well. This is again a multi-center open label RCT because you can't conceal the high flow cannula. And this was used in patients who are tachypneic, more than 25 breaths per minute, a PF ratio of less than 300, while breathing oxygen at a flow rate of more than 10 liters per minute for at least 15 minutes, and whose CO2 was less than 45. But one of the major exclusions was chronic respiratory failure. And they kept the gas flow at 50 liters per minute at an FiO2 of 1 and adjusted to maintain a saturation of about 92%, and applied at least for 2 consecutive calendar days. And there was no difference in the proportion of patients who required endotracheal intubation within 28 days after randomization, either to HFNC versus non-invasive ventilation, but the mortality favored the high-flow nasal cannula. It addresses a very important question whether high-flow nasal cannula is effective and can reduce mortality. However, the term acute lung injury is no longer valid, so that maybe some people, those who believe in semantics, might hold against the Florali study. And again, the non-pneumonia 80% or more of the cohort is pneumonia. So what happens to the non-pneumonia patients, we do not yet know from the Florali study. But what we do know is that the high flow oxygen via nasal cannula is not inferior to oxygen delivered by a high concentration mask or a non-invasive ventilation in reducing the subsequent need for intubation. And it probably reduces the ICU and the 90-day mortality. And also subjectively improves dyspnea and respiratory discomfort. So if you look at prospectively what happened during the COVID pandemic, this is probably one of the best papers of the last decade. Another common problem we find in intensive care unit is for specialties like especially the surgeons asking for fresh red blood cell transfusion. They want the freshest blood that is available in the blood bank to be given to the patients. So this study questioned whether in critically ill patients requiring transfusion, does the transfusion of the freshest available red cells compared to standard care improve the mortality of these patients, which is again a double-blind RCT which used the freshest available blood and compared it against the oldest available blood, which is about 35 to 42 days depending on the country where it was done. But one important thing is all the products, whether the fresh blood or the older ones, were all leukodepleted. So while the platform is uniform, these are all leukodepleted products. So we don't know in non-leukodepleted whether the same analogy can apply. And they looked at death at 90 days as a primary outcome, and there was no difference between the fresh blood and the older blood groups at all. The analysis of patients who were much sicker, who had Apache 3, whose Apache 3 was a little higher than the median of 21.5%, and the 90-day mortality was significantly greater in the shorter term storage group. So the shorter, the fresher blood cell group had a higher mortality. So what we can learn from this paper is that there is no benefit gained from using the freshest blood available in the blood bank for transfusing critically ill patients. So we should not stretch a scarce resource. Conversely, it also confirms that there is no harm from using the oldest blood in the blood bank. Patients do as well if you use the oldest blood that is available in the blood bank as they would do if you use a fresh blood. So this logic of asking for the freshest blood probably can stop, and that's why this paper, from my perspective, qualifies as one of the best papers of the last decade. The other common question, common hypothesis or belief we have as intensivists is that we should initiate renal replacement therapy very early, and we believe that it improves mortality. So the question here is, in critically ill patients with acute kidney injury, does early initiation of renal replacement therapy reduce the mortality? And this was a multi-center randomized controlled trial with a 60-day follow-up. And the patients who were included were KIDIGO stage 3 and above. And the early renal replacement therapy was aimed to start within 6 hours of documentation of KIDIGO stage 3. And they looked at 60-day mortality, and there was no difference whether you started it at 6 hours or after 48 hours. But the early group reported a higher incidence of catheter-related infections. And if you believe that early initiation will make them less dependent on RRT subsequently, there was disappointment on that front as well. So the early group did not have freedom from RRT quicker than those in whom the dialysis was initiated later. So in critically ill patients with severe acute kidney injury, an early strategy compared with a delayed initiation showed no difference in mortality. But the problems with this study were it used intermittent RRT despite the patients requiring vasopressor therapy. And the later stage of initiation, that means you started using them at KIDIGO stage 3. So what happens if you had used CRRT early? What happens if you had done it at the early KIDIGO stage? Are questions yet to be answered. But in most resource-limited countries, CRRT is still not as freely available. So when the mode of RRT is intermittent, early RRT does not confer survival benefit while increasing the chances of infection and does not liberate patients earlier from renal replacement therapy. So this is one of my good papers which probably have changed my practice. Some hope from the vasopressor perspective has come from this study from Ashish Khanna and group about angiotensin II. The patients with respiratory shock. So does the addition of angiotensin II improve the blood pressure compared with norepinephrine or catecholamines? Again, this was a multi-center randomized controlled trial, and all patients who were requiring catecholamines of more than 0.2 mics per kg per minute were initiated on angiotensin II, only those with high output shock at 20 nanograms per kg per minute. And at hour 3, the number of patients in whom the MAP increased to 75 millimeters of mercury or more, or 10 millimeters more than the baseline, was higher as expected in the angiotensin II group. And the mean doses of the background vasopressors were consistently less in the angiotensin II group, and the all-cause mortality was also lower at 28 days in the angiotensin II group. So the bottom line is angiotensin II increases the blood pressure in patients with vasodilatory shock without an increase in adverse effect, but use in other types of shock is not established. So why is this a good paper? It gives us an alternative to catecholamines to think about. So probably angiotensin II is going to be in our market very soon. One of the last papers of this decade, Asif, I'll finish. I know you want to stop me, but I'll finish in 5 minutes. Another 2 minutes. Just give me 2 more minutes, Asif. Thank you. So the oxygen therapy. So do you need to have a liberal oxygen therapy or a conservative target? So the ICU ROCK study looked at mechanically ventilated patients and used a conservative oxygen versus usual oxygen therapy on ventilator-free days. This was again a multi-center RCT which and where assessment was blinded. And the lowest possible FiO2 was used to achieve an acceptable SiO2 of 91 to 96%. And there was no difference in the number of ventilator-free days from randomization at day 28. So a conservative oxygen strategy is a good strategy. It avoids hyperoxemia and it does not force you to use higher and higher FiO2. So the concept of conservative oxygen therapy is what makes this paper one of the best papers of the decade. So those were the 10 best which I thought made a difference to practice. There are others that made the cut, like the end of the expiratory occlusion test. The early parental nutrition did not make a difference. The therapeutic, the targeted temperature management at 33 degrees did not make a difference. The 1:1:1 was probably equal to 1:1:2, so the proper study was also one of the ones. Paul Marrick's HAT study about hydrocortisone, which was again subsequently proven to be ineffective. The hyperoxia again was addressed by the oxygen ICU study. The EOLIA study, which looked at extracorporeal membrane oxygenation and gave us equivocal results. And the last one, the FAR-LAB study. So these were some of the ones that made the cut. But the ones I described were the ones which actually made me think about my practice and change some of the paradigms which I used to use in my intensive care unit. Thank you very much for your attention, and thank you, Asif, for giving me this opportunity. Thank you very much.
Wonderful session. The next session is this is a very interesting topic. That is, does age and comorbidity determine ICU admission? Because we have a lot of controversy during the pandemic situation. Who will get bed in the ICU or not? So for this session, the moderator is Dr. Sharmili Sinha, is a senior consultant critical care medicine, Apollo Hospital, Bhubaneswar, and is also chairperson ICCM Bhubaneswar and EC member of Indian Society of Critical Care. I will request Dr. Sharmili to introduce other panel member and continue the session, and please be on time. I'm very sorry, but
Yeah, good evening, all, and I welcome all the panelists on all my colleagues. And thank you very much, Dr. Asif and your team for this opportunity. I'll start the session, right? So we have eminent panelists with us, Dr. Prasad Nasa from Dubai, Dr. Rahul Dev Sarkar will be unfortunately won't be able to join us today, and Dr. Sankha Sen from Siliguri, Dr. Hasina Jahan Lopa from Bangladesh, and Dr. Ramani from United States. So this session is on a topic which is of very much practical relevance, and it is not there is not much literature on this, and most of it is actually based on a clinical practice and ethics. This is a concept based on common sense, not much of science. That when there is a rise in the age and increase in the number of comorbid conditions, usually patients who get sick, they become sicker, and there is increased probability or chances of those patients getting admitted to intensive care unit, and as such their outcome in terms of mortality and morbidity, if you count it as length of stay in the ICU or in the hospital, dependence on the ventilator, vasopressor days, and total length of stay, mortality, everything gets worse with increasing age and increase in the number of comorbid conditions. So my first question will be to Dr. Prashant. Dr. Prashant is actually a senior consultant in critical care in NHS Super Specialty Hospital in Dubai. So Dr. Prashant, are you with us?
Yeah, thank you, Dr. Sinha. I'm there.
Yeah, welcome. So my question to you will be like, what in your practice and an opinion, what is the correlation between the patient's admission to ICU and the age as such, both in general and in such as such in COVID situations?
Thank you, Dr. Sinha. And out the starting only, I would like to thank Dr. Asif also to invite us over here and to discuss. This is very much important because especially in a such scenario which we have faced, in twice or thrice in last 2020. So before that, these questions may have been discussed in more on a public health setting, but now because of COVID scenario, things have just on the how to optimize the resources and how to decide which one should get a ICU bed, because that's what we faced in last 1 year. When we talk about age, this has been proven into terms of last 2-3 decades, and in fact, one of our well-cited paper in Journal of Intensive Care Medicine in 2012, where we did a study in my last hospital in India, there was a direct correlation between the age and the ICU mortality. The subgroup of patients were sepsis and septic shock. We found that age above 60 is a independent predictor of mortality, and definitely age above 80 has almost 60 to 70% of mortality if they are admitted to the ICU. The major independent risk factors among the age were the requirement of invasive mechanical ventilation and severity of illness at the admission. But over the period of last decade or so, this has been debated, especially in terms of Europe, where the aging population is much more, and it's I think a worldwide phenomena. The aging population is increasing. So just by looking at an absolute number to decide whether the person needs an ICU admission or not is something which has been debated, and there is no consensus among the intensive care colleagues and other colleagues. So these frailty index have been devised, or they are also known as clinical frailty scores, which has come in last decade or so. And what exactly frailty index is calculating, it's not just on the number of years a person has already been passed on earth. It's basically a physiological and cognitive reserve. So where you actually take account of the cognitive part of the elderly population, whether they have a tendency to fall and other those things, plus their physiological age, which is accounted by a number, and along with that, the number of comorbidities. So you calculate a frailty index for that particular person, and you'd see whether that person needs an ICU admission and what will be the more importantly, the outcome. And frailty index per se or CFS score has been independently predicting mortality much better than an absolute number of age. What also we found in these studies was this actually can predict the outcome after 6 months. What has been found is, you can survive them into a good ICU care, but what happens, they have still a very high mortality once they come out of the ICU back to the high dependency unit or to the other part of the hospital setup, or especially 6 months post their ICU discharge. So frailty index can independently predict that mortality also, especially 6 months or a year after discharge.
Yeah, thank you very much, Dr. Prashant. And this frailty index is not only utilized to determine or predict ICU admissions and its outcome, also in Australia and New Zealand, in the residential, in the community-based residential care centers, this index is also utilized to get admissions, because when the resources are limited, there has to be some filter criteria to decide admissions, be it in those kind of care centers or be it in the hospital or intensive care units. Now, keeping this background in mind, I would like to ask Dr. Hasina Jahan Lupa. She is an intensivist and in charge critical care at Samorita Medical College and Hospital in Dhaka, Bangladesh. So, Dr. Lupa, would you like to share with us what has been the trend in COVID-related ICU admissions and age in your center in the last in the last year COVID pandemic times?
Good evening. Thank you very much, Dr. Sharmili, and thanks a lot to Dr. Asif Iqbal, who has invited me in such a prestigious platform. It's a great pleasure for me to be here. What I can say in perspective of Bangladesh, in my ICU, actually, we have run COVID ICU for last 5 months, but at that time, we have dealt with lots of COVID patients. But in my experience, I can say that from in age group like 50 to 65, this age group and the elderly patient with the severe illness, they had the most vulnerable condition, and the mortality rate was high. Below 50, they survived a lot, but most of the patients who are in like 60 to 65 with comorbidity, these patients had a very high mortality. But in our ICU, the priority of admission, whenever we saw that the patient is younger and he has comorbid condition, but that patient actually was reversible. But the patients who were elderly patient, but I think their gender was a important thing. I saw that male patients had mortality rate was high. Female patients, I don't know. In my ICU, male patients had a mortality rate was high, but female survived a lot, and their recovery rate was I can appreciate that recovery rate was very good. But age, we have collected a data actually in our ICU, and we saw that the age between the 55 to 65 had more mortality. So, but in our setup in Bangladesh, in government ICUs and in non-government ICUs, wherever they had dealt with lots of COVID patients, most of them shared that the above 60 had a mortality rate was high.
Right. So what your experience actually corroborates with what Dr. Prasant has just narrated. So
Yes.
it is age is just not a number based on which admission was not decided. So as I understand, it was the severity of the disease at this in the stage of the disease based on which the admission to intensive care unit was decided. And as
But
you have said that
another thing I want to add that most of the patients came to us in a very severe illness, with severe illness. But those patients who came earlier, those patient, elderly patient also survived. I saw above 60 also survived, but those came earlier to us. But with severe illness, those patients, I think only 6 to 8 patients survived who went to mechanical ventilation, and those patient was 55 to 58. Those patients recovered, but the patients who were more than above 60, they didn't survive actually.
yeah, so it's the severity of the disease rather than and the stage of presentation that determined their outcome in during the COVID pandemic, as you say.
Yes.
So my next question will be to Dr. Sankar Singh. He is an eminent physician and intensivist at Newtia Getwell Health Center in Siliguri, West Bengal. So Dr. Singh, in your practice, what are the comorbid conditions that you have seen that usually predict or are more often associated with admissions to ICU in general?
If it's in general also the same answer, the comorbid conditions, definitely along with age, the most important thing we get is who are having uncontrolled diabetes. Uncontrolled hyperglycemia in a diabetic patient is the most important comorbid condition, even in non-COVID setting. And during this COVID pandemic, definitely those patients whom we had to treat in a serious condition, we used to admit in ICU, admission was needed. Comorbid conditions got worse with COVID when they contracted COVID. So what is important with along with treatment, steroid usage and all, which is very important in this particular disease. But most importantly, comorbid conditions like diabetes is the most important thing in India, at least in our setup. And then those with diminished renal function like CKD patients, those who are immunocompromised, then they come along. But if you ask about numbers, I feel diabetes is the most common comorbid condition leading to ICU admission, and particularly in elderly patients.
Right. Along with diabetes, in our practice, actually, we also noted association with hypertension. Patient who had malignancies and other cardiovascular diseases actually also could not do well during the disease process, because when there was moderate to severe hypoxia, this compromised organ functions did not help either.
Sure. Same here.
Thank you. So my next question will be to Dr. Ramani. Dr. Ramani is with us, I believe. He is an eminent and senior infection disease specialist. He was formerly associated with CMC Vellore, Manipal Hospital, and currently he is at Albany, New York, as an infectious disease specialist. Dr. Ramani, are you with us?
Yes. Good evening. Can you hear me?
Yes, sir. Yes, sir. Welcome.
Okay, great. Thank you.
Yeah.
So, I mean, I have a very interesting part to play here, looking at unique pathogenicity of COVID-19. In
and
fact,
their association with and how it determined or associated in the elderly patients, especially determining their admissions to ICU and outcome.
Yes, that's actually one of the peculiar circumstance with COVID-19 is a defining feature of hospitalized COVID-19 elderly patients is the heterogeneity of their immune response. Overall, 3 types of immune response are defined in these patients: patients with robust activation and proliferation of CD4 cells, which is generally lower in elderly patients, and in those who end up with the ICU, patients with a CD8 T cell response and a less robust CD4 cell response that we see in HIV patients, and patients largely lacking detectable lymphocyte response to the infection. So this actually results in a very weak response. Other factors that are involved is the viral sepsis hypothesis, the cytokine storm that we heard about, which I'll talk a little bit about it, inflammation and thrombosis, which is a big issue with COVID-19, misfiring of the immune system, role of interferons, as well as immunogenetic aspects of COVID-19. In fact, we at Albany Medical College Hospital are working on genetic and immune factors in COVID-19, looking at what is the factors responsible. And also another concept is viral evasion from interferon control. So what happens with viral infections is that interferons play an important role in the innate and adaptive immune system in response. And during viral infections, they are able to recognize the receptors and induce production of interferon, which binds to these factors. So if this is lacking, then the response is not robust. When you look at cytokine storm, so what happens in cytokine storm is that there is ARDS, where pneumonia, sepsis leads to a release of pro-inflammatory cytokines by the immune cells, leading to severe lung damage. So in COVID-19 especially, the recruitment of ACE2 receptors by the virus causes disappearance of the angiotensin converting enzyme from the cell surface, resulting in increased unprocessed angiotensin 2, causing severe inflammatory response. And these are, by and large, worse in patients who end up in the ICU. Now, my thought was, when you talk about age, what is age? Age is just a number. But actually, like Dr. Prashant mentioned, it's not just a number. It's also, frailty index is probably a better way to look at it, not just pure age, because age by itself does not give us everything. What is the other comorbidities? Are they hypertensive, diabetic, obesity? So in America, just like in India, diabetes has been found to be a very major predictive factor in poor outcome. In the initial studies published in Monaldi archives from Italy, what they showed was that older patients ended up in the ICU more often, 73% versus 47 for those in the younger age group. So significantly important. When you look at pathogenicity, dyspnea, fever, syncope, all these are associated with the pathogenic responses I mentioned.
Yeah, thank you, Dr. Ramani, for those very important points. I'd just like to also understand from you, have you noted any specific primary and secondary infections in the elderly patients who get admitted to ICU?
Yeah.
In your practice?
Yeah. See, that's very, very, very. See, there are multiple things that are involved. If they are diabetic, if they have heart disease, atrial fibrillation, heart failure, the risk definitely increases. So the primary infection that we see are still the community-acquired pneumonia and the secondary pneumonia that you see in the hospital. If they're intubated, gram-negative pneumonias are more common. In India, I'm told that there are opportunistic infections that play a role, especially Aspergillus and others. But what we have seen here is no specific bacteria is involved, but we see a lot more of Pseudomonas and ESBL, E. coli, and Klebsiella in these patients.
So those are in the hospital setup. I think secondary infections you mentioned about, right?
Yes,
Thank you. So my next question will be to Dr. Prashant about what would you think is the specific reason of increased association of COVID-19 infections in patients who had uncontrolled diabetes?
Yeah, thank you, Dr. Sinha. Again, it's a very, very important question, and Dr. Ramani has beautifully described about the pathophysiology of COVID-19. how different immune pathways do take part in COVID-19. As we are understanding, it's human immune response which is causing much more problem per se rather than the virus. And diabetes mellitus is one such issue where there is already a documented modulated immune response. And with viral illness, this leads to a completely immune and inflammatory pathway which gets deranged. As Dr. Mania also described about different pathways like RAS pathway and the natural killer response or interferons, which get much more prominent in in the patients of diabetes. While there is already an insulin resistance, which is pre-existing in these patients, on top of it, presence of a RAS pathway and natural killer cells, which make it further, especially the interferon and interleukin-6, which make it further higher, the resistance and hyperglycemia. Along with that, there are the other cardiovascular morbidity and mortalities are added to patients with diabetes. So the risk of cardiovascular complications are high with COVID. And as we know now, it's not just a disease, it's much more a syndrome where it involves the multi-organ system. So the chances of thromboembolism, DIC, vascular endothelial damage, these are much more potentiated or exacerbated in patients with diabetes. And studies have found that it is one of the, among the other comorbidities, it is one of the independent risk factor for having a high mortality. And we also faced in UAE where diabetes is like, more of an epidemic. Before COVID, we had almost 1/3 of the population having diabetes as one of the risk factor. It is much more common in, local population of UAE, of Emiratis, where almost more than half of the population is having diabetes. So the risk factor to acquire illness, to acquire a severe illness, and to die from that particular illness is much, much higher in a patient with diabetes.
We can almost say in COVID pandemic, before COVID pandemic, also we had already an epidemic going off for diabetes mellitus. So I was actually trying to also highlight about the AC2 receptors. About those receptors, it has been very much talked about that there is increased expression of these receptors on patients who are diabetic already or patients who are on AC2 inhibitors. How often did you feel it is the patient, like patients who have been using AC2 inhibitors, for patients who have been hypertensive, had more association with COVID-19 infections? Dr. Lopa and Dr. Sen. For patients who are using AC2 inhibitors for their hypertension, did you feel really, I mean, there was a hypothesis was brought about this, and this theory was, again, it was refuted. They just said keep on using AC2 inhibitors. But in your practice, Dr. Sen and Dr. Lopa, did you feel, was there any association between increased incidence of COVID infections and hypertensive patients who are using AC2 inhibitors?
Initially, when this theory came up, I'm Dr. Shen speaking. Initially, when this theory
is muted.
Dr. Sharmili?
Okay, sorry, sir. So I just want to share this article, which was published by a group of authors from Middle East and Pakistan in June 2020. You can see the percentage of comorbid conditions among the patients who died with COVID during those pandemic times. You can see the highest number of patients in Italy who died had hypertension. Also, they had diabetes and cardiovascular disease. But in China, somehow the numbers are quite less. It's difficult to believe. I'm not sure about the genuineness of this report. But also again in United States, you see obesity is the highest commonest comorbid condition which was associated was found among people who died, followed by diabetes. I mean, they are closely competing. And then there is presence of renal disease as well.
Dr. Sharmili, that is what we see in America. Diabetes and obesity, you're right. Both these two are the top two killers.
Right.
In Bangladesh also. Dr. Sen, I would like to add here, I think Dr. Lopa, sorry, Dr. Lopa, sorry to interrupt you. Actually, that's what is very important. Diabetes, obesity, and with the second and third wave, now UA is almost into a second wave where we are, seeing for the first time almost 30% of the population, including females, which wasn't there. I don't remember. I had 2 patients of female on the first wave on ventilator. Now almost 30% of them are on ventilator, females. So I think that obesity is what has changed now, which we are seeing much more obese population, and BMI above 40 is quite common in my ICU who are going on ventilator.
So it's not age. So it is not age that, as you said rightly from the beginning, that it is not a number which decides or denies ICU admissions. It should be the relative factor, or all these much more important comorbid factors like obesity and diabetes mellitus. You see, this graph depicts among obese people, 68% people died, and second next was people who had liver, and then was the kidney disease. Of course, they have pre-existing organ dysfunction, but these population, I think they are the seemingly healthy kinds, but they have the worst curse of obesity, which leads to higher rates of mortality among these patients. So last and the most important aspect of this topic is about the ethical aspects. I think this topic made much more uproar in the last year when there were overwhelming number of cases started presenting to healthcare centers all across the globe, be it United States or Europe, Australia or India or other developing countries. And so many patients presented.
We have to
just few 3-4 questions and we'll quickly wind up. So this was an ethical challenge that actually we faced. So I'd just like to quickly hear from Dr. Prashant. What kind of price did you adopt to assign ICU admissions to patients who presented to ED?
Dr. Sinha, I think this is important to decide about a triage again on age. I again say the number is difficult to interpret. What we do in our hospital is we admit everyone who requires intensive care at the starting, then decide after 48 to 72 hours, decide the requirement of the invasive support further required, take into consideration of the end of life, which we have missed during the initial triage decision, if already a pre-existing end of life has been decided by the patient, because this is quite missed in an intensive care setting when the admissions are coming from, in surge, especially in COVID conditions. So to stop someone at the outset is difficult, but yes, to reevaluate that decision after 48 to 72 hours is what we have started doing and we are regularly doing in last, 6 months to a year.
Dr. Lopa, what was your practice?
Same here also. We don't refuse any patients actually. Whoever come to us, priority of admission is always younger patient, and those patients have a priority. But whoever, I don't know, in Asian countries like Bangladesh, India, the relatives of the patients, whoever wants to continue the treatment at the end of the life.
It is difficult to deny.
Yeah.
Right.
Yes, and there is emotional bonding, and we can't refuse. And I think that's a very important thing to us.
Yes, so define the borders. Very difficult. Right.
Yes, and I want to add one thing, that in this COVID situation, actually Bangladesh has improved a lot in critical care setting. Like now in every district level, also government is trying to set a ICU. So ICU bed and ventilations, ventilator setting, everything is increased in numbers. So patients are getting service, and in ethical practice, we are taking.
Thank you, Dr. Sen, your concluding comments on this.
Definitely, I agree with both of my panelists, because this age or the factors which was mentioned is not point to deny admission at this point of time. Probably this is being discussed because of this pandemic has showed us how much research crunch is there in this part of the world. And when there is when the beds are available and when the clinical severity of the patient needs admission, we should try not to avoid or deny any patient any admission on the basis of age only. When there is a crisis like which happened in certain European countries in the initial period when the COVID pandemic was new, at the beginning when there was bed availability was less, at that point of time, so even some developed countries, unlike those in India, Bangladesh, they have also tried to triage the patients, and there the age of the patient came into the factor, because those are having younger family and all these things who are at the end of life. Suppose at elderly persons, when the family members were in a,
We
they are
have to
living
move
in a
the
old age home and something, then they
we have
needed
to
to
move
be
the next
excluded.
question,
So in
please.
India, this was not the factor. Age was not
Yeah,
the factor to
thank you,
deny
Dr.
admission.
Sen. I think that you very much stated the Indian
Thank you,
scenarios,
panelists.
and I
Thank
think
you.
concludingly we agree that age is just a number. We have to see at the
Yeah.
functional status, that is the frailty index, and comorbid conditions. Again, it is the status of the disease and the severity and stage of the disease that has been deciding ICU admissions. But nevertheless, it definitely hints at a future course of action, that we need to have an end of care policy or a palliative care policy, especially in countries like India and other developing countries. Thank you
Thank
very
you
much
for
again, Dr.
panelists.
Asif.
Thank you. We
Thank you,
will
Dr.
move to
Asif, for the
next.
Thank you.
And thank you all the panelists for their contribution.
Way communication by using our WhatsApp video calling. So my first question to would go to Dr. Sudipta to know what exactly is virtual critical care and do we really need it? I'm sorry, I won't be switching on my video because I'm actually traveling because of the time issues. So the network will be a problem if I switch on my video.
So good evening, everybody. Thank you, Dr. Gunjan, for the question. Thank you, Dr. Asif, for inviting me. And now, as Dr. Gunjan mentioned, basically in our daily day practice, we are using some form of virtual critical care or critical care, depending on the requirement. Now, technically, when we say virtual critical care, that means with the help of resources, with the help of technology, we are providing our medical inputs in ICU from a from from a distant setting. When we are sitting outside the hospital, we are sitting outside the ICU with the help of technology. We are providing our medical input to manage our complex critical care scenarios. And it can be up to scenario when the hospital has a critical care facility, and but the intensive is not available 24/7. Then during the off hours, specifically in the evening hours or odd hours, when someone needs any medical input, he can communicate with the on-call intensivist and get his input regarding that. And another time, sometimes in a resource control setting, in a small hospital, when the appropriately trained intensivist is not available, and they seeking intensive care support in a certain number of patients or in a certain clinical scenario, where the intensivist may be sitting in another city or another state, and they are providing the medical support. we basically look into the two-directional audio-visual system. We can look at the patient's blood lab parameters. We can look at the vitals of the patient, also radiology and other clinical input, along with the contribution from the on-duty doctors. So that is theoretically the EICU or a virtual critical care is. As Dr. Gunjan mentioned, we are basically practicing it probably in a certain amount of our daily routine critical care inputs. And do we need it in India? Yes, it is a high time that we gradually develop it and make it more streamlined. COVID has shown that it has a good scope, and in certain scenario, it can significantly change the outcome, overall outcome. Now in India, because of the lack of number of trained intensivists, it is very difficult to provide appropriate intensive care services in every hospital and even in the small setups, small hospitals. Now, if we can provide any critical care support, then in a certain amount of patients, I think we can give our input and do better. Those patients may have a better outcome. And COVID probably is the best example. But the learning we have obtained from COVID, we can continue that in our future practice, and we can probably continue this service in future also for other specialties and other clinical conditions or other challenges.
So what I get from you is that tele-ICU or virtual critical care is highly technologically enabled care, and it is quite complex, wherein we have remote video visualization of the patients as well as the biomedical devices with their parameters and also access to medical records. And obviously it is quite complex and requires AV communication with telemetry, and many major things has to be arranged. So my next question is to Dr. Tanmay, sir. Sorry,
yes. Sorry, I'm not visible, but I'm audible.
So, you think that in India, as we have seen that many areas lack care, can we actually bridge this quality gap with the virtual critical care? And will the advantages actually supersede the costs which are involved?
Actually, how I see it is actually a second line of defense. You know, it's not the primary care for the patient. So it's a second line of defense. So basically, you have to have some qualified or trained manpower on the ground to actually do the procedures, see the patient and all that. And then someone from remote, doing a remote ICU care or remote ICU, virtual ICU can actually sort of oversee the situation and make a clinic. It is especially useful in hospitals where there is no small cities, small towns, and trained manpower on the ground to sort of make those decisions. And especially even in Western countries, they are using it in US and UK and other countries, like for night support for critical care, where the system works is in a way there is a nurse as well as a consultant who is actually remotely available and seeing all the vitals, reports, and all sort of attending emergency situations and giving advice online. Now, having said that, there is no randomized control trial cities and smaller towns, the cost is definitely lower there compared to bigger corporate hospitals. So in that sense, the cost probably, it is probably cost effective for the patient. Now, obviously there is some cost remote ICUs, all those technologies specialized. We don't need all very sort of intelligent, very highly developed softwares all the time, because we know that a lot of companies, they are promoting all those remote software AIC softwares. What I think and I believe is important is that obviously having a bedside, the patient, see the vitals, the monitors, resolution has to be reasonable, and getting all the other information online, which is probably not that expensive. People situation depending on where they're working and which they're attached to and what is the system there. For my hospital, if I think about, okay, in the night I can see my patients from home or give
premonitory signs and symptoms by which we can actually prevent the organ dysfunction. Maybe the mortality will not be like that type of significantly benefited, but definitely we can pick up acute kidney injury from developing. Maybe in the night time we can start fluid or start vasopressor, and in the morning time when the regular intensivist will come, he will definitely find it very useful. So in my opinion, maybe it will be not a very bad idea. It will be a good idea in Indian rural setups or in developing ICU that the resource is not that great. Definitely it will help, in my opinion.
That was very correctly said, that there are no studies in India, and probably in our setup we would probably benefit from having a 24/7 nocturnal tele-intensivist if around is there, and that is what actually we function as. We function as day intensivist in the ICU, and we function as a tele-intensivist in the night. So tele-ICU platform actually provides an overview of the ICU questions to optimize the clinical care and thus to assure quality. But there are some important factors which are needed for the success of a tele-ICU, and also there are many practical shortcomings that may be very specific to India. Dr. Brajendra, if you could highlight a few points on these.
Okay. Actually, India, this is the largest boom of our Indian population there. So it has been proved in SGPJ also in COVID pandemic. SGPJ, they took the initiative in August probably, and they went inside all the ICUs, most of the ICUs in UP, and they gave instructions to the ICU doctors in different corners of the UP. So that is one model for. So internet users, you see almost 71 crore are using now. And if we can have that infrastructure and utilize that, already we used in our setup also during COVID, that inside COVID ICU we can WhatsApp video calling and so
the intensivist number in India is very low, around less than 5,000. The ICU bed is almost 3 lakhs. So, and people identify actually doctors and the hospital. So if you a big corporate hospital and a big name in the critical care, they come into the discussion point and probably help in the periphery doctors or periphery ICU, and they have internet, and then the people can identify those doctors and taking a second opinion, taking a part in the management will be more benefited. So this is one. Shortcomings, maybe the traditional way we treat. We identify doctors with the patient. In fact, they go to the doctors first and then go to the ICU, and they expect all the doctors to be there in ICU and explain everything by that principal consultant only. So they may not identify any other doctors. That is probably traditional way of treating our patient, and that is the big shortcoming maybe in future, because people are not that much educated in medical things, and they will be expecting their doctor to explain everything and be the side of the patient most of the times. This is practical shortcomings, and I think if I cut short the main 2 points I have highlighted, and I can add any one probably. Thank you.
So for the practical important factors that we need for a success, I think nothing can replace a bedside nurse.
That's right, yeah.
A good bedside nurse, whether a virtual ICU or a regular ICU, a good bedside nurse who relays the red alert at the right time is important for any ICU to be successful. And of course, we always need a hands-on medical physician who can do the technical procedures on a virtual platform, definitely not do the procedures. These are two important factors that need to always be considered even when we set up a virtual ICU. As you know, with the COVID pandemic, health started to supporting patients virtually and in a secure manner. But still, there are issues with patient privacy. Dr. Tanmoy, can you highlight a little interference concerns that
thing comes to you where the actually if explain to the relatives, to the patient, and that's good for the patient, I think that is not going to be a major factor, a major sort of hindrance in developing sort of virtual ICU across. Legal aspects obviously are there. That is probably going to be taken care of.
by privacy issues, actually, there can be definitely some issues which can arise because of the unauthorized access that can be there of the patient. As you said, this will be more important when a ICU is actually set up with a very high distance, where people who are common users can also actually access this and can actually be
medical electronic system as well. So it's all being has to be encrypted and secured from the user point of view, end to end, so that it cannot go out anywhere else. Same happens with ICU notes also, because the thing is that whatever you have to store in hard disk, you have to share with the the center where whoever the company we are providing the backup for storing all the documents and all the sort of information. So that thing, that contract has to be sort of legally legitimate, legally valid, so that there is no issue with the privacy of patient.
This is a very important thing that we should always have in mind when we consider setting up a tele-ICU. So tele-ICU actually promotes evidence-based best practices and improves care and vigilance by a tele-intensivist available at a distance. But at the same time, there is also diffusion of responsibility and disruption of the traditional practices that we have. So we have usually till date being with our juniors being, we have always been kind of following protocol-based ICU care. And now we are coming to tele-ICU, where we will be round the clock. A senior tele-intensivist would be there to consult for the consultation. So now this question goes to Dr. Brajendra and Dr. Sudipta both. If you can share your opinion about what really would be the difference when you have protocol based ICU versus tele ICU, or how do you feel is it different managing a real time bedside patient versus virtual management of the patient?
Should I go first?
Yeah, please.
Okay. So I think rather than protocol-based ICU versus tele ICU, it have to be a combination, because even for a senior consultant or it is not feasible to be available round the clock or 24/7 on a teleconsult for teleconsultation. And also, as we are not able to touch the patient, so a gap of clinical assessment will be always there whenever we are managing a patient over uh, via tele ICU system. So eventually, you have to make a protocol and have to give a clear understanding of the steps of managing the critically ill patient. And along with that, when things are not going down along according to the plan, probably then you have to involve your consultant on tele ICU. Hello, am I audible?
Yeah, you are very much
audible. So when the things are not going according to the protocol, then probably you have to involve the tele ICU consultant to go to the plan B or plan C, or probably for a better correlation of the all findings like lab parameters, vital settings, and also from the radiology. So it cannot be one protocol based or versus tele ICU. It has to be a combination. And in terms of real-time bedside management and virtual management, there will be always a gap of clinical assessment. Though we, to some extent, moved away from our clinical judgment or assessing the patient from head to foot, but I don't think any investigation on any radiology, any lab parameters can replace that. So a good clinical assessment from head to foot is also a very important part of critical care, and that part will be missed in tele-ICU. But I think that's a compromise between the what facilities available at this moment or what we can do best for the patients out.
Dr. Rajendra, you want to add anything for it? Or are you around, Dr. Rajendra? Go ahead. So the expansion of this new care delivery model that has come up has outpaced the development, and however, there will be major legal and regulatory barriers which will be there. I want Dr. Tapas to highlight upon the legal issues that one can face while dealing in a virtual ICU or in a tele ICU.
The last question is really difficult one, because till now I also don't know the tele ICU, the proper legal issues, and I have not heard about the legal complications also. But yes, whatever the literature and whatever the personal experience, like we have to take consent for everything. Like the doctor who is also giving online consultation in the tele ICU also, he has to have professional licensing properly, because anything happens, then the family relatives, they have to also know that is the doctor is having proper qualification to advise over phone or over video. Second point, all the things like the EMR, the chest x-ray, the CT scan, everything has to be properly encrypted, and in case of there is any issue in the legal, then it has to be shared to the proper authorities. Third point, it has to be a sharing basis, like the on-site and the off-site doctor, they have to share the responsibilities. Like if the patient dies in the ICU in the on-site and the off-site doctor is not there, maybe the family relatives will try to meet the doctor who was advised over the phone, over the video, to do something, and they cannot find the doctor at the mid of the night. So there are so many gray areas which are there, which need to be discussed with the family relatives before taking the patient for the tele ICU consultation and adapting the tele ICU in your own hospital or ICU. And the Medicare reimbursement, which again a very gray area, we do not know if the patient dies and the family relatives claim, then they may have some problem that who is the doctor who has not signed over at the site. Maybe that will be another legal issue which can come. And everything, whatever you do, the medical errors can happen, because doctor is
India. So this is the time. This is to bridge this gap. We probably need virtual IPs today. But yes, we have a long way to go, understanding many legalities and many other issues, how to go into it. Though many companies are marketing it, I think this is the future that we want, and which will probably help us bridge the gap early. Thank you so much
Thank you.
for Dr. Asif and the organizing team. I hope this.
Thank you. Thank you.
Thank you. Thank you.
Thank you. Thank you.
Next session is this multi-system inflammatory syndrome for adult, and the speaker is Dr. Sushrut Bandyopadhyay. Sir is Director of Critical Care, AMRI Hospital, Salt Lake, and sir also is a ICCM faculty member for the college, and sir is a very renowned physician also in the Kolkata. So, and this session is chairperson is Dr. Dr. Deepankar Sarkar. He is a HOD critical care in Columbia Asia Hospital, Kolkata. Sir, you start your lecture. We have already late. Sorry, sir, for poor time management.
Hasn't put head in. Hello, am I audible?
Yes, yes, sir.
Yeah, sorry, it was muted. Anyway, thank you, Asif, for the kind introduction, and thanks again for inviting me as a faculty. You told me that I should finish my lectures in 12 minutes, and I'll try to do that in 12 minutes. So is my my presentation is visible? Yeah. So my topic today is multi-system inflammatory syndrome in adults, or this is also called an MIS. Can you mute the other mics? Right. Thank you. Basically, since last year March, a few cases were reported, mostly initially from UK. People started recognizing a syndrome of inflammation in children who had. So this was basically a post-infection inflammatory state. This syndrome was inflammatory syndrome similar to like we had a previously known inflammatory syndrome, Kawasaki's disease, and this new syndrome, post-COVID syndrome, bore some resemblance to the Kawasaki's disease. It had symptoms similar to Kawasaki's disease like fever, pain, abdomen, mucocutaneous lesions. However, it actually differed from Kawasaki's disease in the following aspects. It was the presentation age of presentation was older. Kawasaki usually occurs in children from maybe 6 months to 5 years. But this was in the median age of the children having this syndrome was around 10 years. There were cardiac complications like arrhythmias, myocarditis, and even shock, which was not there. Which was not found in Kawasaki's disease, and it had different racial distribution. Kawasaki's disease was common in the Asian people of Asian origin, but this was, I'll discuss this later, this was not common in people of Asian origin. So this people, then CDC actually requested people to report this sort of disease, and they set a format for this. And when people started reporting this sort of disease, people also became aware that there are some adults who presented with similar syndromes, which was a post-COVID scenario, and the people had an inflammatory syndrome. The reports from the 2020, and the patient had suffered infection something 21 days prior to the syndrome, development of the syndrome. The presenting symptoms were fever, definitely, along with cardiac symptoms, arrhythmias, shock, which may be cardiogenic, cardiogenic shock, and also sometimes distributive shock, poor ventricular in echo, both right and left ventricular functions. There was involvement of other systems too. For example, gastrointestinal symptoms like diarrhea, pain, abdomen, etc. But there were no pulmonary symptoms at all, or if pulmonary symptoms were there, they were very mild. This actually differentiated it from a prolonged or continuing a COVID hyperinflammatory syndrome. That is, patient having COVID and its complications. So it differentiated that the pulmonary symptoms were less, either absent or mild. The inflammatory markers and the markers for coagulopathy, like CRP, like IL-6, like D-dimer, all were raised, and so were the cardiac markers. I mean, the like troponin I, these were raised in these patients. And these patients actually they usually tested positive for IgG antibody. There are some variations, I'll discuss that, but generally they tested for IgG antibodies against COVID-19, which actually showed or which actually implied that they at least 2 weeks of 14 days of gap from their onset symptoms and development of this syndrome. So you can see, basically, we can take these three in a sort of spectrum. There was initially an inflammatory disease, purely inflammatory disease like Kawasaki's disease. On similar lines, we had a thing called this multi-system inflammatory syndrome in children. And then now we have got an acute COVID-19 cardiovascular system, or MIS-A adult. So the common, rather the fulcrum in all these three syndromes was the fever, elevated inflammatory markers. These were common to all three. Now, Kawasaki, there was definitely, it has no cause or trigger, and there was higher incidence in Asian children, young children, 5 months to 6 years. They were the most vulnerable people. 6 months to 5 years, sorry, were vulnerable. And shock was rare, myocardial dysfunction was rare in COVID. But in this COVID in children, multi-system inflammatory syndrome in children, you can see there are older children, higher incidence of this people of African descent, and positive SARS-CoV IgG. This was the differentiating points. And then there was the adult multi-system organ syndrome, inflammatory syndrome. That is, this syndrome followed the pneumonia, and they were also positive for SARS-CoV, and onset 1 to 4 weeks influenza SARS-CoV infection. Cardiogenic shock was common in these patients, or bilateral dysfunction, or myocarditis in the form of arrhythmias. So you can see the spectrum. So that is whether they're related or not, whether they've got a similar genetic preponderance, similar pathway of activation, nobody knows. But we have seen that these syndromes are there, and they have got a some common string which attaches the three syndromes. There's been a proposed mechanism. People have been trying to find out with this patient. So the proposed mechanism, you can see three things possible. A non-COVID infection, where you can see this regulatory immune response is there. The T cells, they give a proper response. The development of immunity leads to rapid viral clearance and recovery by 2 weeks from the onset of SARS-CoV. Then there was a COVID-19 associated hyperinflammatory syndrome. This is basically the of the COVID-19. Is a failure of regulatory immune response. This is the antigen presenting cell which does not do its function well. So there is increase in this interferons, gamma, alpha, and beta. The macrophages are activated. There is a lot of inflammatory mediators like TNF, like IL-6, IL-7, IL-10, etc. Here, 2 or more organ systems are damaged due to excessive inflammation, and there is a huge rise in this inflammatory markers: CRP, ESR, fibrinogen, D-dimer, ferritin, LDH, IL-6, IL-7, then even GCSF. So this is macrophagic chemoreactive protein, monocyte inflammatory protein, TNF, and there is a drop in absolute lymphocyte counts. All these are presented there, and there is possibly an immune exhaustion, and the patient goes into a hyperinflammatory state. Mind it, these patients will have prominent pulmonary syndromes. It is a continuation of the COVID infection, and there is no gap in between, and they will have prominent pulmonary syndromes. And then we have our topic, that is the multi-system inflammatory syndrome, MIS children or adult, where there is an initial recovery. The regulatory system has functioned well, there is an initial recovery, and after that there is a pathogenic antibody response, causes activation of macrophages, increase the markers, and this syndrome, mostly with cardiac involvement, but also other systems, as I told you, including GI involvement. So this is the three proposed, and you can see the time duration. If the patient heals, they heal within first 2 weeks, and if the patients have this sort of syndrome, it will last for 3 to 4 weeks and sometimes longer. So we have a definition for this. How do we say that this patient is having an MIS-A? and illness in adults above 21 years age, which is so serious enough to require hospitalization mostly, with a positive test for current or previous. This is important that either the patient is having a current COVID or a previous COVID, SARS-CoV-2 infection within the last 12 weeks. The time frame is also very important. And severe extrapulmonary organ dysfunction. I told you these patients, they somehow differentiated from a lingering or complicated COVID in the sense that the pulmonary involvement is less. The patients are not very hypoxemic, not much changes in the X-rays. There are ground glands, but not showing, and in the absence of severe respiratory syndromes. So that is the definition. So all the things are important. Above 21 years age, there is an evidence of COVID present or past COVID infection. There is an inflammatory syndrome, which is mostly extrapulmonary, and the lung symptoms are either absent or if present, they're minimal. So if you have this, then you can mark the patient well that this patient is a patient of MIS-A. What is the incidence? I'm talking about so much. What are the incidence? Basically, it's not a very common thing. It's a rather rare phenomenon. Now that we have got an overwhelming pandemic, we are seeing these patients, but otherwise it would have been a very rare entity. The MIS children cases reported all over the world has been something around 440. When I mean, this is the say December data, so it was 440, and MIS is much rarer with just 40 patients reported. I think that was similar. I don't think it has changed much. The largest series of MIS-A patients were from 11 cases reported from a Paris hospital. The hospital till date had 1,190 COVID patients diagnosed. So amongst hospitalized patients, the incidence of this MIS-A is about 1%, I think. That is not a common thing. USA and UK. So there are some 16 patients. So how they present, almost all the patients had cardiac symptoms. 16 patients had cardiac symptoms, and almost all the patients had raised inflammation. So these are the hallmarks of this syndrome. Cardiac syndromes, as I told you, it can be chest pain, it could have been both brady and trachyarrhythmias, it could have been cardiac shock, dysfunction, left ventricular, right ventricular, both biventricular dysfunction. And then some about 12 patients, they had abdominal pain. Some 10 odd patients, they had fever. And there are some ground glass opacities in 8 patients and lymphopenia in about 8 patients. And this mucokidneous lesions, which is rarer. In children, it's more frequent, in adult rarer, only in 4 patients. So you can generally keep an idea. Basically, I've told you the diagnosis, other than the indirect evidence of some COVID infection somewhere in the plus 3 months and raised inflammatory markers, the diagnosis is mostly clinical, that you have a suspicion, you've got a typical picture, and then you tell this patient has got an MIS-A. Laboratory test, the CRP and definitely the ESR will be raised. There is raised D-dimer, raised IL-6, raised serum ferritin, raised cardiac markers like troponin, natriuretic peptide, etc. ECG again showed arrhythmia, as I've told you, both bradyarrhythmia and tachyarrhythmia, echo, LV, and or dysfunction. That's very important. This is not a typical feature of the children variety, but in adults you get this. 2 patients who underwent autopsy showed extensive endothelial damage. So the thing is that the outcome was generally good. Not many people died of this. They required support. I'll discuss that in the later. So this is intelligence. severe stroke, there is significant cardiac and giving a full critical care. Now I have told you, the spectrum of the disease, but the problem is it's a novelty, but it does not have any specific treatment. These patients have been treated. People had to do something. They've been treated. 2 of the patients they received immunoglobulin. Almost all the patients they received corticosteroid. The same dose as COVID dose. 2 patients again received tocilizumab. Some of the patients were very ill. They required ventilation, and sometimes one patient, I think, he also received a venoarterial ECMO as well as a severe cardiac shock. The mortality in both MIS-C and MIS-A have remained low. So that is what I've collected about this MIS-A. You can understand this is a novelty. I should not say novelty, it's a rare complication of COVID, but then you can find it with a huge number of COVID patients coming in. Right now, we have got a significant drop in the city or the country, thank God. But otherwise, when there is a lot of patients coming in, you should be looking out for 1 or 2 patients like this could be having a inflammatory syndrome. I told you the typical scenario would be the time frame, specific thing that the patient gets better after a COVID infection and then again become ill. Typically, the cardiac symptoms are significant in the fever, and you get the typical lab reports, and you get a good suspicion. There will be differential diagnosis, like you need to rule out late hospital-acquired infection, sepsis, a pure cardiac disease. So all this would be the differential diagnosis. And the treatment remains, you can use these things, corticosteroids, immunoglobulin, and tocilizumab, but the treatment mostly remains supportive. Hopefully, the patients will not die of them. The mortality has been low. But we know I've told you 40 patients across the world is not a big number. We still need to know a lot of the patients, not a lot of this syndrome. Thank you. I think that's all.
Thank you, sir. Thank you for enlightening this burning topic because after COVID, it is one of the most important topic. And thank you for participation. And this was the last lecture of the day. So thank you. And I will request Dr. Ashok Sengupta sir to conclude the session as a chairperson of this conference. Ashok sir, Dr. Sengupta, are you online?
He's muted, I think.
Ashok sir, your Dr. Sengupta. Hey, Dr. Sengupta. Dr. Sengupta, are you in?
Unmute. Start video.
Yes, sir.
I am in. Yes, I am in.
Yeah.
I am in.
Yes, sir. You just conclude the session because last lecture was Dr. Shushruth
Yes, thank you, Shushruth. It has been a wonderful day of discussion, updating, and whatnot. We have been very pleased to have a huge response from the audience, from different categories of doctors, postgraduate trainees everywhere. And we are now concluding the session. I would like to thank all participants, the speakers, the panelists, the students, the colleagues everywhere. And we are looking forward to tomorrow's session, which should be equally encouraging. Thank you.
I just share the information during the streaming. We have seen that the participant is more than 600, sir. All over India, the participant more than 600. That's audience.
That's great. Hope it will increase tomorrow even.
Great job done. That's very good.
Thank you, sir.
Thank you.
Thank you. We are closing.
Good night.
Thank you. Good night, sir.